Vamos a esperar unos cuantos minutos para iniciar la sesión, ¿ok? Muchas gracias. Muy buenos días. Good morning. Bonjour. Bon dia. Pido amablemente que todas.
I kindly ask you to please take your seats.
Es familiar la cosa.
Exactamente. Bueno, es un gran placer.
It is a
presentar a ustedes
great pleasure to
actualización.
bring to you the update of the monkeypox in the region of the Americas. For those of you who don't know me, my name is Ciro Ugarte, Director of the Health Emergencies Department, and who will be presenting, this is Dr. Marcos Espinal, Assistant Acting Director, Acting Assistant Director of the Pan American Health Organization, and he will be talking about the situation, but also priority issues for the different countries. So Marcos, please. Ciro, thank you very much. Good morning, everyone. It is a great pleasure to be with you today. This morning, this warm, welcoming morning. I will make a presentation that will try to include all the different elements that we've been working on with our countries and for the benefit of our countries from the Pan American Sanitary Bureau.
Okay. I was doing it the wrong way. So, tenemos traducción, ¿no?
We have interpretation, right? Good. The slides are in English, but I will be speaking Spanish. This way we share.
En el primer slide,
On slide 1, what we can see is that on July 23rd, the Emergency Committee of the IHR recommends to the Director General of the World Health Organization to declare the monkeypox outbreak as a public health emergency of international concern, so that the countries will be able to take immediate measures in order to contain the monkeypox outbreak.
es una enfermedad viral.
Monkeypox is a viral disease. You know that smallpox was eradicated in 1980, and then we see how some orthopox viruses have come up, and amongst these monkeypox, and some outbreaks were seen in the past, such as the one in 1970. There was an outbreak in the U.S. Back in that year. Well, it was in Congo, and then in 83 in the U.S. And we've had some outbreaks, some monkeypox outbreaks. However, and in other countries as well as the UK, it is until May, I believe, May of 2022, when we start seeing cases of monkeypox, essentially in men who have sex with men. So we started collecting the evidence, and that evidence leads to this declaration of a public health emergency of international concern.
Aquí tenemos la curva epidemiológica.
So here we have the global epidemiological curve. And as you can see, the two regions that have reported the largest number of cases, and it doesn't mean that this is a real incidence, because it is a disease, and maybe some cases do not go to see a physician. So Europe and the Americas, with most of the cases, as you can see, this curve is quite significant, because what does it tell us? That by week 32, 33, we started seeing a peak. This might be real, but We have to be careful because there could also be cases that have not been reported, cases that have not been found, but the curve tells us that perhaps we're seeing a peak starting that week. So it has been reported, as you can see, 165,000 and plus confirmed cases, and thanks to only 26 confirmed deaths, which is quite different from what we saw with COVID-19. The previous week, we saw 3,700 additional cases. But in recent weeks, after week 32, what we've seen is a trend to a drop. But we cannot say that we're winning because these viruses mutate. And we just had a very important article on the magazine Science, where it gives us the background of these viruses, and they speak of millions of years, and the possibility that at some point it could mutate and change. And the same thing with COVID. It is a completely different virus from COVID, and we're lucky that it is not transmitted through respiratory paths. And this is an epidemiological curve for the Americas, where we see 40,000 cases, slightly more, in 31 countries and territories. And we also see on this curve that the most impacted country is the US, followed by Brazil. Brazil is in green, also Mexico with a lot of cases. And so these are the countries with the largest number of cases in our region. But we also see in week 33 this trend to decrease. And we've seen week after week that the trend continues on a downslope. So once again, this is a promising sign, but it is also a sign so that we will continue on the lookout with open eyes and having good epidemiological surveillance, and to continue detecting and educating, because we can still not say that we've conquered this, but the signs are quite telling us that we say. And here we have a bit more detail on how the region of the Americas is doing. 24,000 cases in the US, 24,000 plus, Brazil with 7,000 plus, Peru, Colombia, Canada. And these are the countries that show the largest number of cases. And we're lucky enough that in other countries, we're not seeing that large number of cases. But once again, I repeat, maybe some have been impacted and they don't go to the doctor because it's very simple. They have a pustule, a scab, and they don't see it. And so they go to the doctor when the case is already more serious. But the map tells us that we have cases in 33 countries. I believe 33. How many? 34. No, 24. 24, 7 territories, 31 in total. And so in the region, we have 5 deaths: Cuba, Brazil, Ecuador, and the US. And also a very promising sign, because as the DG was saying yesterday during the reception, the Director General, in COVID, we had 8,000 deaths a week at some point in 2020. So it is an important signal telling us that this is a disease with a very low mortality level. The clinical characteristics of monkeypox in a sample of 12,000 cases is seen here to the right, the age group, and young men. Most of these are men who have sex with men, and this is very important. And that is why perhaps we could think of saying that the control of this disease will be a bit easier than the way we controlled COVID. Why? Because since this is a clearly determined group, but it is a group that when educated, they immediately pay attention. And the community and civil society and the LGBT community, LGBTQ plus community is quite active in educating the community, paying attention, and thus these preventive measures can be followed. Young men 20 to 29 years of age and 30 to 39 years of age, most of them. There are some 61% is HIV positive, and so this is a very well-defined community, and that is why the messages ought to be, as we say in English, targeted and working with that community. And we will see this later on. The organization immediately decided to engage all that community and civil society. The symptoms, you can see these fever, rash. It is not a headache. It is not the typical monkeypox that was observed in the past. It might be quite atypical that just one lesion. So we start defining the characteristics of this outbreak. And it is important that if we know that men are being impacted, 95% of the cases that we have are men. And most are men who have sex with men. And so there's a targeted population and some women. We have to bear in mind the fact that this is all part of natural history. We're not saying that there's an increase in women. We would have to see this later on in the future. We're just saying that there are cases in women, but luckily it is a lower share. So this is the strategy that we're using based on the preparedness and response strategy, WHO Strategic Preparedness and Response Plan of WHO. And the main goal is to stop transmission, human-to-human transmission, and minimize the possibility of zoonotic transmission of monkeypox. To interrupt the human-to-animal transmission, because it's been reported that there's some pets. I believe that there's a dog in this region to protect the vulnerable groups. And not only the contacts of our patients, but also workers in labs that deal with and manage the laboratory specimens. And then we have the pillars, the most important areas, engaging and protecting communities, clinical care, and infection prevention and control, collective intelligence, coordination, emergency coordination, and countermeasures and research. It is important because WHO right away designed or had its incident management system team. They immediately created this incident management system team. The translation into Spanish is a bit complicated for me, says Dr. Espinal. That is headed by the director under the regional emergency director, under the regional director, and there's an incident manager. Dr. Tamara Mancedo, please stand up so that people can see you. She's sitting up here, and you heard the director saying that the credit, she is assisted or helped by the states. So these are the staff, the members of the staff that are part of managing the corporate system team. It is not only personal in the emergencies department. All departments and technical entities of APAHO are represented here. We have people from the revolving fund, people from the immunizations group, people from the communicable diseases group. The deputy is also from that department. So it is teamwork. So here we have, and I will not go into the detail, but these are the same pillars or areas recommended by WHO. And I will refer to one of these. Very important to see risk communication. Why is risk communication so important? Well, it seems to me that it is important because what it enables us to do is to educate. It enables us to reach the communities, to focus. So as you can see here, we have guidelines that have been developed. We have communication materials, preventive measures on the stigma. It is very important not to stigmatize this disease. Ladies and gentlemen, it is very important not to lead to stigmas because we're all human beings. The director has its press briefing every 2 weeks where we participate, yours truly, and the emergencies director, as well as other colleagues. So what we're trying is to bring that message, to educate and to inform about what our countries are doing and the work we do with and for the countries. And something very important that I mentioned previously, the engagement. The engagement with the communities and with civil society. As you can see, 8 webinars in YouTube Live. The communications people know more about this than I do, but 25,000 views so far. People are interested. They want to receive information. So we're bringing the leaders of the communities, the LGBTQ plus I communities, I plus, and leaders of these communities of men who have sex with men to ensure that there will be good communication that flows and that they can become part of the response as well. Because there's no community that will pay attention if their leaders are not involved. And that is important for the leaders to be involved. We've published guidelines on additional gatherings and mass events because it's very important that we also report about avoiding these massive events where we can see an increase in the risk of transmission of monkeypox, the monkeypox virus. So trying to tie all the loose ends, as we say. Clinical care guidelines, differential suspicion and diagnosis, and support to national guidelines, and to provide training to health professionals. And as you can see, several webinars on clinical aspects on what ought to be done by our health workers. So this is a constant dialogue. And this does not end here. We will continue to have more webinars and more communication on this. Why? Because we not know it all with monkeypox. Unfortunately, it is a disease that has existed in Africa for several decades, and the international community did not pay attention to it. And it is quite shameful because we only have one vaccine, limited vaccine, and we don't have antivirals for a disease that has existed for so long. And so we have to think a little bit about that. So we go back to a déjà vu. Because if we go back to the 80s, the HIV epidemic, men who had sex with men in London, New York, Amsterdam, and immediate attention. But this was in Africa, and so did not receive good attention, poor attention. Infection control and prevention, virtual sessions, guidelines. And so this is a corporate work that we do where we have experts from all over the region, who are working day and night in order to provide the information required by our countries. We have to remember that there was no surveillance systems in the region of the Americas for monkeypox. And very quickly, we mobilized our actions. Surveillance guidelines have been updated. There are several updates, as you can see, May, June, August. We immediately activated things through the international health regulations, rapidly activated in order to share data for outbreak characterization. We have epi alerts, epidemiological alerts that have been issued, and we continue improving that surveillance, which is the most important thing in order to have a clear idea, clear understanding on how the epidemic is doing, and to know that this curve will continue to decrease, or there could be another peak soon. There was no diagnosis previously in the Americas. And so the organization, as you can see, quickly mobilized its actions. Our experts in virology, 20 countries that were trained in 3 work sessions, one in Fiocruz in Brazil, another one in Mexico, and I believe that there was another one in Jamaica.
Nuestros países inmediatamente.
And immediately our laboratory experts were mobilized, and all of the countries here, 41 countries and 20 territories, received the support with regard to at least the lab diagnostic of monkeypox. I'm not going to dwell on this, but we do recommend that our pets be tracked to find out whether they have confirmed cases as well. And this is important under a One Health issue, because this too has to be seen as what it is. It's a zoonotic disease, that is a disease of animal origin. And so on August 5th, the Director Council authorized Madam Director to continue to negotiate with suppliers for better access to the vaccine. Prior to that, the advisory group, the TAG, the Technical Advisory Group, recommended a number of recommendations on the basis of what came from their meeting. Some of them were priority. Their question of contacts of cases was absolutely key, and laboratory personnel handling these samples were also very much at the top of the vaccination rate. Nobody was talking about massive vaccination. This was absolutely not the case and is not the case. This is quite separate and different from the situation with COVID. But I am pleased to tell you that 14 countries have already signed the necessary documentation to have access to these vaccinations. This vaccine is very limited. It's a 3rd generation vaccine wherein there is no complete evidence as to its efficacy. There is some evidence, yes, but it is not the level of richness and of broadness in terms of facts that one generally has in other respects. And so there is a host of liabilities and indemnities that have to be considered. So we have 14 countries that have already stepped up, and the first shipment, matter of fact, is about to go off next week, 6th October, ladies and gentlemen. The first batch will, 3rd October, the speaker corrects himself. The first batch will arrive in Brazil, and we are already looking closely at how we can calendar the rest of the countries that are signatories to this agreement. Now, the antivirals for monkeypox is a more complicated issue. There is currently no evidence on safety and efficacy to recommend the use of antivirals for the management of monkeypox. There flat is none. And so what can we do? That's a very touchy and delicate fact. What we've got is at best ad hoc information for which one is grateful as it trickles in, but that's it. So there are a host of clinical trials that are being organized in the northern countries. And the only possibility of use here is for compassionate use or on the basis of the so-called MURI protocol, that is the monitored emergency use of unregistered and experimental interventions. That is the acronym MEURI. That's the framework. This had been approved for the monkeypox but not approved by the emergency use listing, the European Medical Agency, and by the UN. So again, this is the WHO recommendation for use under randomized controlled trial or monitored emergency use of unregistered and experimental interventions, for which the patients must give their specific consent. And in all of the 6 regions of WHO, its 6 frameworks, headquarters, there have been protocols established, and I think there are going to be some 6,000 vaccines that are going to come to the Americas for those countries that can have access to that MURI protocol. There is also an array of regulatory issues, as you well know. This is a region that has a host of regulatory bodies which have an opinion. And so the exchange of information with national bodies is going to be key. And by the way, not only with regard to the vaccines, but also with what we call the Teco-Vermont context. And we have certainly had webinars and spread information as best we could. But the important point here, ladies and gentlemen, is that you have to take a holistic view of this situation. Got to take a broad view of what we've got, because we are now haggling with a number of private pharmaceuticals. And so the rules of the game have got to be better defined. And that's what we're working on. There are protocols for clinical trials, randomized clinical as well. But all of this, you understand, goes to ethical issues, not just legal issues, but ethical issues, clinical issues, training issues. This isn't going to happen overnight. I want an antivirals and I want them tomorrow. Well, I'm afraid that's not how it works. Because again, these are situations, these are contexts that absolutely require a full debate. And it had been suggested that that there be a WHO contact with the country under the MURI protocol. These vaccines are authorized for regulatory authorities, and it is through the revolving fund that it is eligible, not through the strategic fund. But that again poses issues. It's a delicate issues. And there are negotiations with WHO in that regard. But let me end with a message. It is critical that we work together in a number of respects. First of all, we need to continue strengthening multi-sectoral coordination and to develop response plans to this monkeypox outbreak. The fact that the epidemiological curve is more encouraging doesn't mean we can call it a day. Not at all. We have to strengthen our epidemiological surveillance, including laboratory capacities to detect and monitor these cases and to break the stigma and the discrimination that has arisen. And let me say again, and I will say it constantly, there is no place in the health sector and in public health in particular, no place for stigma. We must also strengthen our, I say again, epidemiological surveillance, including the lab capacities to detect and monitor these cases and support informed decision-making. It's always hard to be sure of your data. And let me tell you that PAHO is with you step by step in trying to facilitate timely, accessible, and quality clinical care through the MURI protocol. And you've seen this after we met in August, and we hope that by October there will be vaccines in hand. But again, WHO is certainly still worrying about the liabilities and the many other legal niceties that cannot be disregarded. And so bottom line, we must certainly empower and engage affected groups. We have to remain engaged with community-based organizations, civil society networks, and particularly the MSM group, the men who have sex with men. Got to keep teaching, got to keep communicating and sharing information, because so long as we stand together, so long as we each contribute to this, we will end this outbreak. Thank you.
Muchas gracias, Marco.
Thank you very much, Marcos, for that presentation. Each time with the pause that was necessary to underscore the highlights. And among these, of course, is the response from the countries and epidemiological information that must be shared. We've got to work together on this. And one of the examples that Marcos pointed out as it is occurring within the system is the system that the director activated very, very quickly to make sure that all of our mechanisms were in play in order to reduce the impact on society, on our economy, on the political body of this new outbreak. I don't know whether any of you, ladies and gentlemen, might have questions or comments, but I offer the floor, should that be the case. Mexico has the floor. Thank you. Thank you. And thanks very much for that presentation. It's certainly very clear. This, it appears to be a very contained outbreak from what I'm hearing. And I think, however, that the emergency committee did not recommend that this be declared as a public health emergency at the international level. In point of fact, the committee specifically said that should not be the case. And certainly one of the freedoms that the Director General has at his or her disposal is to go ahead and do so. Now, this monkeypox epidemic comes in to the context of mental health epidemic here that has certainly complicated matters. And all it points to, we believe, is the absolute need to go forward with vaccinations no matter what happens. But that can't be the end of the story. In a case like this, precisely, that should not be the case, as you pointed out, and that is information that the organization itself, we believe, in Mexico, should be the case. And in fact, Undersecretary Lopez-Attel said so at the meeting of directing bodies when they last met. We think that overemphasis on vaccination in this case is not helpful. First of all, it isn't available for everyone. That's point one. Secondly, we have been working within a context that, let's face it, is difficult in a pandemic in which there are public health and mental health issues. So the diagnoses that we are working with here have, in light of the present medical view, been slightly mistaken. Instead of moving on the clinical side, we are moving, it would appear, even with affected people, immediately to the vaccination. You have, you're thirsty, you have some kind of an outbreak, some rash, but they haven't said, you know, I'm positive, so I'm not. So I don't do what I could do to contain that possibility based on clinical measures that might be advisable. And that narrative, we believe, from a social standpoint, from the standpoint of society at large, is something that has pretty much been generated by ourselves. Where the lab exam is the conclusive point, that is the wrong message. It should be the clinical analysis that should weigh the most. We are in an imperious need for vaccination, it would appear, and this is the first time I hear clearly that, in fact, that is not the case. It should be post-exposure. It's the first time I hear this, that the vaccination shouldn't be pre-exposure, but post-exposure. Well, that has to be made very, very clear, because that is not the normal issue. And when we generally see this kind of situation, we yet again come down on the fact that it is information first and foremost, communication with the communities that has to be first. But if we put the lab results, vaccination, and communication third in our order of priorities, I'm awfully sorry to say, but I think that is the wrong road to take, and it will certainly lead to perpetuating mistakes that will I believe, complicate the management of this problem, which is not an easy one. So far from minimizing the problem, I believe we are at a crossroads right now, and we are perhaps still in time to slow down on certain aspects and maybe consider others. The point also, we believe, is to know how much of this was circulating before this particular outbreak took place. How widespread was monkeypox? Isn't that a good question to ask? What communities were affected? What is an outbreak that absolutely needed and needs a specific lab result, or where are we exactly? Thank you so much. All those comments are very well received. Mexico, we've got 2 more interventions, one from Argentina, second from Chile. Thank you very much indeed. The presentation, we believe, has been extremely timely, and the question is certainly complex because the sensitivity of our society and the complexity of this is certainly daunting. I would echo Mexico in stating that communication from PAHO towards the countries has to be very carefully considered. It's important to be very clear as to the means of transmission, the gravity of the situation, and the epidemiological curve is very, very different from COVID. And part of the population pretty much thinks, oh, this is like COVID, because we are in that post-pandemic or in that pandemic mindset. But it is very important that we distinguish these situations. The profile that monkeypox offers from its international standpoint is very different from COVID. It's not an international health situation. We in Argentina have to have declared a sanitary emergency in order to move to certain other measures. And we get that the epidemiological data are just not there for us to move to that next step. So communications with countries that might have gone to certain labs, that is something we did in Argentina, because that, with the case of this past pandemic, is different. And we have a curve that is downward sloping in terms of the strategy that we immediately generated, decentralizing the input from the labs in timely fashion because of all of the lessons we learned during the pandemic. And so this will be extremely useful. We are frankly a little worried that we give this vaccine too much relevance and start underscoring the fact that there isn't sufficient numbers available, and also that the numbers that might need it don't warrant it either. Yet again, for all of those steps to be taken, there has to be the prior sine qua non condition of declaring an international emergency. So I think it's important to compare and contrast the situation and differentiate what we've been through to what this simply points out. And this supports everything that Mexico said. Thank you, Argentina. Chile has the floor. Thank you. I'd like to congratulate Marcos Espinal, the Assistant Director of the organization, for this excellent presentation and all of the a very clear and cogent presentation that he offered this morning. Now, we also believe that the general director, that the director herself had stepped up to assume this importance when the emergency committee did not have a very clear position on the matter and was not frankly in favor of that. She took it under her wing and carried through a very, very significant analysis by the Secretariat and looked at all of the necessary elements that, of course, had been looked at in COVID and took the decision she did. And in that regard, I think that's the road that needs to be followed as we move forward. When an emergency is declared, obviously the objective is to alert the international community that, hello, there's a problem. That's the number one purpose of declaring an emergency, surely. It's to make people aware. And for PAHO to have taken such a measure and have implemented the necessary management of this incident so that necessary surveillance of the event should take place, even without it having the same characteristics as, say, a COVID pandemic or an influenza pandemic, is something that can't just be taken for what it is. It needs to be looked at. This is not over. You need to keep strengthening the capacity of the health authorities in the countries in terms of isolating the cases, in terms of communicating the risks. Those are, we believe, the emphasis that have to be kept very much before us with regard to monkeypox. All of the points that were made by the two countries that spoke before me, Mexico and Argentina, said things that we agree with fully in Chile. And as was very clearly pointed out by the assistant director in the presentation, there are in the vaccines here issues that go to the public health management of these cases. And through public management, there can be adequate control, but the clinical issues that are being looked at, the clinical management of these points needs to be very closely tracked. And certainly there has to be security in terms of there not being transmission to members of the family or to one's close friends, as was pointed out in the communication. Traceability, here again, as always, is key. And the knowledge of the population of the fact that there is a health problem is important, but no stigma. I agree with you fully. Well, thanks very much. I'm now going to give the floor to Dr. Espinal, only with a very brief introduction with regard to the role of WHO here. The framework for emergency responses from WHO is rooted in a policy which is called, for good reason, no regrets policy. Because guess what? There have been decisions in the past and likely will be in the future that have generated that sense of possible regrets. But the worst thing you can do in certain circumstances is to do nothing. And so you have to look at the highest level of activation should it be necessary, and that is WHO that requires it, in which the countries have the authority to move. It's down to them. And here, Dr. Espinal will tell you more, but I wanted that brief introduction. Marcos, please go ahead. Thank you very much indeed, and I'm very grateful to the member countries that have taken the floor now to share their views. But I do just want to clarify that the Emergency Committee did not reach consensus. It did not recommend that it be declared, neither did it recommend that it should not be declared. There was a division. And in such circumstance, the director has the prerogative to make her own decision, as Mexico properly pointed out. But let's remember that when Ebola erupted in West Africa, there were very, very, very negative comments about the decision-making process and when decisions were taken. And so in this context, the director here at PAHO thought, when we're looking, and Science magazine said, this virus may mutate. Possibly not, but it may. And so when you're facing an uncertain situation and you're at that crossroads, it's a tough decision to take, but somebody has to take it. And in the juncture, the director felt that it was better to err on the side of caution. Now, the comment that was made with regard to COVID and our mental impression is, of course, true. COVID has changed everything. There were member countries that immediately jumped up and said, we want an answer and we want vaccines. And as the director said, we are here to share the facts. The decision is up to the countries. And that is why the directing council was, in fact, convened. And there were some 20 countries that decided, yes, they wanted access to the vaccine. But what the Secretariat did then was to draw up a calendar for what would be equitable distribution so that those 20 countries would have equitable access, so that the first lot wasn't sent, by way of example, for instance, to Brazil and everybody else was caught short. So we're not looking here at efficacy, but at the effectiveness of the vaccine in the real world, because there are secondary effects and so forth. So it's important, we believe, to put this in its proper context, in the context wherein we don't have all the facts. We just don't. There is an outbreak, but we don't know enough. We don't know what we would want to know. And so when a country has 7,000 or 8,000 cases and an LGBT community that is strong and that is vocal, you know what? Those people are the citizens of that country too. That's all I want to say. Thank you. Thank you, Marcos. And I greatly appreciate your presence, ladies and gentlemen, at this very early hour at an 8 a.m. meeting in our session. And we have great participation. Thank you all for being here. Let me just say that the technical committee that is coordinating this monkeypox response will continue to be here throughout the session. And so that if any one of you wish to look more in depth to questions like engagement, epidemiologic surveillance, diagnosis, vaccination, these people are available to you for further consultation. Thank you very much indeed.
Bom dia a todos. Very good morning to all. Buenos dias a todos. Bonjour. I hope you had a restful night. Espero que hayan tenido una noche tranquila. Que hayan gozado su descanso.
I hope that you all had a good evening. Please take your seats.
Para que podamos iniciar la mañana.
Please take your seats so that we can begin our work.
President, we have quorum.
Thank you, Monica. And any of you that don't know Monica knows that although we have Madam Director here, Monica is the one who really runs the show. So good morning, colleagues. First of all, let me thank both the United States and Madam Director and the Secretariat for hosting the reception last night. It was nice that Dr. Tedros was able to make it and had an opportunity to say a few words along you, Madam Director, alongside of you. And clearly there's a warm and personal relationship between the two of you, longstanding. And it was appreciated, I think, by all of us that that both of you were there. And thanks as well to, again, to our American colleagues for also hosting and saying a few words last night. We have a busy agenda today. We're going to start with item 2.3, then item 3.2, item 4.1, and item 4.2, and we hope to get through all of those in time for the coffee break. And the first item, we have item 2.3, the first report of the Working Party to study the application of Article 6.b of the Constitution of the Pan American Health Organization. And I'd like to yield the floor to the delegate of Costa Rica, the chair of the working group, to present the first report. Costa Rica, please.
Good morning, Mr. President, and thank you very much. The working group established to study the application of Article 6B of the Constitution of the Pan American Health Organization met on September 26 to examine the situation having to do with the collection of assessed contributions in view of what is established in 6B of the Constitution of PAHO, in keeping with suspension of voting rights of any member state that has, quote, arrears that excess the amount of the annual payment of quotas corresponding to 2 complete years, end of quote. The members of the working group are the delegates of Costa Rica, Paraguay, and St. Martin. The group is chaired by the delegate of Costa Rica. The working group will meet again today on the 27th of September to continue its work and will present a summary of its deliberations in a second report to the conference during this afternoon's meeting. Thank you very much, Mr. Chairman, Mr. President.
Gracias, Costa Rica. Are there any objections to this report? Comments or questions? Seeing none, I'd like to declare the report approved. We'll now move on to item 3.2. And by the way, for anybody that wonders why we keep jumping 2.3 to 3.2 to 4.1, and we go back to 3.1, there is a logic to that madness. I'm not quite clear myself what it is, but it is logical. So item 3.2, reports of the Pan American Sanitary Bureau, Health in the Americas. Document CSP 30/3. Health in the Americas. I'd like to bring that to your attention and invite Dr. Sebastian Garcia Saiso, the Director of the Department of Evidence and Intelligence for Action in Health of the Pan American Sanitary Bureau, to come to the head table, present the item. Dr. Garcia, floor is yours.
Señor Presidente,
Mr. President, Director Etienne, honorable ministers, delegates, representatives to this 30th Pan American Sanitary Conference. Colleagues, right from its origin, one of the most important functions of the Pan American Health Organization has been to gather, analyze, and exchange data, information, and knowledge. Since 1954, PAHO has worked with member states to systematize data, thus complying with the mandate of producing a periodical report. That is our banner publication, which, as you all know, is called Health in the Americas. Today, it is my pleasure to share with you a new edition of this report. It has important news to report, because this is a platform that is going to allow us to access up-to-date and quality data in real time with greater interoperability with other sources of data and information that are online. These changes are in keeping with our need to provide information and knowledge having to do with the most important issues in public health, and we will be able to do so in a more timely fashion. This is something that was made obvious by COVID-19, and it was at the core of the decision made in 2019 to turn Health in the Americas into a platform so that it could supply information by providing access to data, information, and knowledge on an ongoing basis. So this platform complies with that mandate and is part of the banner report in a time of digital interdependence, where we need access to critical data at the most appropriate time and in the best possible format. Now, this is related to COVID-19. It explores the most important trends in our region, and it analyzes and presents country profiles in a systematized fashion. It is automated, it is interconnected with different data sources, going from interagency indicators and direct sources in the countries. The 2022 edition is the second edition in a new format. This platform provides access to data and information published previously, along with a report on premature preventable mortality that was published in 2021. Just like the previous edition, Health in the Americas 2022 is based on the most recent data collected in the countries, the territories of the Americas, including interoperative platforms, and allows us to compare information across countries and across regions so that we can better understand the status of health in the Americas. Right now, everyone has the document, a document like this, and this document has a QR code. And I would call on you, please go to the platform. And while you're doing that, I wanted to show some of the most salient aspects with you. The 2022 edition focuses on COVID-19 and the implications of the pandemic for the health of the Americas and the health systems. It shows the impact of the pandemic in the region, the effect on the economies, societies, and also the challenges for the future. It provides an overview of the health situation in the region during a context of accelerated epidemiological spread. It also focuses on results in health and presents lessons learned and ways to improve the health of the population. It talks about the connection between COVID-19 and social, environmental determinants of health and the impact on health inequalities. The online report, Health in the Americas 2022, includes a dashboard, maps, interactive tools, other tools and resources, and its information architecture is programmed so as to allow for different types of analyses and an ongoing analytical update. Also, it looks at profiles of countries and territories following a standardized format with something like 80 health indicators and graphs that are based on FAO, WHO, and United Nations data. All of this has been validated previously with the countries, and the information has been standardized so as to be dealt with efficiently. The use of interagency data, as we have discussed with member states, allows us to have information with comparable data following the same methodology for all countries. And in that connection, you can aggregate to talk about the region. And you can also talk of individual countries or from a regional perspective. There are specific indicators that came from national sources, and also we received the vision from different countries. And also we have a platform of basic indicators publishing something like 200 indicators all the way to the most recent update for 2022 that will be published and made available to you today. And that is information provided by the countries. Allow me to conclude my remarks by emphasizing the importance of prioritizing actions that have to do with strengthening IT systems for health and data governance. Just having access to quality and real-time data, can we move towards agile updating mechanisms for information-based decision-making? I invite all of you to use this platform. It is a very relevant tool for the work that we all share to strengthen our region and to build more resilient information systems without leaving anyone behind. Thank you.
Dr. Garcia. So now we'll open the floor. Just a reminder to put up your placard if you wish to speak. That I believe there's the usual 3-minute time limit. But notwithstanding that, please do not speak too quickly so the interpreters can follow your comments. So the floor is open for delegates. I see Mexico. Mexico, please.
Thank you very much, Mr. President. And good morning, Director. Dr. Garcia Saiso, thank you for your presentation. Doing this in real time, right now, when you were speaking, to hear about what is being done in the Pan American Health Organization, to transition, to improve, to give us the most up-to-date information possible, and doing it with a QR code, the way you presented it, that is really fantastic. It seems to me that this is a transition. It's work that we have all done together, and it gives us quick access to information that's comparable across countries so that we can make joint decisions and know more about each other. So I just wanted to take the floor to congratulate you. Thank you. Thank you, Mexico.
Delegations wish to speak on this item? Okay, I don't think I see any. So Dr. Garcia, you want to respond to Mexico? And then I'll turn to you, Madam Director.
Simplemente
I just wanted to thank all of the countries for their participation in this exercise. It's an ongoing updating exercise, sharing data. And also I want to thank Mexico for his kind words. And please do continue to participate in these exercises because it does give us better data in the format that we need it. So I truly hope that this will be one more tool for all of us. And again, I wanted to emphasize that you can count on the Secretariat to support this work. It's work done by whole of organization, and it includes not only the technical areas, but also publications, all of the areas that have to do with information management within the organization. So thank you very much, and I hope that you enjoy using it.
Oh, yes. Stop. I was waiting on the president, sorry. So let me thank Mexico. I don't know if many of you are young, so and your association with PAHO is probably recent, but up to 2017, this was a hard copy document where we looked back 4 years, but the data was always 4 years late. And so we transformed this into a real-time platform where we are able to give you real-time information close to as real as possible and within a short period. We have found that this lends itself to member states having more accurate and timely information. And one of the things that we do is we gather information from various sources. So this is more a more complete picture of what is happening in the region. Of course, this has to be coupled with helping member states improve their own information systems. And that is one of the things that we are doing. So our information will always be kept as current as possible. I too would like to invite you to visit that platform and to see the breadth of information that is available here. Let me also thank Dr. Garcia and his team for the work that they've done. And we have been pushing and pushing, and they've been responding very well. So thank you for that leadership as well, Dr. Garcia. Sorry.
As everybody knows, QR codes are our new reality. When I first saw one, I thought it was a version of Minecraft, for those of you who played that. But my son told me, no, that's not the case, Dad. Very useful. I work for a minister who's preoccupied by data and how data should drive health decision-making. And he's absolutely right. But he also acknowledges, and I think we all do, that it's hard to measure behavior and attitudes, particularly when it comes to public health measures, and when to have them, when to stop them, how to influence how people behave and act. And I think a lot of lessons that we are learning through the pandemic have learned about how to influence behavior, supported by data, but knowing that it's not only data, it is other sort of ways that people make up their minds about what they're prepared to do or not to do and to comply with public health measures, how critical that is. So the whole behavioral science part of that where data needs to play an important role is quite important. So thank you again, Dr. Garcia, for your comments. The conference knows, as with every other thing, that we'll note these discussions in the final report. So, gracias, Anka. Okay, we're turning now to item 4.1, Program Budget of the Pan American Health Organization 22-23, proposed amendments. document CSP 30/6. And I'd like to invite Mr. Ronnie Meza to the Director of Department of Planning, Budget and Evaluation to come to the head table. Morning, Ronnie. I'd like to yield the floor to the President of the Executive Committee, who, as some of you know, also has another minor job of Minister of Health of Argentina, to report on this item. So, Madam President.
Thank you very much, President. This is agenda item 4.1, Program Budget of the Pan American Health Organization 2022-2023 Proposed Amendments. The Executive Committee was informed in June that several amendments were being proposed to the program budget for 2022-2023, following the approval by the 75th World Health Assembly of an increase in the WHO allocation to the Americas for base programs, and also a projected increase in the amount received for special programs, including outbreak and crisis response. The Executive Committee welcomed the expected increases in funding for the program budget 2022-23 and underscored the need to implement the increased funding effectively and efficiently and to strive to reduce operating costs and other expenses. The Bureau was encouraged to focus particular attention on strengthening action on non-communicable diseases and mental health, emergency preparedness, prevention and response, risk factors for communicable and non-communicable diseases, and access to health services. Given the historical shortfall in the receipt of the region's allocation from WHO, the Bureau was also urged to plan for potential gaps in funding and to put in place contingency measures to mitigate the risk that the expected level of funding might not be received. The Executive Committee adopted Resolution CE 170R9, recommending that the Pan American Sanitary Conference approve the proposed amendments to the PAHO program budget 2022-2023. Thank you very much, Mr. President. This concludes my report.
Gracias, Madam President. Ronnie, now over to you.
Thank you, Mr. President, Madam Director, honorable ministers, distinguished delegates to the conference, colleagues in health. It is indeed a pleasure to present to you a brief overview of the proposed amendments of the program budget of PAHO for 22-23. Consistent with our accountability Thank you. Let me proceed. Consistent with our accountability and transparency practices and collaboration member states, the Secretariat is pleased to present the proposed amendments to this program budget. Can you just to this program budget, which member states approved last September at the Directing Council. The increase represents a 28%, increasing the budget from a total of $650 million to $881.5 million, as outlined in the table below on this slide. There are two main drivers, as presented by the President of the Executive Committee, that resulted in the increases in the budget. The first one is the increase approved by member states in the base budget per the revised program budget of WHO approved by the Assembly in May this year, which resulted in $39.5 million additional budget space, and I want to underline budget space, to the region of the Americas, increasing the total allocation to the Americas from WHO from $252.6 million to $292.1 million. The regional budget of the Americas from WHO is an integral part of PAHO's budget, and therefore we need to incorporate such increases into the PAHO program budget. While the increase in the budget allocation to the Americas represents a more equitable distribution in the budget space, it is important to note that an increase in budget space will require additional efforts and collaboration to mobilize and finance this increased budget. Regarding the special programs, which I would like to highlight, this is a placeholder budget as we cannot plan for emergencies or events that occur during the biennium. The Secretariat takes the opportunity to present also an updated budget after analyzing the influx of funds and the continued demands for technical cooperation responding to the pandemic and other emergencies. Based on current funding and commitments, the total budget in this segment is projected to be over $200 million. I would like to caution here, however, that this budget is expected to increase should the pandemic continue to demand additional resources. Next slide, please. Previously. The table here presents how we translate the increases in WHO of the third 9.5 million to the Americas by a strategic priority to the PAHO program budget. As you will see in the document before you, in table 5, we present the specific increases by outcomes. And here on this table, we have summarized the areas of focus or thematic areas that will see an increase. For example, under Billion 1, universal health coverage in WHO translates to an opportunity to scale up and expand our work in strengthening health systems, addressing NCDs and mental health, and continuing with the elimination agenda of communicable diseases, which are all priorities identified by member states in the consultative process that we conducted last year. Under Billion 2, we'll continue to build on preparedness and prevention, areas that have not seen adequately funding over the last years, despite, of course, the increasing funding to the response aspects of emergencies. Under Billion 3, we see again the emphasis on determinants of health, health promotion, and addressing the risk factors of NCDs and communicable diseases. And under Pillar 4 of the WHO General Program of Work, we see again the importance of continue building on leadership, governance, accountability, and transparency, with a special allocation to the prevention and response to sexual exploitation and harassment, and continuing to build data and innovation with special emphasis on countries. While the programmatic structure of the PAHO's program budget doesn't change, we'd like to note again the opportunity that if these increases in budget translate into real funding, we will be able to continue to expand and scale up our work in these priority areas identified by member states. Last slide, please. I'd like to kindly ask the conference is invited to analyze the proposed amendments to the program budget and provide comments it deems pertinent, and to consider approving the proposed resolution in the annex. I thank you for your attention. I look forward to your comments.
Thank you, Ronnie. So, delegates, anyone wish to speak to this item? Raise your placard. Canada, please, followed by Bahamas.
Good morning. Canada would like to thank the Secretariat for providing an overview of the proposed amendments of PAHO program budget for 22-23. We recognize that COVID-19 has had unprecedented impacts globally and regionally, demanding the reassessment and reallocation of resources in order to respond. As such, Canada understands the impetus behind PAHO's proposed amendments to its program budget, including to both its base programs and special programs, and sees no major concerns with these amendments as presented, including the accompanying resolution. We are encouraged by PAHO's approach in allocating these additional funds across agreed outcomes, and the proposed amendments provide an opportunity for the organization to expand or scale up efforts in certain areas. Canada remains committed to ensuring that discussions on WHO's budget and decisions taken at WHO reflect regional priorities, and are also well translated into PAHO's work. While Canada has no concerns with the amendments, we would like to reiterate caution around proposed financing. The increase in WHO allocation to the region would now correspond to 43% of the PAHO budget for base programs. We are cautiously optimistic, but we also recognize that the WHO has historically struggled to dispense the full funds allocated to AMRO due to other pressures. Given this, we ask the organization to continue to be prudent and plan for potential gaps in funding in an effort to maintain sustainable program delivery. Regarding special programs, we acknowledge that the exceptional increase in funds has made it necessary for PAHO to increase the initial estimated budget to $202 million. Recognizing that this is considered a placeholder, we again urge the organization to have contingency measures in place to mitigate all potential risks. Thank you. Merci.
Thank you, Canada. So now Bahamas, followed by Paraguay.
Thank you, Mr. President. The Bahamas thanks the Secretariat for this report. We are especially pleased to note the amended program budget 2022-2023, reflecting a 28% increase in total budget over that approved in September 2021. The increase in WHO allocation to the Americas in base programs is well merited, and this bodes well for the improving health of our peoples. PAHO's impact also accrues irrefutable benefit for global health security, evidenced in the COVID-19 pandemic. Nonetheless, new and re-emerging public health threats superimposed on long-standing scourges of chronic diseases and their complex risk factor profiles are all required urgent attention. The $154 million and technical cooperation allocated for special programs, namely outbreak crisis and response and smart hospitals, is noted. While the region has weathered the COVID-19 storm and is now experiencing some reprieve, COVID-19 remains with us, requiring ongoing shifting and revisions of response to the evolving viral menace. The potential effects of climate change are now being realized globally. Health systems and services must be reinforced and resilient for withstanding ravages and onslaughts. This became evident for the Bahamas after its lived experience with Hurricane Dorian. Recovery is slow and costly. Nonetheless, our focus is toward building a stronger climate-resilient health system. The Bahamas is grateful to have received funding under the Special Program Area BWP 2022-2023 biennium, where OCR funding encompassed most of the budget. We note, however, PAHO must display ingenuity in attracting additional donor funds for accelerating progress on programmatic gaps in combating declining immunization coverage. This in particular has been exacerbated in the past 2 years by the COVID-19 singular focus. Upstream measures are required to minimize the detrimental outcomes of recurrent outbreaks of vaccine-preventable diseases within and across member states. These must receive required funding and technical support from PAHO. Finally, we note that the revised funding prioritization of outcomes are generally aligned with our country priorities. The Bahamas supports the resolution and urge PAHO's sustained holistic approach to the many public health threats. I thank you.
Thank you, Bahamas. Paraguay, followed by Argentina.
Thank you very much, Mr. President. Paraguay is grateful to the Secretariat's efforts to produce the timely report on the proposed amendments to the budget. The program budget of PAHO for the period 2022-2023, where there is a total increase of $193.5 million, which is a 28% increase compared to the budget approved by the Directing Council in September 2021 through Resolution R8. As stated in the document, the increase is due on the one hand to a review of the PAHO program budget 22-23, considering the basic programs, and on the other hand, the resources obtained by PAHO thus far, in addition to what was anticipated for this biennium for special programs. Considering the $39.5 million increase for basic programs due to the increased WHO allocation to the Regional Office of the Americas, let us point out that this is 7% of the total increase provided. This region is the one receiving the least increase from the organization because in absolute values it has been $40.2 million below what has been assigned to Europe. Furthermore, in addition to having these extra budget allocations, they do depend on a number of factors for their effective financing. It is therefore necessary to recall that the financing level for base programs in the region of the Americas for the 2022-23 biennium is the lowest, compared also to the previous biennium, which is a null advance. In addition, given the amendments of the outcome for the base programs as seen in Table 5, we can see the distribution of allocations in high and medium priority. Let us point out then that there are some intermediate priority notions with higher allocations than some of the high-level ones. So we'd like to understand in depth how this distribution was drawn up and what is the prioritization criterion used for this. Is it due to financing gaps in the outcomes? That is why this delegation expresses concern about the problem, because there is a mismatch between the WHO provided funds and the multiple needs in the region which have been identified. And likewise, we'd like to ask the Bureau to put in place the necessary and best mechanisms to achieve the best results, and that way achieve a more profitable and beneficial outcome for the member states. Thank you.
Thank you, Paraguay. Gracias. Argentina next, followed by Suriname.
Thank you, Mr. President. Argentina notes the document, including WHO allocation to the region of the Americas and the proposed amendments. We welcome the fact that the proposed revision of the WHO program budget implies a 28% increase for the Americas compared to the initial allocation for the biennium. Furthermore, we welcome the increase in total program budget of 28% and 36% more for the post-program 2021, which we hope will continue increasing. We're grateful for the presentation of the report and periodic reviews, which contribute to transparency, accountability, and collaboration with member states. Therefore, we support adoption of the proposed resolution contained in the annex. Thank you very much.
Gracias, Argentina. Suriname, followed by United States.
Thank you, Mr. President. The increase in funding for base programs assigned to the outcomes categorized as high and medium priorities may result in increased financial resources to strengthen technical cooperation in Suriname, as the country has identified many of these outcomes as high or medium priorities as well. These include universal health coverage, access to services for NCDs and mental health, response capacity for communicable diseases, and addressing preparedness and response to health emergencies, among others. These were also identified as priority objectives in the recently developed Country Cooperation Strategy for 2022 to 2025. Increased resources for technical cooperation will contribute to our country's goal of eliminating malaria by 2025, implementation of the HEARTS initiative, and strengthening capacity for responding to health emergencies and pandemics. The allocation of additional resources, however, is dependent on the level of implementation of current funds assigned to Suriname. Suriname, Mr. President, supports the proposed resolution. Thank you, Mr. President.
Thank you, Suriname, United States, followed by Mexico.
Thank you, Mr. President. The United States welcomes the report of the director indicating the increased funding from WHO for the region of the Americas and the anticipated influx of voluntary contributions for special programs. We support the approval of the amendments to the program budget and look forward to receiving information at the end of the biennium, confirming the results and accomplishments that PAHO was able to achieve with the additional funding. Thank you.
Thanks, United States, and I'm impressed that you could read that from an iPhone. Mexico, please.
Thank you very much, President. The Mexican delegation notes the presentation by the Secretariat of these proposed amendments for PAHO budget program for the biennium 2022-23. Mexico understands that PAHO prepared its proposal based on existing requirements and available resources at the time, and given a global situational change, the amendments to the program budget corresponds to the programmatic links between the WHO and PAHO. So, looking for transparency and accountability, which are so characteristic of this organization, Mexico wants the organization to continue working based on the outcomes and outputs determined by the organization, given the existing gaps. With the increase of the global resources, the emphasis of the increase obviously has to focus on outbreaks and crisis, but as being an exogenous process after the planning discussions, it would be sufficient to talk about the change of situation based on the prioritization that had already been done and without changing it. And according to these ideas, as in Article of 36.3, which governs the election of the director, we'd like to receive a report on the use of flexible funds where the director of PAHO is given notification of how to use resources from the flexible fund to finance the PAHO representation of the countries that benefited from the funds. As the flexible funds in the context of the integrated budget are used to finance the PAHO program budget and is assigned to countries based on the needs determined by member states in the organization's strategic plan 2020-2025, the Mexican delegation asked the Secretariat to report why these funds were used to finance the payment to the representatives, the PWRs, and that is a cost that is on the payroll of the organization, instead of being used to provide support to the technical programs that require the exceptional financial resources to respond to emerging or emergency health situations. Thank you very much.
Gracias, Mexico. I don't see any other placards up. So, Ronnie, if you could answer or comment on the interventions, please.
Thank you, Mr. President. And again, thank you to the delegations who have commended the efforts of the organization for your questions that allow us to clarify some of the key points. If my notes serve me right, I have 4 main points: the issue of funding, priorities, risks, and reporting. On the first point on financing the program budget, while we acknowledge that indeed we need to be cautious, optimistic, and we have done so in that planning to ensure that when we look at our outlook, that we're planning realistically. And while the overall trend of financing this program budget that is currently being implemented is positive, we note that there is uneven funding across priority program areas. And therefore, the intensification of resource mobilization with existing and new partners is critical and continues to be reinforced by the Secretariat. I'd also like to acknowledge a colleague from WHO is here, Director of Planning and Budget, who through the collaboration with WHO, we have also seen an increased allocation to the Americas in the funding. And again, while there is still a gap, we continue to work with WHO to ensure that the corresponding allocation comes also with the increase in budget. And also would like to thank member states for their continued advocacy in the global fora to ensure that the region not only gets its budget space, but also its due share of resources when distributing. Now, with regard to the priorities, I would like to again acknowledge that we have done this exercise with member states jointly last biennium. We look at the situation, we look at the needs, we look at the country cooperation strategies. Thank you for acknowledging that. But we also look at the influx of funds. We had to plan according to what realistically can be mobilized in voluntary contributions. We look at the funding gaps, okay, and also where the member states are demanding additional technical cooperation. As we have highlighted in the previous discussions, there are some areas where it's difficult to mobilize resources like the NCDs and maternal child health. And this is where the assessed contributions, the most flexible funds and precious funds are critical to ensure that such resources can be allocated to respond to those priorities. So while the prioritization is an input, we look at other factors to allocate the budget increase, including, and I need to highlight this, the alignment with the WHO, with the decisions already that member states had approved in the WHO program budget. With regard to reporting, there are two aspects of this. Indeed, we will report, as we always do, with the full accountability and transparency in a biennium assessment on how the resources were invested and to what end, what results were achieved. And with regard to the specific question on the Director's Reserve, as per the financial rule of line, there is a quarterly report that is put together on the reserves of the Director, and the next report, which is due at the end of this month, will be made available to the member states. I thank you.
Many thanks, Ronnie. Madam Director, any comments?
Thank you, Mr. President. I would just like to add my own words of thanks to our member states who have advocated so successfully for the WHO increased budget for AMRO. I think now you have to be vigilant that that budget is funded. And just to reiterate that despite that increase, that the AMRO portion of the WHO budget is still the lowest. So there's still room for more advocacy. And I say that recognizing the budget director of WHO. So I'm sure that they are taking note. But thank you so much for ensuring that that we could get increases in budget and funding. And this is particularly important as you have passed the resolution for increasing quota contributions to WHO. And you have not considered that yet for PAHO. So make sure we get money from WHO. Thank you very much.
I always like Madam Director, she tells it like it is. I do want to echo though, the DG of WHO is here this week, and AMRO is, I think I've seen the figures, almost around 74–75% short. I mean, of the overall amount that WHO is supposed to pay to PAHO is each biennial is it's not happening in a way. There's a slight trend upwards recently, but we need to get well above 75%. So anything you can do and talk to your colleagues in Geneva about supporting adequate funding from the WHO to PAHO would be really important. So appreciate that. It's now my exciting pleasure to invite our poor rapporteur who's been waiting all this time to be able to read a resolution. And I'd like to turn to her now for the reading of the resolution. Madame.
Muchas gracias, señor presidente.
Thank you very much, Mr. President. Proposed resolution, program budget of the Pan American Health Organization, 2022-2023, proposed amendments. The 30th Pan American Sanitary Conference, preambular paragraph 1, having reviewed the document, program budget of the Pan American Health Organization, 2022-2023, proposed amendments, document CSP 30/6. Whereas 2, having considered that during the 75th World Health Assembly in May 2022, member states approved the proposed revision to the program budget 2022-2023 of the World Health Organization, WHO, with an overall increase of $604.4 million, including an increase of the regional office for the Americas portion of the program budget of the Pan American Health Organization, PAHO 2022-2023 of $39.5 million in base programs. PP3, having considered that the increase in available funds and the technical cooperation needs for outbreak and crisis response and the Smart Hospitals Initiative imply the need to revise the special program segment of the PAHO program budget 2022-2023, PP4, noting that the proposed revisions to the PAHO program budget 2022-2023 consider the evolving context and impact of the ongoing COVID-19 pandemic at global, regional, and country levels, PP5, bearing in mind Article 14.c of the Constitution of the Pan American Health Organization and Article 3, Paragraph 3.5 of the Financial Regulations of the Pan American Health Organization, OP1, resolves to approve the proposed amendments to the PAHO program budget 2022-2023, a total increase in the PAHO program budget 2022-2023 of $193.5 million, $39.5 million in base programs, and 154 in special programs, 154 million, bringing the overall PAHO program budget 2022-2023 to an amount of $881.5 million, as outlined in document CSP 30/6. OP2, to encourage PAHO member states, participating states, associate members to continue advocating for an equitable share of the WHO resources, and specifically for WHO to fully fund the budget space allocated to the region of the Americas. Operational paragraph 3, to encourage member states, participating states, associate members to make voluntary contributions that are aligned with the PAHO program budget 2022-2023, and where possible, to consider making these contributions fully flexible and unearmarked. OP4, to finance the approved base programs in the following manner and from the indicated sources of financing. Source of funding or financing amount in US dollars. Source of financing, assessed contributions from PAHO member states, participating states, and associate members, $194,400,000. Budgeted miscellaneous revenue, $14 million. PAHO voluntary contributions and other sources, 179 million. Funding allocation to the region of the Americas from WHO, 292,100,000. Total, 679,500,000. Operational paragraph 5. To authorize the director to use all sources of financing indicated above to fund the PAHO program budget 2022-2023, subject to the availability of funding. Operational paragraph 6. To request the director to prepare a report on the expenditure amounts from each source of financing and against the 28 outcomes outlined in the PAHO program budget 2022-2023 to be presented to the governing bodies in 2024. That is all we have in terms of this draft resolution. Thank you very much, Mr. President.
Gracias, Madame Rapporteur. That was one of the shorter ones. Look forward to hearing a lot more from you in the next couple of days. So one more chance for any delegates to comment on the resolution. I believe I do not see any. So I'd like to declare the resolution adopted. Oh yes, do I do this? Right. Okay, there you go. Okay. So we now move to item 4.2. I'm noting the time. I'm hoping that we might be able to get through this item before our coffee break. Report of the end of biennium assessment of the PAHO program budget 2020-2021. First interim report on the implementation of the PAHO strategic plan 2020-2025. Document CSP 30/7, addendum plus addendum 1. Ronnie, you can't leave. You have to stay there. That's right. So there you are. Please come and actually, no, I'll turn first to the president of the executive committee to report and then Ronnie afterwards. So, Madam President.
Muchas gracias, señor presidente.
Thank you very much. For 2, we have the first interim report of the end of biennium assessment of the PAHO program budget 2021-2021. The executive committee reviewed an earlier version of the report on this item in June. The committee welcomed the report, which was considered a crucial document for accountability and transparency. Delegates agreed that the evaluation exercise offered the opportunity not only to take stock of progress, gaps, challenges, and lessons learned, but also to inform action in the current biennium. The executive committee expressed its concern about the lack of progress towards the impact targets of the PAHO strategic plan 2020-2025 and asked the Bureau to provide more information on the action needed to recover from the impact of the COVID-19 pandemic and accelerate progress towards these targets. It was recommended that the Bureau should focus its resource mobilization efforts on the areas where the targets were currently not on track to be achieved. Thank you, Mr. President. This concludes my report on this item.
Gracias, Madam Presidente. Ronnie, please.
Thank you, Mr. President, Madam Director, honorable ministers, distinguished delegates, and colleagues in health. It is indeed an honor to present an overview of this important statutory report, the end of biennium assessment report of 2021, which is a key pillar of the organization's accountability and transparency on results and resources. This report documents progress on implementation of the PAHO strategic plan during its first biennium 2021 and accounts for the implementation of the approved biennial program budget, including achievements, which are the result of the collaboration of member states and partners, challenges, lessons, and recommendations, which will be key as we charter the way forward, protecting the hard-earned gains, recovering and building stronger. This biennial report is more important than ever, as it captures and tells the PAHO story during such trying times. It should serve as an important reference for years to come on the work and resilience of the organization as it responded to its mandate while facing an unprecedented pandemic, a financial crisis, and navigating through evolving and fluid socioeconomic and political issues in the region. It is anchored, all of this was anchored in PAHO's values and principles of excellence, ethics, inclusiveness, and Pan-Americanism. The final report contains updated information since the draft we presented to the Executive Committee in June. And given the need to document and account for what transpired in such a unique biennium, the report was divided in two parts to facilitate its presentation and reading. One, the executive summary, which includes an overview of the findings and key recommendations. And two, a comprehensive addendum, which details the findings of the assessment of the impact indicators, the results of the joint assessment of the outcomes and outputs conducted with member states, the challenges faced, and the country success stories by outcome clusters. We also include a section on a full analysis of the budget implementation, resource mobilization efforts, risk analysis, and lessons learned. To celebrate the hard-earned achievements amid such unique situations, the Secretariat produced a booklet that highlights key main achievements during the biennium, and a printed copy has been distributed to you. We are very proud to celebrate such achievements in such unprecedented times. Allow me to highlight some of the findings. Transformative action was achieved while combating the pandemic. During 2021, the region was able to maintain and achieve significant public health gains while producing transformative action in key priorities, despite the dedicated attention required by the pandemic at national, sub-regional, and regional levels. The pandemic exposed health inequities and the importance of regional solidarity, as has been widely recognized in this forum and other regional and global fora, showing that no country acting alone can successfully address a health emergency of such magnitude, and that people living in conditions of vulnerability were at greater risk due to the pandemic and were profoundly affected by its socioeconomic impact. Progress towards the strategic plan targets is at risk. 9 of the 35 impact indicators that should be achieved by 2025, and I want to highlight, the impact targets are the joint responsibility of member states and the Secretariat. The remaining targets are in trouble or at risk, and therefore they require decisive and bold actions as we accelerate to recover progress and get back on track. At the intermediate and immediate results level, we see encouraging results with 64% of the outcome and 79% of the output indicators assessed as achieved or having significant progress based on the joint assessment conducted with member states. Program budget implementation reached historical levels with 126 million or 23% more than what we implemented in 2018-19. This was driven mainly by funds to respond to the pandemic and other emergencies that the region faced. However, uneven financing of priority programs and timely availability of resources to implement the approved program budget by member states was a significant challenge in the biennium. It is worth noting that the WHO allocation for the Americas showed the highest level of financing in the last 4 biennia, reaching 74% of the approved budget for biennium 2021. All of this was possible thanks to the unwavering commitment of PAHO's personnel, who also had to face the unique challenges: the sound management implemented by the Secretariat, the close collaboration of member states, and support of partners. In addition to the information presented in this report, a detailed assessment of outcome and output indicators conducted with member states is available on the PAHO program budget portal. As I conclude my introduction on this item, I would like to reiterate our appreciation to all member states for their participation and collaboration in the joint assessment that serves as a key input for this report, despite the challenges in completing it amid many competing demands. PAHO's joint monitoring and assessment member states is a best practice in results-based management. This is unique to PAHO processes, and it deepens and broadens PAHO's technical cooperation while enhancing accountability and transparency with member states. Thank you for your attention, and I look forward to your comments.
Thanks, Ronnie. Again, open to delegates for any comments. So Brazil, followed by Bahamas, please.
Senhor Presidente, o biênio 2020-2021 foi marcado por consequências negativas.
This two-year period was marked by the consequences of COVID-19 in the Americas, and taking into account inequities in health that were more visible, reinforcing the principle of solidarity. However, the pandemic has caused tremendous difficulties. Also, this emphasized public health, and this was a catalyst in terms of the region developing its capacity to deal with these emergencies. But this is an important report in terms of accountability and transparency that offers us the ability to take stake of the lessons learned and the challenges ahead. So Brazil considers the evaluation of the end of the biennium a very valuable opportunity to learn not only lessons for the region, but for member states. And it is a roadmap for the different activities that are going to be executed. And this refers to implementing the strategic plan 2020-2025. And we feel that this assessment provides us with an opportunity to take stock of the gains as well as the gaps in the area of health, and analyze the challenges, the lessons learned, and basically the major opportunities. Now, this is a plan for implementation of Health in the Americas 2030 and obtaining the Sustainable Development Goals that have to do with health in the region of the Americas. And it is aligned with the principles of management that are results-based. This report is monitoring past experiences, learning from them, and also looking forward and having interventions that are based on scientific evidence, improving health. For Brazil, it's important that there's this multi-sector approach and that we will be looking at results of evaluation, things like health promotion, primary health, and determining also barriers to access to health services. All of that should also be taken into account. So we know that to move ahead, it will be necessary to have a significant level of political commitment as well as allocation of resources to strengthen those areas that are lagging behind because of the effects of the pandemic. And for this reason, Brazil agrees with the several recommendations to accelerate the recovery of the region as proposed by this document. Thank you.
Obrigado, Brazil. Bahamas, followed by Argentina.
Thank you, Mr. President. Undoubtedly, the budget period under review has been historic for public health agencies at all levels. Unprecedented times call for unprecedented measures. Fortunate for the region, leadership from PAHO has been consistent and steadfast throughout this period. The end of biennium assessment is critical for accountability and transparency and is an opportunity to collectively take stock. While the region was able to maintain and achieve significant public health gains and yielded transformative action in key priorities, the biennium no doubt was marked by unimaginable challenges of the pandemic, PAHO's financial crisis, and the evolving socio-economic and political context in the region. With just around 25% of impact indicator targets estimated to be on track to be achieved by the end of 2025, another 25% at risk, 30% in trouble and unlikely to be achieved, there is much to be done. The remaining 20% of impact indicators that could not be measured speaks to the long-standing inequities in data systems across the region. Progress with outcome and output indicators are encouraging, and the call for sustained implementation of proven interventions is a commitment from the Bahamas. With PAHO's assistance, we are already progressing with health system governance revision and strengthening toward universal coverage with first level care focus, also implementing the IS4H strategy, strengthening the national regulatory system for medicines and other technologies, as well as incorporating genomic sequencing capacities in the National Reference Laboratory. Mr. President, sadly, socioeconomic inequities within and across countries continue to negatively impact health outcomes. The reality is, without collective high-level commitment to tackle these determinants of health, achieving desired health impacts are not likely. The determinants are complex, and while they may be considered as elements outside of the scope of ministries of health and health organizations, the aims to protect, recover, and build stronger during the 2022-2023 and beyond as a region demands an approach that takes into consideration the determinants of persistent health inequalities and other barriers to access of health services. I thank you.
Thanks, Bahamas. Argentina, followed by Canada.
Thank you very much, Mr. President. Argentina takes note of this report. We want to thank the Secretary for presenting this preliminary report in the biennial assessment of the PAHO program budget, and it also talks about SHAA and the health agenda for the Americas. This is important because of the accountability for programs and the transparency of the organization in the context of the world pandemic with major challenges, but especially for the region of the Americas. We know that there is still a lot to be done, but we recognize the efforts of member states and the support of the Bureau, as well as the contribution made by member states. We realize that we have to take stock of the accomplishments of the region of the Americas in the area of health and the challenges that are still faced by our health systems because of the COVID pandemic. This would be necessary so as to guide the 2022-2023 budget. We support the joint assessment of the outputs and outcomes, and here the Ministry of Health has worked very closely with the country office of PAHO WHO and have reported our evaluation data. Thank you.
Gracias, Argentina. Canada, followed by Cuba.
Canada thanks the Secretariat for this report. It provides a solid overview of key achievements in the region over the last 2 years, as well as ongoing and emerging challenges. In this regard, we agree that this provides a critical opportunity for us to take stock while identifying areas requiring increased collective effort. The sudden and unprecedented shift in public health priorities to focus on COVID-19 response are clearly reflected in the findings of this report. We do note the slower progress of certain targets, with only 9 out of 35 on track for achievement by the end of 2025. With the end of the pandemic in sight, we are now at a critical juncture to take decisive corrective action to accelerate progress, particularly on those areas at risk. We appreciate the lessons learned and actionable recommendations outlined in the report, which should inform the collective approach we need. We should also reflect on how we prioritize investments in health, not only reacting to critical health issues, but proactively addressing them. A key path to do so will be through tackling inequities and addressing equitable access to the determinants of health. If we have learned anything over the last few years, it is that we must invest in health through an equity-centered approach. As the report makes clear, addressing the determinants of health remains among the most effective means to achieve higher level impacts. We must take these long-term investments seriously for the benefit of us all. Regarding the budget, we note 17 of the outcomes were financed between 60 and 90%, and 8 outcomes at less than 60% of their approved budget levels. While we recognize reasons for this underfinancing, it is important to acknowledge that this does have a direct effect on the achievement of results. We continue to recommend that PAHO's resource mobilization efforts and resource allocation decisions focus on addressing funding gaps for those critical programmatic areas currently off track. We also continue to urge member states to pay their assessed contributions on time and in full, as we know these funds go toward areas that are critical in enabling the organization to do its approved program of work. Canada is committed to our continued cooperation as a region to ensure that we continue moving in the right direction. May we meet these goals together and achieve the best possible health outcomes in the Americas. Merci beaucoup.
Thank you, Canada. Cuba, please.
Gracias, señor presidente. Thank you very much, Mr. Chairman. We thank the organization for this plan and for the strategic plan of the organization 2020-2025. After several very intense years trying to grapple with COVID-19, we now look at this end of biennium plan as what it is. It's a fundamental means by which we can look at our accounting and define our key priorities. The pandemic certainly highlighted inequities in health, in production, and the distribution of vaccines, as well as the need to be more generous, to show greater solidarity, to intensify our South-South cooperation, and to boost the technological development of this region, because that, at the end of the day, is going to put us in a better position as we face future health emergencies. Cuba maintains its position of total solidarity with this region. Thank you, sir.
Gracias, Cuba. I don't think I see any other delegations wishing to speak. So Ronnie, do you want to comment?
Thank you, Mr. President. And I would like, first of all, thank the delegations of Brazil, Bahamas, Argentina, Canada, and Cuba for their comments. First of all, acknowledging the commitments for action that is required to recover and accelerate progress, the importance of accountability and transparency, which we aim to enhance every time we conduct these assessments. And just to note that in addition to the end of biennium assessment, the Secretariat has an internal practice of reviewing progress every 6 months with the director, senior management, and the entire House. And that goes a long way. And this report is the culmination of the collective assessment with member states, which is also very specific, as I said, to the region. I think it's important to highlight on some points that member states have highlighted in terms of the need to implement the lessons learned. I'm glad to hear that member states find them useful, not just for us in the organization, but also at country level. That is important because indeed we try to capture those lessons learned to inform and the way forward and opportunities to continue addressing gaps. With regards to the issue of priorities and financing, indeed, we note that constant challenge of while we prioritize with member states, it is very difficult to attract voluntary contributions from priority areas that member states identified jointly with the Secretariat. And therefore, and thank you, Canada, again, for highlighting the importance of the timely payment of assessed contributions, which goes a long way to ensure that we can respond to those priorities that do not attract the necessary voluntary contributions. I think as highlighted also by member states going forward, putting equity at the center of health and development will be critical so that we can truly achieve those targets and sustain the achievements. And from the Secretariat, we will continue to monitor and ensure that whatever effort can be done, guided with our senior management and technical enabling and country teams, that we continue to respond to those priorities that member states have approved and agreed upon in the program budget 2022-23. I thank you.
Thanks, Ronnie. Some of you may have noticed the Madam Director has miraculously turned into Mr. Director. Madam Director had an appointment she had to attend to. She'll be back later. Dr. Marcos Espinal, thank you for stepping in. I think you have no comments on this particular item. In that case, I'd like to inform the conference that the discussions will be reflected in the final report. We're going to break, health break, we should be calling it, not coffee break, health break. Before we do, I'm going to ask the Secretary if she'd like to make some announcements.
Thank you, Mr. President. Good morning. I'd like to inform that the working party to study the application of 6B, that a second meeting will take place at the Calvert Room during the coffee break. And again, the PowerPoint presentations of this morning's side event on the update on monkeypox in the region of the Americas is now available through the app of this meeting. Thank you, Mr. Chair, Mr. President.
Thanks, Lou. So it's 10:35. We'll return sharp 11:05 after the health break. Thank you.
The nationally determined contributions, NDCs, meet the commitments made by countries to face climate change. They include adaptation to climate change and mitigation actions, the reduction of greenhouse gas emissions and other atmospheric pollutants. Their implementation brings about benefits: reduction of the number of deaths, number and length of stay in hospitals, number of sick leaves, and respiratory and cardiovascular disease cases related to the quality of the air, among other consequences for the public health system, the companies, and the state. In order to quantify the benefits brought about by NDCs, the World Health Organization developed a tool called Carbon H. Carbon H allows legislators, voters, decision makers, and entrepreneurs to have the information they need on the expected effects on health of the enhancement of the air quality. The NDC, as prepared by Colombia, encompasses 148 measures aimed at reducing greenhouse gas emissions by 51% by the year 2030, as compared to 2014. By using the Carbon H tool, it is estimated that some of the health co-benefits of implementing the NDCs are avoiding 25,600 deaths over the period 2021 to 2030 and 3,800 per year after 2030. As of 2030, 2,750 cases of hospitalization per year caused by respiratory and cardiovascular disorders will be avoided, reducing 892,000 asthma episodes in children per year after the year 2030. This represents economic benefits for the public health system of up to $12.9 billion during the period 2021 to 2030 and of $1.8 billion per year, or the equivalent of 0.64% of GDP as of the year 2030. Carbon H is free of charge for countries, and PAHO is committed to providing the necessary technical cooperation to make the most of it by adding the healthcare costs and tangible figures to the climate actions. You're the only one missing. Visit www.paho.org and get acquainted with the experiences, applications, and possibilities offered by Carbon H.
Gostaria de falar hoje. Oi.
Hi, I'm Paula. I'm the Pan American Health Organization's first digital health specialist on alcohol use.
Why we developed Paola? The COVID-19 pandemic amplified two chronic problems we had with alcohol. One is misinformation on the internet and social media. The other is the limited health professional capacity to deal with alcohol problems in the health system. Therefore, the pandemic accelerated the need for a trusted and reliable source of information to improve health literacy related to alcohol, as well as to help people assess their needs and decide on a change plan towards a healthier lifestyle.
What is Paola, and why do you think we need her? I was brought to provide reliable information about the impact alcohol can have on your health. I want to help reduce your risk of harm from alcohol use.
Beber álcool pode causar câncer?
Há uma forte ligação entre o álcool e as doenças crônicas, particularmente o câncer.
How can I make sure I drink responsibly?
I'm sorry to say, but there's no such thing as responsible drinking.
¿Cómo sé si estoy bebiendo demasiado?
Puedo ayudarte a evaluar si lo que bebes puede causarte daños.
Paola is a conversational agent created by PAHO, the first in the world dedicated to alcohol topics. She's built with artificial intelligence and the latest scientific information on hundreds of alcohol-related topics. Paola speaks English, Portuguese, and Spanish to an unlimited number of users, 24 hours per day, 7 days a week, in a way that is totally anonymous, confidential, and free to the user. She can be reached by mobile phone, desktop, tablet, or other similar device.
Why a digital health specialist for this obviously really important function? What was your decision there?
Paola can answer your questions on alcohol and health or alcohol-related harms, can screen for your alcohol risk, and guide you towards a change or quit plan. She can also refer users to treatment resources in their own country. Paola is empathetic, engaging, her conversations are anonymous and non-judgmental. The capacity of digital people is enormous to reach more people where they are at a minimal or low cost. It can reduce the workload of health professionals and give them more time to talk to the patients when necessary. Compared wear to mask campaigns of education or education in schools, digital solutions like Paola have the potential to be so much more cost effective.
Provokes in humans a limbic system response, if you like. So you can retain more information and you can do it for longer.
Paola is completely innovative, but is based on established evidence-based principles.
In fact, artificial intelligence has become the new frontier in health.
Technology designed to improve knowledge, promote health through personalized, non-judgmental engagement, and ultimately to save life.
It is a great step forward.
Think you could benefit from drinking less?
I know I would. Can you please help me?
I'd love to help you, and I promise I won't judge. I'm a digital person after all. I don't know how to judge.
The Americas, a dynamic region full of diversity, and yet the most unequal in the world. 201 million people still live in poverty. Illnesses such as obesity, diabetes, hypertension, and high cholesterol are more prevalent among poor and vulnerable populations. The mortality rate is twice as high for children under 5 with undereducated mothers. And every year, 2 million babies are born to mothers between the ages of 15 and 19. It is our duty to protect those who are most in need. We will do whatever is necessary to ensure that no one is left behind. We've been doing so for over a century, and we're not going to stop now. Because our determination doesn't stop. Our dedication doesn't stop. Our commitment to our communities doesn't stop. And because life doesn't stop. Health is the most precious resource we have and an engine of sustainable development. It helps to close gaps and reduce inequalities. Investing in resilient healthcare systems is vital for their recovery and preparation for the future. However, no single nation or organization can tackle the health challenges facing the Americas alone. We are the partner of choice to promote public health and the best resource to improve the quality of life in our communities. We provide coverage in all countries, management and supervision of projects at the regional and national level, knowledge and networks in all areas of healthcare, capacity to convene people, mechanisms of transparency, and experience with responding to emergencies. Building partnerships has been essential to improving healthcare in the region. Life expectancy has increased by 36 years. The mortality rate for children under 5 has been reduced by 67%. Hundreds of millions of people have been able to get vaccinated and obtain access to medicines. Smallpox, polio, rubiola, and measles have been eradicated. Each of these achievements demonstrates what can be attained through collaboration. And yet, we still have much work to do. Many people's lives depend on us. Let us continue working together to bring health and hope to every corner of the Americas. The Pan American Health Organization.
There is a silent threat we can confront and beat when empowered with information. Around 57% of cases of liver cirrhosis and 78% of liver cancer worldwide are caused by infections, which in turn are caused by hepatitis B or C viruses. These viruses may produce an inflammation of the liver. Some of the common symptoms are fever, nausea, vomiting, abdominal pain, skin rash, jaundice, loss of appetite. However, in most cases, symptoms caused by the virus do not show for years until the disease becomes chronic. Knowledge is power. Moreover, in order to prevent the spread, we must bear in mind that both hepatitis B and C are transmitted by contact with infected blood due to unprotected sexual relations, mother to newborn contact during delivery, sharing needles, and other personal and intimate objects. A vaccine against hepatitis B is available for people of all ages. A single dose administered to a baby within 24 hours of delivery, followed by a comprehensive vaccination plan during the first 12 months of the child, may avoid transmission of the virus from an infected mother to her child. A routine vaccination plan for children and adults belonging to groups at risk, such as healthcare workers, is the best way of achieving immunity for the population from hepatitis B. In the case of hepatitis C, there is no vaccine to prevent contagion, but there are treatments that cure the infection for good, thus avoiding complications and transmission to others. Remember, knowledge is power. That's why, ask for a hepatitis B vaccine for your baby. Practice safe sex. Do not share syringes, needles, or other objects that may contain contaminated blood. And last but not least, go get tested. Do not hesitate to get a test in order to have a hepatitis diagnosis. If we act mindfully, we may achieve our goal to eradicate viral hepatitis in the Americas by the year 2030.
Las tecnologías perinatales elaboradas por el CLAP son herramientas que permiten acompañar el cuidado de las mujeres embarazadas en el periodo prenatal, durante el trabajo de parto y en el parto, así como en el control de los recién nacidos. Son instrumentos de bajo costo y de alto impacto en la atención primaria de salud, pero también lo son para especialistas que asisten a niveles de mayor complejidad.
Son fáciles de utilizar, de interpretar, trasladar y facilitan la atención oportuna tanto de las gestantes como de los recién nacidos.
Esto con mi historia cita, me voy al medio del campo y yo controlo un embarazo.
Al calendario obstétrico se le agregaron medidas de algunos parámetros seleccionados que permiten calcular la menorrea, vigilar el crecimiento y la vitalidad fetal y estimar la edad del
embarazo, la edad del recién nacido y verificar la normalidad del incremento del peso materno, de la presión arterial y la contractilidad uterina, entre otros parámetros. Este disco permite detectar casos con restricción del crecimiento fetal o macrosomía fetal, alteraciones de la duración del embarazo o una contractilidad mayor a la correspondiente a la edad gestacional. Además, si se desconoce la fecha de la última menstruación, nos permite estimar la amenorrea a partir de las medidas ecográficas embriofetales. A partir de la semana 20 se presentan los valores de percentiles 10 y 90 de peso fetal y el percentil 50 de la talla correspondiente a cada semana.
La cinta obstétrica se utiliza para medir la altura uterina durante el embarazo. Permite controlar el crecimiento fetal y recordar los patrones para la vigilancia de la salud materno-fetal.
El estetoscopio fetal ilustrado tiene figuras sobre la técnica de auscultación y registro de patrones normales y desaceleración de la frecuencia cardíaca fetal a partir de la semana 20 de gestación, asociada a las contracciones uterinas en el embarazo y parto. De esto depende su interpretación y las recomendaciones. El estetoscopio de Pinot, a diferencia de otros métodos, tiene la ventaja de no necesitar baterías, dispositivos que a menudo faltan en los lugares de atención. El dilatómetro es una herramienta que nos sirve como una plantilla para ir viendo el grado de dilatación y de esa forma entrenarnos para la correcta valoración del trabajo de parto. Como podemos ver, se va dividiendo por centímetros, que es la manera como nosotros vamos valorando la evolución normal de un trabajo de parto, y lo hacemos mediante la introducción de nuestros dedos para tener un estimado de la dilatación. Por ejemplo, la dilatación de 2 centímetros nos cabería la introducción de un solo dedo, o la de 10 centímetros cuando podemos abrir al máximo nuestros dedos acá. La cinta neonatal es una cinta métrica diseñada para medir el perímetro cefálico del recién nacido al momento del nacimiento y a las 24 horas si fuera necesario confirmar la medida. En el anverso tenemos impresa una escala de 55 centímetros con divisiones entre centímetros y milímetros. En el reverso contiene los valores correspondientes a -2 y -3 desvío estándar para el perímetro craneano para una edad gestacional conocida para niños y niñas desde las 27 semanas hasta las 42 semanas de edad gestacional. También en el reverso se encuentran los valores normales correspondientes a -2 y -3 desvío estándar de perímetro craneano para niños y niñas de término. Esta tecnología ha sido de gran utilidad para vigilar el síndrome congénito posiblemente asociado al virus del Zika. Este instrumento es de fundamental utilidad para nosotros los neonatólogos y en general el seguimiento del recién nacido, dado que podemos obtener información clara y precisa acompañado de un instrumento que es fácil de utilizar, nos facilita la valoración de nuestros pacientes.
Although you may not feel it, it's here. The air we breathe is a right. Nine out of 10 people live in cities where air pollution levels are above those recommended by the World Health Organization. Air pollution knows of no borders. It is a global issue, causing inflammation of our airways, cardiovascular diseases, neurodegenerative diseases, preterm births, and skin aging. And it kills almost 7 million people every year. We may reduce pollution levels by demanding laws that limit the emission of gases and particles, by using clean means of transportation, providing for a good disposal of waste products, by opting for energy efficiency. You are part of the solution.
Aging opens up a world of possibility. The possibility of continuing to do what we love and be who we are. But without the right support, aging can also bring limitations. Poor health, vulnerability, loneliness. We believe that a safe, caring, and supportive environment can turn aging into an opportunity to be healthy, to live fully, to embrace change, and keep learning and developing. We believe all people have the right to thrive at any age, adding dignity to years, well-being to years, life to years. It's a decade of healthy aging in the Americas, adding life to years.
A região está diante de uma iminente crise pela considerável diminuição do número de crianças que recebem todas as vacinas. Em 2021, nas Américas, 2,7 milhões de crianças com menos de um ano não receberam ou completaram seus esquemas vacinais básicos devido às interrupções nos serviços de saúde ocasionadas pela pandemia da Covid-19. A pandemia também afetou a vigilância dessas doenças e os sistemas de laboratório. A região poderia não ser capaz de detectar o próximo surto de uma doença prevenível por vacinação antes que ela se torne uma epidemia multinacional. Pela íntima relação entre epidemias e a vida em sociedade, estamos não somente ante a um risco sanitário, mas também ante a um risco econômico, educacional e social. Precisamos diminuir o risco de importação e de surtos de doenças que foram eliminadas das Américas, como a poliomielite, a rubéola e o tétano neonatal. Para conseguir isso, os Estados-membros, os parceiros e a Organização Pan-Americana da Saúde devem trabalhar em conjunto para fortalecer todos os aspectos dos programas de imunização, investindo recursos financeiros e aumentando a quantidade de pessoas capacitadas que possam garantir serviços de imunização e sua integração ao sistema de atendimento primário da saúde. Isto somente vai ocorrer se os governos e os sócios se comprometerem, política e economicamente, a fechar as lacunas na imunização. Como principal colaborador da região em todas as questões de saúde pública, a OPAS está perfeitamente posicionada para ajudar os Estados-membros a priorizar suas necessidades mais urgentes e implementar ações a favor da vacinação. Continuemos com nossa exitosa colaboração para fortalecer os programas nacionais de imunização em toda a região. É possível superar esta crise. Juntos, triunfamos no passado e voltaremos a triunfar. Organização Pan-Americana da Saúde, 120 anos. Somos a Organização Pan-Americana da Saúde,
comemoramos 120 anos de solidariedade na promoção da saúde e bem-estar das pessoas, sem deixar ninguém para trás.
Good afternoon, morning still, everyone. Muy buenos días, mitad de la mañana a todos. Very good half morning. Can I kindly ask you to take your seats, please, so we can check quorum and reconvene. Muchas gracias.
There we go.
You're on.
Colleagues,
You're on.
yeah. Good morning again. So we have two items to complete, we hoped, before the lunch break. 4.3, which is a resumption of our item from yesterday, policy for recovering progress toward the Sustainable Development Goals. And I had two speakers, Costa Rica and Colombia, who had previously put up their placards, so I'll recognize them first. And then any other speaker that did not speak yesterday, any other delegation who wishes to speak could please indicate your interest at this time. We will be moving on before and hopefully completing before lunch break, item 4.4. So to my colleague from the UK. I thought it was this afternoon, but it's actually this morning. We hope to get it done before we break for lunch. And I believe there are resolutions associated with these items as well. So if my colleague, our colleague from Costa Rica is ready, you have the floor.
Thank you very much, Mr. President. Costa Rica acknowledges and would like to express its gratitude to the Secretariat for presenting this policy document. In connection with the text, I would like to offer some comments of a general nature. In strategic line 1, it is important to go back to the health approach in all policies in order to understand how the formulation and intersectoral actions have a direct impact on the health of individuals. Even though they do not belong to the health sector itself, because synergies are unavoidable, and one action can have impacts that are not assessed because of the answers of technical clarity. In connection with strategic line 2, it is crucial to have a standardized framework of issues as health promotion, social determinants of health, social determination of health, and services with the equity approaches, amongst others, that will enable us to re-guide health services. In connection with strategic line 3, it is necessary to conduct an analysis of participation and involvement. To turn communities into part of the decision-making is crucial, as well as strengthening those spaces for participation in order to give them the power to modify their reality by giving them a sense of belonging and leadership. In connection with the strategic line number 4, it is undoubtable the role played by local governments in the health of their communities, but the biggest challenge is to make them part of the process. Municipal actions lack a visualization in the health component. It is urgent to include the health promotion component and thought in the work done by local governments. And last but not least, in strategic line number 5, no doubt the greatest challenge lies on the integration of the social determinants of health in monitoring and evaluation systems, because the systems in the different countries are concentrated on numerical values without taking into account the forces or the elements that have an impact on that result, which are the most significant. We ought to promote a more objective measurement model that allows us to make more timely decisions, because the numbers are unquestionable until we understand their origin and their cause. As we see in the proposed resolution, the health sector must analyze in a critical way the way their policies help us reduce inequities on health, recognizing at the same time that the action in connection with other SDGs outside the health sector is crucial in order to attain SDG 3. However, this entails a commitment in order to develop articulation processes for the benefit of health and in tune with other sectors, so that these will understand that their actions have an impact on health, and thus the importance of working with One Health. Thank you.
Gracias, Costa Rica, Colombia, followed by Dominica, and then Brazil.
Muchísimas gracias.
Thank you very much, Mr. President. Colombia wishes to begin by expressing its gratitude for the presentation of this policy and highlighting the participatory nature of the process that led to its development. Colombia notes with satisfaction that most of the strategies envisaged in this policy are aligned with the actions implemented at a national level in early childhood and adolescence, prevention of pregnancy, participation of the community in building policies, amongst others. Nevertheless, we're still aware of the challenges that we face as a country with a view to compliance and implementation of the regional policy proposed, in particular in order to strengthen governance capabilities, which is a key, so that the proposals and the efforts aimed at the transformation of social determinants of health will materialize and become a specific reality. Undoubtedly, the support of AMPAJO in this field will be essential in order to be able to comply with the objectives set forth in the regional policy and the national goals. As we have mentioned previously, the organization is a key stakeholder whose assistance and cooperation will enable us to strengthen the efforts that we have been deploying at a national level. in order to move forward with the strengthening of the monitoring systems and thus be able to assess the health inequities and the social determinants of health. It is important to promote the progress of countries in dealing with the situation analysis tools that might become contributions to joint development of other indicators that will allow us to share and compare information amongst countries. For Colombia, the developments and debates at a regional level in connection with these issues might contribute to the creation of other approaches and methodologies and analysis of reality that might contribute to a better understanding of the problems and the responses required in order to transform them. In order to attain the different goals, we obviously need the understanding of the social representations, practical representations, and attitudes that then underline explaining the behavior of these individuals, and based on that to define relevant social cultural actions for its approach and transformation. In this context, the exchange of experience and knowledge at a regional level is essential. Last but not least, for Colombia, it is relevant to move forward towards a deepening of the conditions or circumstances and need to be transformed in order to favor health equity, and in particular, in order to attain SDG 3, acknowledging the national context and their real capacity in order to transform them. Once again, we're very grateful to PAHO for their support, and we reiterate that from Colombia, we're willing and interested in continuing to work jointly in the attainment of the Sustainable Development Goals at a national and regional levels. Thank you.
Gracias, Colombia, Dominica, and then Brazil.
Thank you, Mr. President. Dominica lends its support to the proposed policy for recovering progress towards the Sustainable Development Goals with equity through action on the social determinants of health and intersectoral work. As stated in the policy document CSP 30/H, the region of the Americas may not be on track to achieve the SDGs by 2030. However, in spite of the many challenges and the hurdles that seem to be permanently etched in our path to accomplishing these goals, our governments should remain undaunted and find different ways and means to overcome such challenges and hurdles. Dominica has placed great emphasis and focus for the achievement of the SDGs. Following the devastation of Hurricane Maria to our country in 2017, the Honorable Prime Minister of Dominica made a pronouncement of Dominica becoming the first climate resilient country in the world. In keeping with this, the National Resilience Development Strategy, NRDS 2030 Dominica, was developed. The NRDS is designed to bring hope to the people of Dominica and factor climate and non-climate considerations in the development process, aimed at increasing the probability of attaining key development objectives such as poverty reduction, social protection, and overall improvement in the quality of life of our citizens. The NRDS 2030 presents the government of Dominica priority areas of pursuit to sustainable economic growth, and of highest priority is progress towards achieving the Sustainable Development Goal targets by 2030. It is characterized by three major forces, one of which is the Sustainable Development Goals. The policy presented for consideration speaks to complex health problems requiring actions beyond ministries of health. The COVID-19 pandemic has further highlighted the importance of this, and the need for interministerial as well as multi-sectoral approach is achieving positive outcomes. The government of Dominica have realized that sectoral strategies that focuses on people, as well as logistics and cross-cutting areas, will help drive the NRDS and lead to the achievement of our resilient agenda. As such, our country have taken these approaches in managing the health priorities, and the various ministries, for example, health, education, and agriculture, have identified areas of synergies and have incorporated this into the individual strategic plans of our ministry. As an individual country, we have also adopted a multi-sectoral approach and community involvement in our quest to achieving the SDGs 2030 goal, but we must continue to work together as a region towards that same goal. Dominica remains very hopeful that with such an approach, we are able to achieve much and therefore supports the proposed resolution. Thank you, Mr. President.
Thanks, Dominica. Brazil, please.
Mr. President, the COVID-19 pandemic exacerbated inequalities, particularly in access to health, having a negative impact not only in SDG 3, but also having an impact on many other aspects of development. As soon as it picks up with the issue of preparedness, response, prevention, and response to health emergencies, we reiterate our approach. The national health system that are strong and resilient will always be the main pillar in creating scenarios to deal with this. And on the other hand, we have to be aware of the need to simply deal with this and deal with the social determinants of health, aiming at reducing inequalities. Through the resolution thus adopted, we reaffirm the commitment of our region with Agenda 2030 in the sense of attaining equity in health and well-being based on the strengthening of community participation and the involvement and engagement with civil society, besides the monitoring of indicators and the evaluation of progress in order to reach SDG 3 in a context of equity. And let us remember that in 2011, together with WHO, we organized the World Conference on the Social Determinants of Health that led to the Rio Declaration on the Social Determinants of Health. The policy that we're about to adopt in this proposed resolution defines strategic lines of action that will enable us to accelerate the development and conception of SDGs and to build a sustainable development model that prioritizes education. The pandemic showed the need for equity policies that will act on the social determinants of health, better issues on health, and will improve the preparedness and response to public health emergencies. Because of those reasons, we defend that the region should work in order to look for an increase in health investments and stepping up international cooperation and the exchange of best practices and lessons learned. Last but not least, Brazil had the opportunity to contribute actively to developing and building this proposed resolution, whose content we fully support. Our joint work will be essential in order to reduce inequality and improve the quality of health in our population and in our populations. Thank you very much. Thank you.
Obrigado, Brazil. I see no other states wishing to speak. I know many of you did yesterday. So I'm now going to turn, oh, I'm sorry. Is there one more? Puerto Rico, please.
Gracias, señor presidente.
Thank you, Mr. President. We thank the Secretariat for presenting this policy document in order to facilitate the work of PAHO and the recognition of the development of this document that is now brought to our attention, CSP 30/8 in Agenda Item 4.3. It is a document that has been prepared with a great effort and dedication, with a high scientific value, in order to adapt it to its practical application in public health. One of its virtues and its definite importance is found in its subtitle, Policy for Recovering Progress Toward the Sustainable Development Goals with Equity. By simply looking at the title, this implies not only renewing the commitment, but reverting the backlog towards the attainment of SDG 3, and to go back to the path towards the goal of not leaving anyone behind. In connection with the proposed resolution, it once again stresses that search for equity through actions that deal with the social determinants of health. And something that is very important is intersectoral work, and it acknowledges that health is a key dimension in social and economic development. Last but not least, the proposed resolution includes the cross-cutting nature of complementarity with the following documents. The objectives of the strategic plan of PAHO 2020-2025, the health agenda, sustainable health agenda for the Americas 2018-2030, and also the strategy and plan of action on health promotion within the context of the Sustainable Development Goals 2019-2030. So we support the policy as well as the proposed resolution. Thank you, sir.
Gracias, Puerto Rico, Ecuador.
Muchas gracias, señor.
Thank you very much, Mr. President. Ecuador also welcomes the submission of this report and stresses the importance of renewing the commitment that states and the international community have towards the attainment of the SDGs. This path towards the attainment of the SDGs has been obviously impacted by the pandemic, and therefore going back to the path towards their attainment will call for collective efforts and public policies aimed at the strengthening of the health determinants.
But let us also recognize that the pandemic also has represented an opportunity to involve other social actors. Indeed, during the pandemic, many private and social actors stepped up in the processes of vaccination and boosting the resilience vis-a-vis COVID-19, and offered a means by which, from their own respective competencies, contributed to making a difference. And so the 2022-2032 decade for health in Ecuador has focused precisely on reducing inequities with regard to the right to health, living conditions, and inequities in access to health through an intersectoral approach involving the social and environmental determinants of health. In that regard, the responsibility of the other public sectors, such as, let us say, food, education, mining, education, industry, you name it, all these sectors have their respective obligations to look for improving life conditions. And the passing of policies to improve health, not just in the health sector, but in the rest of the health sectors, we believe speaks to the community and municipal and social organizations' contributions for what is in fact a collective adoption of policies. And that is why we very much support the proposed resolution that we are considering at this moment, because it underscores the importance of every member state's contribution to ensuring that our broaching of these elements are non-divisible and cross-cutting. Thank you.
Gracias, Ecuador. I'd just like to take this moment to, I think most of you are aware already, but after you give your remarks, don't be afraid because some PAHO representative comes hovering over you soon after. She's just trying to make sure she gets a copy of your intervention. So we have several non-governmental organizations that have asked to speak to this item. I'll list them in the order that I'll request you to speak. I'm going to use your acronym, and I would like you to introduce yourselves before you give your statement. So we'll be starting with AIDS, then the ICN, then the CLAS, and finally Movendi. So AIDS, you have the floor.
Buenas tardes, buen día, perdón.
A good day to you all. I'm Stefan Lege from IDIS, and I am representing an institution that was founded in 1948 and that has been working with PAHO since then. We have our 2030 development that was plan that was adopted in 2017, and our 2018-2030, in which we established 5 thematic axes with regard to these goals. This involved environmental health and SDG 13 and an alliance to move us all forward. With regard to the use of water resources, we worked through the provision of water and sanitation to make sure that these are real and effective for the consumer and in the whole chain of sanitation. The use of water, using WHO plans for the safety of water, for sanitation in general, and we very much emphasize the virtual means for training that WHO facilitates. We also work on the disposal of solid residue from hospitals and the sustainable recycling of same. In SDG 11, we work with establishing agreements under our environmental and healthy policies as regards coastal areas. At the present time, we know how many of these have turned into trash lots, and we're working very much to make that change and to ensuring sustainable development of the marine environment as well as the coast. The principles of appropriation, harmonization, and alignment with governments and civil society organizations is important to us. We're looking for sustainability in an environmental sense and looking also to reduce inequity in these areas of provision of water and sanitation. The fight against the pandemic has certainly emphasized the importance of our work, and we have chapters throughout the Americas, by the way, North, Central, South America, the Caribbean. We have representation so that health and the environment are very much at the forefront of people's policies there. Thank you.
Thank you. Next, ICN.
Hello, my name is Dr. Giladinsky, and I'm speaking on behalf of the International Council of Nurses. We are a federation of more than 130 national nurses organizations and the voice of 20 million nurses worldwide. The International Council of Nurses supports the need to focus on social determinants of health in order to achieve the Sustainable Development Goals. ICN sees investing in nursing and health workforces as key to achieving health equity and addressing SDHs and preparing for future pandemics. Nurses work in a variety of settings, including preventative and public health. They see the impact of failing to address SDHs in achieving SDGs. SDGs regarding poverty, hunger, education are all things that nurses are trained to assess in their patients. Nurses are also key players in health equity research and policymaking. Failing to incorporate nurses into leadership positions in health equity will leave us with unmet needs in our healthcare system. The ICN calls for the following: ensuring nurses have adequate training to deal with health disparities so SDHs are addressed and assessed in healthcare systems. Ensure that nurses are in leadership positions within all health equity interventions. Ensure that disaggregated data on health workforce populations is also included in your resolution. Your policy called for disaggregated data on populations such as sex, gender, age, ethnicity, territory, income, education, occupation, social class. The ICN also calls for the same disaggregated data on health workforces, as we need a diverse health workforce in order to meet the needs of diverse populations. Finally, the ICN calls for incorporating investments in health workforces and nurses into all health equity interventions, as without strong nurses and health workforces, we will be unable to address social determinants of health and prepare for future pandemics. The pandemic has increased poverty, reduced access to food, and widened gaps in education, making it more difficult to address social determinants of health. Nurses are key to resetting after the pandemic and to help work towards SDGs. We call for nurses to have leadership in all health equity interventions. Thank you.
Thank you. If we didn't know it before the pandemic, we certainly know it now, how important it is for frontline workers like nurses to be not just frontline workers, but to be involved in the policy and decision-making that influences their work. So one hopes that we all get that, and that is an activity which we will be, as policymakers, accelerating and engaging more in the time to come. Next is CLAS. You have the floor.
Honorable Chair, distinguished delegates, I'm Angelica Maria Claro, and I'm part of Movimiento International. And I thank you for this opportunity to speak on behalf of my organization. We congratulate PAHO for the document that has been put forward on the policy in question. And we very much back the 5 strategic lines that are included therein, most especially, I might add, strategic line 3. And let us remember that the strategic line on the goal of the 2010 WHO already underscored the importance of community action as a result of alcohol and its very negative impact on equity. Damage caused by alcohol is already very palpable in the 2030 agenda because of the 17 SDGs and the 17 action on sustainable development health shows again how pernicious alcohol is throughout the Americas, both because of the damage that it causes to the consumer of said alcohol, as for all of those who live around the consumer, the secondary effects. The overall burden of alcohol is almost twice that of tobacco. Damage from alcohol, therefore, it's fair to say, disproportionately affects those who are most vulnerable in our communities, in our societies at large. But there are solutions that have been proven to be effective in order to prevent and reduce the impact of alcohol, and in so doing, to promote equity and the development toward many sustainable development health policies. That is why we urge you to do 3 things. Guarantee effectively the formulation of policies in all important contexts to do with health and the rest of the sustainable development goals. Also, impose taxes on alcohol to a greater extent, because that in and of itself will be a benefit. It will minimize the inequities caused by alcohol, and it'll also generate the resources we so need to fight it. Thirdly, implement the technical proposal called SAVOR. This will be a means by which we can boost socioeconomic progress and better equities and health. It's important that we recognize what a great obstacle alcohol is to equities and health. Now, I do have another statement, if I may, Chair. At this time, it is an honor to speak on behalf of the coalition Healthy America. I represent more than 200 civil society organizations, and as well as Campaign for Tobacco for Kids, Corporate Accountability, ASH, Smoking and Health, Moendi International, and NCD Alliance. Along with these, we congratulate PAHO and its member states for their renewed joint and several commitment to the developments, to the Sustainable Development Goals at 2030, and very much as regards leaving no one behind with regard to our own SDHs. Prevention of non-communicable diseases is a critical part of our action. This has not so only contributed to so many deaths in COVID-19, but it says a great deal about ongoing hunger, poverty, and lack of education, and so many other elements that are determinant in our SDGs. There are negative impacts on our economic, social, and health policies where these are not regarded, especially in the more vulnerable communities. So if you want to really make a difference to our region in terms of health, we have 3 suggestions. Number 1, back regulation of those industries that are hugely damaging to health. The tobacco industry, the sugar industry with its ultra-processed products, and the alcohol industry. That's suggestion 1. Now I move to 2. Move for healthy diets, sustainable intake. There's much we can do. Impose taxes on the non-healthy taxes like ultra-processed foods, tobacco, and alcohol. That will increase taxes, bring more money to the medical areas that need one, but also use 5.3 of the Framework Convention of WHO against tobacco that focuses on the created interests in the tobacco industry and what we can do to counter it in that and other industries. Also, extend this focus to all of the non-healthy productions of food and other things that humans ingest, smoke, or drink. All of this has a tremendous negative impact on public health. The pandemic and non-communicable diseases, as we know, are slow but deadly and have a tremendously negative impact on health. I know you have good plans in this regard in terms of vaccination and especially political leadership. Thank you so much.
Many thanks for that. I think I'd now turn back to Dr. Eichmann's. There was a lot of comments from a lot of sources, so try not to necessarily think you have to address every single one, but you have the floor to provide.
Thank you. That was exactly what I was planning to answer to all the 24 interventions. Muchísimas gracias. No se asustan. Muchísimas gracias.
Thank you very much to each of the many countries that have spoken up to support this resolution, and precisely with an aim to closing the gap between statements and fact. You have rightly pointed out the urgency of taking measures to reduce inequities in health through action on the social determinants of health, through its economic, political, environmental, and other dimensions, through intersectoral approaches, as we know that SDG 3 can only be met through the meeting of so many others at the national, subnational, provincial, and community, and frankly, urban areas. Esteemed delegates, you have rightly pointed out the actions that are already being taken in order to bring us toward a proper post-pandemic recovery with renewed focus on equity at the national level. We heard Suriname, Chile, Paraguay, Panama, Honduras, the Dominican Republic, St. Lucia, Cuba, Colombia, Dominica, and others, but also at an international level, Brazil, Canada, Argentina, and others, speaking of their international efforts. Likewise, many of you have rightly pointed out the importance of leadership in the health sector and combination with other sectors, labor, education, social protection. We heard it from Honduras, Argentina, Mexico, and others, and also the importance of letting that coordination filter up to the highest levels of government, as has been done in Suriname. You also reiterated the fact that there is no health if there is no action in the other SDGs, and the 2030 agenda simply won't go anywhere without health. We all get it after the pandemic, one would hope. We will certainly keep supporting our member states from the Secretariat of PAHO together with other partners, other international organizations. Secretariat is already distributing plans of action in that sense in a practical and in a concrete way, adapting the measures we're proposing to the actual context of the countries as Bahamas requested, and which will continue doing so, generating capacity in governance for health, diplomacy for health, intersectoral activity for health, looking for a focus of equity in our health systems, cross-cutting as it must be. Also to generate social participation and local work with local governments to transform our monitoring systems to go above and beyond averages. We also back the generation of resources, facilitating exchanges among countries, cities, and townships. Ladies and gentlemen, you have said clearly that now is the time to rethink the future and to act in a manner that the future may be more just and more equitable. Or, as the representative for the youth of Canada has said, the voice of the future, have a brighter future now as a result of you. Thank you. Thank you very much.
Thank you very much, Dr. Eichmann. I think you have a future as a politician here. No, seriously, I'm very impressed by your ability to reflect back. And I think it demonstrates very well that you member states speak and PAHO listens. Dr. Acting Director Spinelli, you have a few words.
Thank you, Mr. President. This is, this policy focus on equitable access, equity for the people. And this is the most inequitable region of the 6 regions of WHO. So the policy, it's fit to apply to our countries. But the issue is that social determinants are always very broad with several domains: economic stability, education, access to healthcare, neighborhoods, education. The key issue to me is that empowering local government, going to the subnational and empowering communities and the people in civil society, so they demand from these local governments, because we keep hearing about social determinants and there is a lot being said. And when Dr. Eichmann said from the commitments to action, that's where the key issue here. And I think if some of these strategic lines, let's say all of the strategic lines, are implemented and embraced by our member states, as they said they will in the resolution, this could really help to achieve the Sustainable Development Goals and to improve the life of our people. I think it's vital. This is not only endorsed, but takes, to the heart of our countries for the benefit of the people. Thank you.
Thank you, Dr. Marcos. Now we turn to the rapporteur to present the proposed resolution. I think everybody should have a copy of the resolution. I believe the interpreters do as well. So, Madame Rapporteur, over to you to propose it.
Muchas gracias, señor presidente. Thank you very much, Mr. Chairman. Proposed resolution, policy for recovering progress toward the Sustainable Development Goals with equity through action on the social determinants of health and intersectoral work. The 30th Pan American Sanitary Conference, preambular paragraph 1. Having considered the policy for recovering progress toward the Sustainable Development Goals with equity through action on social determinants of health and intersectoral work, paren document CSP 30/8, close paren, preambular paragraph 2, bearing in mind member states' commitments to the achievement of the goals of the 2030 Agenda for Sustainable Development, which provides a powerful framework for improving health and equity. Preambular paragraph 3, recognizing that the region of the Americas is not on track to achieve the goals of the 2030 Agenda, including Sustainable Development Goal 3, ensure healthy lives and promote well-being for all at all ages, and that this situation has been aggravated by the COVID-19 pandemic. Preambular paragraph 4, considering the urgent need to recover and accelerate progress towards the achievement of the goals of the 2030 Agenda with an equity focus, and to acknowledge that health is a key dimension of social and economic development. Preambular paragraph 5, recognizing the importance of social determinants of health for the achievement of health equity, as has been stressed over the years and has been recently reconfirmed in Resolution WHA 74/16 on social determinants of health, 2021, which calls on member states to strengthen their efforts to accelerate progress in addressing the unequal distribution of health resources within and among countries in support of the 2030 Agenda. Preambular paragraph 6, recognizing the cross-cutting nature of this policy and its complementarity with the objectives of the strategic plan of the Pan American Health Organization 2020-2025, the Sustainable Health Agenda for the Americas 2018-2030, and the Strategy and Plan of Action on Health Promotion within the context of the Sustainable Development Goals 2019-2030. Paren document CD 57/10 of 2019, close paren, resolves, operative paragraph 1, to approve the policy for recovering progress towards sustainable development goals with equity through action on the social determinants of health and intersectoral work. Document CSP 30/8. Operative paragraph 2, to urge member states, in accordance with their national contexts, to adopt the following 5 strategic lines of action. A, promote intersectoral action to address the indivisible goals of the 2030 Agenda, integrating equity as a cross-cutting value. B, reorient health policies, plans, and programs to overcome barriers to access to health and to achieve health equity and well-being. C, strengthen and facilitate community participation and civil society engagement through an intercultural approach in order to attain equity and achieve SDG 3. D, strengthen local governance to achieve SDG 3 with equity. E, strengthen the monitoring and evaluation of progress towards the equitable attainment of SDG 3. Operational paragraph 3, to request the director to A, provide technical support to member states to strengthen the specific competencies and skills that are needed for effective intersectoral action on social determinants of health. B, provide technical support to member states to integrate social determinants of health into the work of health systems and services, and to include an equity focus in the formulation of health policies to overcome barriers to access to health and health services. C, provide technical support to member states to strengthen community participation and civil society engagement, promoting effective mechanisms and tools for meaningful participation, giving a voice to all. D, promote the strengthening of local governance and of healthy municipalities, cities, networks in the region, facilitating city-to-city exchanges and supporting urban and rural health action that addresses inequities in order to achieve SDG 3. E, strengthen monitoring of SDG 3 indicators through exchange and learning platforms, facilitating the incorporation of timely information from the health sector and other sectors, and provide guidance on the development of systems for the monitoring and evaluation of social determinants of health and equity. F, promote collaboration with other international organizations to create synergies in addressing the indivisible goals of the 2030 Agenda with equity, and encourage international financial institutions to provide financing that is adapted and adequate to developing countries so that no one is left behind. G, report to the governing bodies of PAHO on the progress made and challenges faced in the implementation of this regional policy and its adaptation to specific contexts and needs through a progress report to be presented in 2027 and a final report to be presented in 2031. This is the end of the resolution, Chair. Thank you very much.
Many thanks, Rapporteur. I know there are a current and 5 prospective directors that are taking furious notes on what might be their responsibilities very soon in this regard. Okay, so we have the resolution. Any questions or comments, objections to the resolution from the floor? Seeing none, I declare the resolution adopted. So colleagues, we have about 30 minutes left before lunch break. We will likely not get through, in fact, we'll certainly not get through this item 4.4 policy for improving mental health, but at least we can get started. And then we will resume after the lunch break with that item. So document CSP 30/9 and Dr. Anselm Hennis, the Director of the Department of Non-Communicable Diseases and Mental Health, the Pan American Sanitary Bureau. Please join us. There you are. And as per usual, we yield the floor to the President of the Executive Committee to report on this item.
Muchas gracias, señor presidente.
Thank you very much, Mr. President. Agenda item 4.4, policy for improving mental health. The Executive Committee expressed solid support for the policy for improving mental health. Delegates welcomed the policy's focus on vulnerable and marginalized populations, noting that those populations are disproportionately affected by mental health issues. It was considered essential to invest additional resources in promoting mental health and addressing disparities in mental health outcomes due to inequitable access to mental health services. Several delegates drew attention to the link between mental health and social, economic, and environmental determinants such as poverty, poor education, unemployment, violence, and climate change. Since such determinants fall outside the purview of the health sector, an integrated, intersectoral, whole-of-government approach to mental health was considered imperative. Community-based mental health care and the provision of mental health services at the primary care level were also seen as crucial. The importance of combating stigma and discrimination against persons with mental health disorders was stressed. Delegates also emphasized the need to incorporate mental health care into disaster and emergency response activities, and the need to give due attention to the mental health needs of healthcare workers, especially in high-stress emergency situations. The committee adopted the resolution CE 170.R2, recommending that the Pan American Sanitary Conference approve the policy for improving mental health. This is the report, Mr. President. Thank you very much.
Gracias, Madam President. Actually, I should say Señorita Presidente. That's correct. I'd like to turn to Dr. Hennis now to present the item. Dr. Hennis, you have the floor.
Thank you, Mr. President. Honorable Ministers and Secretaries of Health, Madam Director, distinguished delegates to the 30th Pan American Sanitary Conference. Thank you for this opportunity to present the policy for improving mental health. Now, as we all know, mental health is not only vital to health, but also to social and economic well-being. Poor mental health is both a cause and a consequence of poverty, compromised education, gender inequality, ill health, and other global challenges. Mental health conditions are linked to premature mortality from cancer, cardiovascular disease, diabetes, and HIV/AIDS, as well as increased likelihood or risk of suicide. Depression and anxiety alone cost the global economy US $1 trillion each year, and it has been projected that by 2030, mental ill health will account for loss of $6 trillion per year, which is more than half of the global economic burden attributable to non-communicable diseases. Mental, neurological, and substance use conditions are a major source of morbidity and mortality in the Americas. Depressive disorders anxiety disorders, and drug use disorders, respectively, represent the second, fourth, and sixth leading causes of all years lived with disabilities in this region. And in striking contrast to all the other WHO regions, there's been a steady increase in suicide in the region of the Americas over the past 2 decades, and suicide now claims 100,000 lives annually. The COVID-19 pandemic has not only increased rates of mental health conditions, but also worsening of the burden of pre-existing conditions. It has amplified long-standing inequities in mental health, as those living in the most vulnerable conditions bear a disproportionate burden of suffering. Furthermore, the pandemic has led to significant and sustained disruptions to mental health services, essential services, limiting access to mental health care. However, despite notable advancements in line with the Plan of Action in Mental Health 2015 to 2020, progress in essential areas such as financing for mental health, suicide prevention, deinstitutionalization, and mental health surveillance has indeed been slow. And while countries have made significant efforts to respond to the mental health needs as part of the response to the COVID-19 pandemic, existing weak mental health systems and services have severely limited these efforts. The unique mental health challenges created by the COVID-19 pandemic, which will likely last well into the future, necessitates a commitment to building back better mental health services using innovative approaches that emphasize high-level advocacy, intersectoral policy coherence, and whole-of-society partnerships and collaboration, and the integration of mental health into all policies, including those beyond the health sector. This policy aims to provide strategic and technical guidance to member states for the successful development and implementation of strategies and initiatives to strengthen mental health within the larger framework of development and in the context of the COVID-19 pandemic and beyond through 5 strategic lines. There's no health without mental health, and the policy for improving mental health represents an important opportunity to not only build mental health systems and services for the future that are stronger and more resilient, but will also support the region in advancing towards achieving its health and development goals. We invite the Pan American Sanitary Conference to review and consider approving the policy and improving mental health. Thank you for your attention. Thank you, Mr. President.
Thank you very much, Dr. Hennis. So we have a growing speakers list. We start with UK, followed by St. Kitts and Nevis.
Thank you very much, Mr. President, and thank you so much for the updates on this incredibly important topic. I know from yesterday's introductory conversations how many people raised this. Very much agree with the points that have just been raised about links with inequity, climate change, the need for an integrated approach, a cross-government approach, and we must combat stigma. Also hearing what was said on the impact on disease and the economic cost, and hearing the concerning rise in the rates of suicide. The pandemic's impact on people's mental health and well-being has really exacerbated many existing inequalities. And we welcome the renewed focus on the importance of mental health services in this discussion, and we can learn from one another. We support the integration of mental health and well-being in the Global Action Plan for the prevention and control of NCDs, and greatly welcome the emphasis on a community-based approach. We're also very aware of other work of WHO on universal health coverage, of which, of course, this is an important part. Integration and a rights-based approach are key. I'm here with colleagues from our overseas territories, and colleagues from the Turks and Caicos have given an example of disasters such as hurricanes and the impact that has on mental health. And the role of PAHO, I know, is so important in helping those impacted. Also, to give some examples, in Montserrat, where currently mental health policy is under review, the focus is very much on integration. It's about how can we use primary care, as you have already said. How can we screen? How can mental health be parts of school programs and parts of antenatal health, for example? And also, I should mention colleagues in Bermuda who have done a comparative analysis of mental health services with others across the Caribbean. Once again, focusing, how do we integrate mental and physical health? How do we link in best with primary care? And training is absolutely critical. And the UK Health Security Agency, CARFA, and of course, PAHO all play their role. So in summary, we greatly appreciate this conversation because we can learn from one another. There are great initiatives across the region, and we very much believe that PAHO, through training and in other ways, has a really key role to play. Thank you very much.
Thanks, UK. We now have St. Kitts and Nevis, followed by Jamaica.
Okay, thank you, Mr. President. St. Kitts and Nevis reviewed the policy document and supports the proposed resolution. The COVID-19 pandemic has increased the burden of mental health issues in the Federation, with a 58% increase in the absolute number of patients diagnosed with depression from 2019 to 2020. The policy document was reviewed, and of particular interest is strategic line of action number 4, reinforcing the interpretation of mental health and psychosocial support in emergency contexts. The Federation is a small island developing state with an estimated population of 53,000, and any emergency or disaster has the potential to affect the entire population. So we recognize that it is critical that national emergency and the Ministry of Health's disaster management plans must include provision for mental health and psychosocial support to reduce suffering and ensure well-being. In response to the COVID-19 pandemic, PAHO partnered with the Ministry of Health to establish our Mental Health Psychosocial Support Committee in October of 2019. This committee aims to address the mental health and psychosocial support needs of the Federation. PAHO also provided technical support and funding to facilitate training of our mental health team and our frontline workers. A mental health and psychosocial support technical working group was formed in September of 2020. The formation of this group helps the committee to consistently map the resources available for mental health support. In 2021, PAHO also provided technical support to facilitate the development of the Mental Health and Psychosocial Support Action Plan, along with standard operating procedures. The standard operating procedures has been included in an annex to the Ministry of Health Disaster Management Plan and the National Disaster Plan to support the COVID-19 response and disaster response. St. Kitts and Nevis aims to prioritize the improvement of mental health and substance use service delivery. St. Kitts and Nevis lends its support to this proposed resolution presented in Annex E. Thank you.
Many thanks, St. Kitts and Nevis. We'll probably have a time for about 5 more interventions. Obviously, there's a lot more that wish to speak to this item, which will be resumed after lunch. But the 5 that I hope to get in before we break are Jamaica, Belize, Cuba, Argentina, and Suriname. So Jamaica, you have the floor.
Thank you, Chair. Jamaica commends the Pan American Health Organization for developing the policy for improving mental health in consultation with member states. We recognize the 5 strategic lines of action around which the policy is framed as critical to regional efforts to improve mental health. Jamaica also recognizes that the strategic lines of action are in keeping with our own efforts to advance the national mental health agenda, which has suffered significant setbacks by the COVID-19 pandemic and has likewise transformed based on the psychosocial impact of the pandemic. Regarding strategic line of action 1, Jamaica has a national mental health strategic plan 2020-2025, which describes the steps to be taken to address the mental health of Jamaicans over the next 5 years. The plan was developed through a process of stakeholder meetings and deliberations aimed at achieving as much consensus as possible. The whole of government approach articulated within this plan recognizes that many of the determinants of mental health and mental illness are influenced by factors beyond the health system. We have also taken steps to integrate substance use policy and related legislation into the mental health policy currently being revised and the current Mental Health Act 1997. With respect to Strategic Line Action 2, Jamaica is currently involved in the MA gap for community training of trainers. Trainers will equip other community-based workers in other program areas to provide mental health support at the community level. Another PAHO MH gap initiative being undertaken in Jamaica is the Problem Management Plus pilot project, which seeks to train community workers to assist members of the community develop problem-solving skills to overcome challenges or adverse situations. In keeping with Strategic Line Action 3, we are working on the increasing our prevention and promotion activities in schools under the School Mental Health Literacy Program. Also, a comprehensive assessment of child and adolescent mental health services will be embarked on with a view of strengthening the existing services through a PAHO SDG project entitled Training in Multisystematic Therapy for Youths at Risk. The existing CAMH staff capacity is being enhanced to support this strategic line of action, and the further development of Jamaica's workplace mental health policy draft will also increase mental health awareness and support in working environments. Jamaica has formed the Intersectoral Mental Health and Psychosocial Support Technical Working Group, which is currently collecting data on the mental health and psychosocial resources and services available island-wide. This is fundamental to identifying existing gaps, taking steps to address those gaps, and for the technical working group to execute its ultimate goal of coordinating mental health and psychosocial emergency contexts. As the inclusion of mental health services in phase 1 of electronic health records being developed under the Health Services Strengthening Program will facilitate continuity of patient care. Jamaica, therefore, in closing, Chairman, calls for greater emphasis on mental health. We recognize the need for greater financing and prioritization of mental health in order to address resource constraints, elimination of stigma and discrimination that continue to undermine the region's effort. We therefore welcome this policy and stand in support of the resolution for its adoption by the 30th Pan American Sanitary Conference. Thank you.
Thank you, Jamaica. Belize, followed by Cuba.
Thank you, Mr. Chairman. The COVID-19 pandemic has put greater burden on mental health programs, which has jeopardized mental health progress. Although mental health has recently received more attention as part of national health agendas, failure to adequately prioritize and fund mental health has prevented countries in the region from making significant progress. In 2019, Belize had an elevated disability-adjusted life years on mental disorders. In this context, the Ministry of Health and Wellness, with support from PAHO, is currently reviewing and updating the national mental health policy to align it with the current overall national health strategy, as well as global and regional practices as defined by the PAHO WHO Plan of Action on Mental Health 2013-2030. The Ministry of Health and Wellness, along with assistance from PAHO, is involved in a capacity building exercise to create awareness and strengthen the primary care network through its support for mental health with the WHO Mental Health Gap Action Program, training initiative across all 6 health regions of Belize. This has been completed in all regions of Belize, including training of 200 community health workers based in the most rural areas in Belize. Review and updating of the police mental health training manuals, as well as the review and development of the police training curriculum to include de-escalation techniques and the proper use of restraints. The development of the mental health and psychosocial support for victims of road crashes project. The review and updating of the suicide prevention plan, which was completed, and the upgrade of the short stay mental health unit to a smart facility. there is still a lot of work that must be done in the area of mental health, including increasing training for psychologists and psychiatrists, as well as psychiatric nurse practitioners, in order to continue reducing stigma and isolation of persons with mental illness and improving access to healthcare. Strengthening health literacy and improving the understanding of mental health and its complications must start early in life. The Ministry of Health and Wellness supports this aspect of health and is working towards finalizing a project known as Workplace Wellness. This project will further support giving breaks throughout the workday, flexibility in work schedule when needed, wellness areas for breastfeeding mothers, exercise equipment and healthy snacks, and training for early detection of mental health issues in the workplace. In Belize, the Ministry of Health and Wellness has taken steps since the 1990s towards strengthening the national mental health program, with the transition from a traditionally custodial, asylum-based service to a community-based model of mental health care. In 2008, Belize's mental health policy was finalized and approved by the Ministry of Health and Wellness and is currently being updated. Through continuous multi-sectoral collaboration with regional bodies such as PAHO and COMISCA, and increasing health education and awareness, Belize remains committed to improving the mental health of our population. We support this resolution. Thank you, Mr. President.
Thank you, Belize. Just to note that I'm usually allowing delegations to go a little bit over the 3 minutes, but if I have to get more difficult with you in the future, I will. Please try to respect as much as you can the 3-minute limit. Cuba, followed by Argentina.
Muchas gracias,
Thank you very much, Mr. President. The document constitutes an excellent tool in order to promote comprehensive and integrated care for mental health in the region. It bases this on a diagnosis of the current problems, the impact brought about by the COVID-19 pandemic, and the urgent need to intervene on risk groups and populations in conditions of vulnerability, thus ensuring psychosocial support. To reach access and coverage of comprehensive mental health care services and to bring in mental health into the different levels of healthcare services is a priority. We acknowledge the need to bring in psychosocial support and mental health to provide care to health emergencies and the use of instruments for training, such as the guides proposed. An important element is the priority to look after the health of health workers and the ratification of giving special attention to institutional environments as well as the family and community surroundings. The development of multidisciplinary research work, the collection of data, the use of good clinical practices, as well as the implementation of actions for monitoring and assessment constitute the guidelines for this policy. We believe that the lines of action proposed will enable us to move forward and make headway in this sense. We ratify the importance of the leadership of health systems so that mental health will become a full part of all of the agendas, and with that to contribute to the goals and attainment of the Sustainable Development Goals. Thank you very much, Mr. President. I abide by your suggestion in a very disciplined way, sir.
Muchas gracias, Cuba. Argentina, followed by Suriname.
Gracias, señor presidente.
Thank you, sir. Argentina is aware of the alarming increase in the worsening of mental health problems during the pandemic. Within this framework, we've strengthened the national strategy during the pandemic by strengthening the mental health component in the response and recovery of the health system by improving the coordination mechanisms for mental health and psychosocial support in emergencies and updating protocols and developing special plans and specific plans for healthcare workers. For the first time, we've included psycho drugs within the essential medicines that are freely distributed to the national state with the purpose of providing a response to the mental health problems in the first level of care. our country has presented the federal strategy of a general approach on mental health that promotes the promotion, prevention, the preparedness of mental health in all jurisdictions. From a point of view of comprehensive healthcare services, we prioritize mental health by doubling the annual budget with the purpose of transforming care towards a model based in the community and with a cross-cutting and intersectoral approach with the perspective of rights that will displace the struggle in that search to fight the pandemic, promoting health. This year, the president of Argentina participated together with the DG of WHO in the launch of the Global Report on Mental Health, which is the first world report of WHO on this very important topic. We're very grateful for PAHO's commitment on this score, and we encourage all the other member states so that they will prioritize mental health in their agendas and will assign resources in order to improve the provision of mental health care services. Last but not least, we support the policy in order to improve mental health and the 5 strategic lines on the basis of cross-cutting gender, equity, ethnicity, and human rights principles. Thank you very much.
Gracias, Argentina. And just as I said, try to keep to the 3 minutes. Also try to remember the interpreters are keeping up with you. So we want to try to make sure we balance the 3 minutes with speaking slowly enough so the interpreters can capture. Okay, lastly, Suriname for this morning session.
Thank you, Mr. President. Suriname would like to thank the Secretariat for the joint efforts for this policy. Mental health is recognized as an integral element of overall health and as a basic and fundamental right. Improving mental health and well-being is also recognized as an essential component of universal health coverage. The post-COVID-19 circumstances in Suriname regarding the mental health burden and treatment gap do not particularly differ from the rest of the region. The pandemic has contributed to elevated rates of psychological distress, anxiety, depression, and substance use within our population, especially at-risk populations. Mental health services were also disrupted in the past 2 years. Suriname, as a part of the region, has also prioritized its response towards mental health. The strategic actions proposed are therefore relevant for Suriname. With the support of PAHO, the MOH evaluated the mental health plan 2015 to 2020 based on the review guiding documents from the WHO and input of stakeholders. A mental health plan 2022 to 2030 was drafted and is to be completed. Of note, the burden of suicide in Suriname is daunting, reaching a third of mental, neurological, substance use disorders and suicide burden at 20 years old and remaining the highest mental burden by far during youth. While men are mostly affected by suicide, alcohol use disorders, and depressive disorders, women are mostly affected by depressive disorders, headaches, and anxiety disorders. The Parliament recently allocated 10 million Surinamese dollars to support this. Plans are in place to strengthen our surveillance systems for suicide, and some 40 healthcare workers and other community workers, such as teachers and police officers in Western Suriname, were trained in the prevention and management of suicide attempts. Additional work is needed in adopting a whole of government and a whole of society approach to improving mental health that promotes strategic collaborations and partnerships with diverse stakeholders across all relevant sectors. There is also a need to improve and scale up equitable and comprehensive community-based mental health care for the entire population. School and community-based programs are also needed to promote mental health awareness and prevention of suicides. Suriname supports the approval of this proposed policy. Thank you, Mr. President.
Many thanks, Suriname. So we will stop now. We have just a couple of announcements. I'll turn to Madam Secretary in a second. But wanted to indicate to you that after lunch, we have, I think, at least 16 more speakers. We will start with Chile, Paraguay, and Saint Lucia. Those will be the first 3. And so we resume after lunch at 2:30. And it's just a gentle reminder that we will be continuing, as I said, on this item 4.4, and then we will be moving to 4.5 and 4.6, hopefully to finish that before the afternoon health break. additional note for you all to be aware of, I unfortunately must be away this afternoon for part of the afternoon. So you voted for two vice presidents for a reason. Antigua and Barbuda and Chile will be successively acting in this position in the afternoon. Please be nice to them. They will report to me on your behavior at the end of the day. So with that, Madam Secretary.
Thank you, Mr. President. Let me please remind our delegates of the side event here in this room, starting now, on leveraging lessons learned from the COVID-19 pandemic to address the mental health challenges for the future. A light lunch will be provided to those that are participating in our side event, joining our side event. For other lunch options, there's a deli and a restaurant here in the hotel, and you may also find a list of restaurants nearby in the governing body's app. Please let me also inform the Committee on Credentials that a second meeting will take place in the Calvert Room now during the lunch break to continue with the verification process. For the committee, a light lunch will be provided. Thank you, Mr. President.
Madam Secretary, we're adjourned until 2:30.
What do you turn this on? I need to turn this on. This is not coming on.
I have no clue what the pen is.
How do you
Yeah.
turn? Oh, no.
Let me find the button.
Okay, we need to.
I think this one is always open, I guess.
Yes, good. Good. Good afternoon, everyone. Distinguished delegates, we're about to begin. So it is my privilege. My name is Anselm Hennis. I'm the Director of Non-Communicable Diseases and Mental Health at the Pan American Health Organization. And it is indeed a privilege and a pleasure to welcome you all to this side event. So we're very pleased to have with us today Dr. Tedros, who has actually joined us a few minutes ago. And so we wish to welcome, give him a special welcome. We also wish to welcome Her Excellency, former Vice President of Costa Rica. We wish to welcome the Honorable Ambassador, Mr. Nestor Mendez from the OAS. We also wish to welcome members of our head table, the distinguished ministers of health and delegates who will also be presenting. So thank you very much and good afternoon to one and all. Now, I would like to remind you that there's simultaneous translation. You'll see the devices on your seats as necessary. There'll be in English, Spanish, Portuguese, and French. And without further ado, I'll actually do an opening video by Dr. Chris Etienne. And then I'll ask Dr. Tedros if he wishes to say words of welcome to you. In fact, I'll ask Dr. Tedros to say a few words to begin with, if that's okay with you, Dr. Tedros.
Yeah, thank you. Thank you so much. Very glad to be here with you. Without further ado, I prefer that the program start, and then I will maybe intervene later on if needed. So back to you, moderator.
Thank you so much. So we'll do brief briefings from Dr. Chris Etienne. If you can have the video.
Members, honorable ministers and public health officials, distinguished delegates, ladies and gentlemen, a good afternoon to all. I am not able to be with you in person, but it is my great pleasure to welcome you to this important side event on leveraging lessons learned from the COVID-19 pandemic to address the region's mental health challenges for the future. The COVID-19 pandemic has adversely impacted the mental health and well-being of everyone, everywhere. And we have seen rates of stress, depression, and anxiety soar in our region. Among the most affected are persons living in conditions of vulnerability, who have traditionally experienced a higher burden of mental health conditions and unequal access to care. Our young people have been disproportionately impacted by the pandemic, and their lives have been upended by extended school closures, the inability to form usual social relationships, and to also enjoy the rites of passage so important to our youth. While they experience the loss of caregivers and loved ones and now uncertain futures. The overall impact of the pandemic is still being evaluated as we continue to learn about post-COVID-19 conditions and its longer-term mental health sequelae, including the risk of cognitive impairment and dementia. Throughout the pandemic, PAHO member states found innovative approaches to respond to mental health demands during the COVID-19 pandemic, including the use of telehealth. But much more is needed to ensure a true transformation of mental health through political actions at the highest level, strengthen multi-sectoral partnerships, investments in infrastructure, human resources, and services. In light of the current mental health crisis, the Pan American Health Organization established in May a high-level commission on mental health and COVID-19 to provide critical and urgent guidance to the organization and its member states. not only to reinforce national and regional mental health responses to support COVID-19 recovery, but also to ensure that we all support the building of more resilient and equitable mental health systems and services. We are honored to have today Ambassador Nelson Mendes, who is co-chair of the Commission. Ladies and gentlemen, as we look to the future, we must ensure the recovery of mental health in our region, not only in the context of the recovery from the pandemic, but also to address the ever-present public health emergencies and humanitarian crises linked to violence, conflict, and natural disasters. We must also highlight the often unseen toll that climate change creates for mental health conditions in our region. And we must address mental health in the region of the Americas holistically to consider individual emotional well-being, self-care, elimination of barriers to accessing care, such as stigma and discrimination, in order to achieve optimal societal well-being and sustainable development. Permit me to express my sincere gratitude to our esteemed presenters who have joined us in person and via video, as well as to the Government of Canada for their support of this event. I hope you have very fruitful and interesting discussions. Thank you.
Thank you so much for those words of welcome from Madam Director. Now we will move on to our first panel, which will share perspectives on elevating mental health in national and regional agendas. And Canada will be represented by the Honourable Dr. Carolyn Bennett, Minister of Mental Health and Addictions and Associate Minister of Health of Canada, who has sent a message in a video, and Dr. Theresa Tam, the Chief Public Health Officer of Canada, who is here with us in person.
Hello, everyone. I'm Carolyn Bennett, Canada's Minister of Mental Health and Addictions and Associate Minister of Health. Today, I'm honored to join you virtually to share with you the approach Canada has taken to address the mental health challenges presented by COVID-19 and the lessons learned that we will take into planning for the future. Before I begin, I'd like to acknowledge that I am speaking to you from the traditional unceded territory of the Algonquin and Anishinaabe people, whose presence here reaches back to time immemorial. For
many of us, recent years have been difficult for different reasons. Many individuals in Canada have faced problems to deal with stress, anxiety, depression, and solitude, which can be attributed to isolation and uncertainty having to do with employment, finance, and even daily disturbances.
Feel that their mental health has worsened since the beginning of the COVID-19 pandemic. The pandemic has also compounded existing health inequities, and public health measures have put greater pressure on groups who were already struggling with mental health challenges before the pandemic. This includes economically and socially disadvantaged groups, as well as sexually and gender diverse people and racialized groups, Indigenous populations, immigrants, and people living with functional limitations. The pandemic has also adversely impacted healthcare professionals, especially women and frontline workers. There
is no doubt that the COVID-19 pandemic raised major challenges to our health systems. But at the same time, we see that it served as a driver for some people that perhaps will result in greater coverage for mental health, thus reducing stigmatization and help us make and achieve positive changes and surprising, innovative actions, and not only the virtual reality.
Leveraging lessons learned from the COVID-19 pandemic resonates this twofold impact. In Canada, we have the teachings of the medicine wheel, the goal of balance, keeping people well, mentally, physically, emotionally, and spiritually. As Minister of Mental Health and Addictions, I know that we can no longer see healthcare as a repair shop. We must honor the transformation articulated in the Ottawa Charter of 1986. We must work towards moving from health care systems to true systems for health. Ultimately, mental health care must be treated as a full and equal part of our universal healthcare system. As Canadian war veteran Dr. Brock Chisholm, the first Director General of the World Health Organization, famously stated, without mental health, there can be no true physical health. Je crois qu'ensemble, à mesure que
I believe that together, as we change our practices and promising practices, we can achieve this objective, create health systems that are well adapted, and they will be able to tackle future challenges when it comes to health in Canada and everywhere else in the world.
Miigwech, and enjoy the rest of the conference.
Good afternoon, everyone. It's great to be here and have the opportunity for me to be here in person with you in Washington. And I gratefully acknowledge the Nakashtan and Anacostan and the neighboring Piscataway and Pamundi peoples on whose traditional ancestral homelands we gather. Alors que nous nous réunissons de toute la région panaméricaine.
The mission in all Pan-American regions to exchange knowledge and culture, I'd like to encourage us all to, in one moment, recognize the indigenous peoples of all the lands where we come from and to acknowledge their importance.
Like health issues. So it is great that in Canada we have a minister for mental health and addiction, which means that there's political attention to this important public health matter. So the COVID-19 pandemic has certainly highlighted in a massive way that mental health is interconnected with all other complex public health challenges. So using a public health approach to mental health can help us advance our efforts to promote positive mental health, build a system and population resilience, and respond more effectively to the mental health needs during times of crisis. This means, first of all, using science and data to guide our interventions, including disaggregate data, so disaggregation by gender, by race, by indigeneity, for example. So in Canada, for example, we have very good levels of self-rated positive mental health, a strong sense of community belonging, and high life satisfaction. But during the pandemic, studies have shown that there's been reduction in mental health during the pandemic itself, with some populations being disproportionately impacted, such as youth, Indigenous peoples, and racialized communities. Such findings then demonstrate the importance of bringing an equity lens, an equity approach to our collective efforts to support the mental health of these different populations. There is one example I just want to highlight of how to do community-based initiatives. So there are community-based initiatives for Indigenous children and youth that are helping to create access to land-based culture and spiritual teachings, in-person and online peer mentoring, and access to culturally safe mental health resources. And there's an organization in Canada called Fostering Open Relationships Among Youth that uses the arts to focus on cultural identity and developing coping skills while processing trauma in order to deliver culturally safe mental health promotion and interventions for Northern and Indigenous young women and non-binary youth. This type of intervention is a great example of upstream mental health promotion and illness prevention because it's promoting resilience and well-being, as well as addressing underlying trauma resulting from years of colonization. Downstream or treatment-based approaches need to go hand in hand with these upstream approaches, particularly during a public health crisis. As the minister said, and I'm sure it's the experience in many countries, access to virtual care really accelerated, including access to virtual mental health services across the life course. One example that some jurisdictions are implementing into virtual stepped care. including the Wellness Together Canada portal that the federal government supported. So in this portal, if you are going through a tough time and you need to talk to a professional counselor, it's 24/7 free, and you access a counselor immediately in different languages, and there's different services for Indigenous people and for kids as well. And 95% of users felt better after talking to a counselor. So STEP Care is an evidence-informed system that structures care according to the least intensive and most effective options, and the intensity of the treatment can be stepped up or stepped down based on a person's needs. And it covers interventions across prevention, promotion, and treatment. So these kind of innovations can then be leveraged for other public health emergencies like floods. So there was a flooding in British Columbia, and this kind of platform can be used to address mental health needs in those situations. So another really important aspect to mental health is in partnerships and intersectoral collaboration. It's particularly important for populations such as Black Canadians who face racism and other systemic barriers. So funded by the Public Health Agency of Canada is the Mental Health of Black Canadians program, which is an example of cross-sectoral collaboration. One of the projects is called Mobilization Partnerships, taking steps together for supported reintegration. It aims to support the reintegration of African Nova Scotians from the criminal justice system back into the community and to address the mental health related barriers, including stigma. So I think while big challenges remain, I'm particularly hopeful because I think there's greater awareness of the importance of mental health in our society, and stigma around it is certainly in Canada is declining, and that community leaders, youth, Indigenous leaders are creating innovations themselves that are culturally and contextually appropriate. So that's critical to any equity-based public health approach, and helps prepare us for challenges ahead, including climate change and related public health threats to both mental and physical health. I really think that it's great that we're here together. We need to continue these conversations and generate shared solutions, and I hope that we can continue this momentum. So thank you, merci, miigwech, and buenas tardes.
Thank you so much. We thank the Honourable Dr. Bennett and Dr. Tam for their remarks. Canada works to promote inclusion, equity, and diversity in community-based mental health care, which constitutes an important example for the entire region. Ahora quisiera
Allow me now to give the floor to the Honorable Dr. Carla Bisotti, Minister of Health of Argentina. Thank you very much for that presentation. Good midday to you all, distinguished colleague at the head table, DGE, and all who are sharing lunch and listening to this very important topic and the importance that PAHO and WHO have assigned to this topic, a topic that is truly a particularly complex challenge. Firstly, I'd like to echo the words from my colleagues from Canada who just took the floor, who provided us with a very clear diagnosis of the complexity of the problem. Argentina is a federal country. It's the 8th largest country in the world, and one of the countries that have over 45 million inhabitants in Argentina. Health is distributed federally. The state has a directing activity, and each of the provinces manage the health systems, and then at lower level, there is the municipal level. In other words, the public and private sector are very fragmented, as well as national social security and also provincial social security. We have social security in each of the 21 provinces. The challenge to implement public policy is major then. When we think about the complexity of mental health, it is even larger. Despite the recognition about mental health issues, including also addictive consumptions, all of these are problems for mental health when looking into the prevalence or generating data as to impact and looking at the costs. So when analyzing the costs related to mental health, one realizes that we underestimate the magnitude and really it deserves much more work. There are two major challenges in Argentina. One is the one we're discussing here, the impact of the pandemic when it comes to mental health throughout the entire population, but in particular youth and adolescents, and the historical debt when it comes to implementing a mental health law that was enacted in our country in 2010. I don't need to say it here, you've heard it often, the pandemic really has shown up the existing gaps and made them even deeper. Looking at individual care, collective care, building consensus for well-being, promoting health, and the capacity to provide response when any emergency occurs. When we think about the non-specific interventions, the work to support well-being, as we heard from the Minister of Mental Health in Canada, mental health should appear and all must be visible, and all the professionals need to understand it in order to generate a non-specific intervention. Our mental health law, as I said, was enacted in 2010, provides that people with mental health troubles have rights, and the state and local governments are urged to promote systems of care at all levels and to also develop it at community level and to strengthen primary health care, in addition to transforming service-based practices into community-based services to ensure social participation and full social inclusion. It is an enormous challenge. As I told you, the law was enacted in 2010, and Argentina was determined under our president to implement that law and thus respond and react to the COVID-19 pandemic and its impact on mental health. Obviously, this has not been the case of Argentina only, but throughout the world. The presidential decision within the recovery from the pandemic focuses on mental health, thinking about rights, gender, with a community-based, free of violence, and respecting sexual diversity. The president, as we heard from the delegate from Argentina not long ago in this session that preceded this parallel event, presented the overall federal actions because a consensus was built with the 24 jurisdictions. And it is integral because it goes beyond health. It's an interministerial mental health and problem usage committee under the Cabinet of Ministers. The monthly meetings bring together all the areas of national government in order to develop strategies that I will be describing in a moment. The strategy was a part of full implementation of the mental health law to ensure protection of mental health of all persons, and this is recognized in the international international agreement on the rights of people with disabilities. Given what was thought by and announced by the president, there will be technical cooperation with economic support in order to make strides in this strategy governed by the federal government, but also entering into agreements with local authorities, thinking always about federalism and the health system fragmentation. The challenge is that each service, each sector within the health service has to work towards inclusion of promotion, attention, and care of mental health. The federal strategy and some measures, and as we heard from our colleague, implies also working with virtual care access and virtual consultations in order to facilitate access to health for the person from where they live. That way, having their specialized consultations and also training human resources. This is really crucial in Argentina. It was decided to have a twofold increase in the number of people taking care of mental health, and the human resources need to be trained. And from 12 provinces where we were doing this, we grew to the 24 provinces in order to provide training in virtue of the law. Community mental health specialization was created. Health teams were also created in these areas, and they didn't have the degree of specialist. And so before they were not able to practice. We're working with the Ministry of Education to have a pre-graduate curricula that is adjusted and adapted to the provisions of the law. When it comes to training, next year, we will be issuing degrees, postgraduate degrees, to over 1,500 students in mental health. Earlier, we also said that Argentina decided to make available at the primary level to have psychodrugs. There was a lot of dispute about this, but we're moving forward. Argentina has an essential drugs program that provides the essential drugs to 8,600 units, covering most of the frequent pathologies. They're provided freely, and there is a medical kit that is being rolled out progressively in order to provide medication for mental health at the primary care units. Funds are being transferred from the provincial level in order to have greater consultations for boys, girls, adolescents, adults, and the elderly. These diverse modalities for transfers can transform the primary care as well as general hospitals, providing comprehensive use and care of the people who use the different addictive substances, whether it's alcohol or drugs, and also for suicide prevention. We're also working with the LGBTQ+, providing primary care. Another area is training in all the national public administration staff so they're aware of the law, reduce stigma, and guarantee the rights of those suffering from mental health issues. Working with PAHO, we have now reached the 24 jurisdictions in Argentina to launch the global action to overcome gaps in mental health, the HGRAPTA, in order to reproduce training in each of our provinces. This has been a major achievement, and implementation of CARES and providing support to parents in the nurturing of children. Argentina had a law for the prevention of suicide that was enacted in 2015. We have now regulated it recently, and a national program was established to avoid or to address the problem of suicide. And when it comes to the territorial distribution and reaching out to remote areas, both during and after pandemic, the different levels of government are focusing on territorial access. The actions include mental health. A program is called Entre Varios, amongst many. I don't know how the interpreter is going to deal with this expression, but it's when we think about the community outreach in neighborhoods. And here again, it's integral, multidisciplinary approaches to the problem. I do believe that the resolution or item 4.5 is very pertinent. It talks about integration of health systems. If we can't integrate them, then equitable access and universal access to comprehensive care of mental health will not be possible. Mental health needs to be a state policy that goes beyond health. And that is why the Interministerial Committee is above the Ministry of Health, and the commitment of each and every one of the entities is truly valuable, and it's good to be able to encourage it. As we saw during the pandemic, there are actions that go beyond health. We were able to coordinate, and this was not only in Argentina, but all the countries have shown that health is a priority. Without health, you can't work, study, or generate. So it's an opportunity to support leadership of health to address mental health in particular. We should also talk about accessible and quality care services, especially for the vulnerable population who suffer much more and face difficulties in accessing care. We also work of deinstitutionalization of people in my country. We're referring to people using monovalent hospitals. With the Ministry of Habitat and Housing, we're working on a program to build assisted living in order to take people out of asylums. The Ministry of Public Works is financing the updating and renovation of polyvalent hospitals to take care of people with mental health problems and problem usage. Lastly, I echo the words from the Minister of Mental Health in Canada. There is no health without mental health. She further said, without mental health, there can be no social justice either. It's very important to work along these lines. Argentina is participating at the Mental Health Summit 2023 in Italy, in Rome. And to show the priority and commitment assumed, we have proposed offering to host the summit in Argentina. The president is committed to this. Hopefully, the entire region will be active and will participate actively to show everything that we have been doing under the pandemic, what we're doing now, and what we intend to continue doing. Thank you very much.
Yes. So thank you so much, Dr. Vizzotti, for that very comprehensive perspective on mental health care in Argentina and for reminding us that there's no health without mental health. Her Excellency Epsie Campbell Barr had an emergency, was unable to attend with us today, but she has sent her regards and a message by video, which we will now share with you.
Gracias.
Thank you very much, Honorable Assistant Secretary General of the Pan American Health Organization, Ambassador Nestor Mendez, honorable ministers and of public health officials, distinguished Director of the Pan American Health Organization, Dr. Carissa Etienne, distinguished delegates, guests, good afternoon to you all. One of the structural challenges that perhaps was not sufficiently visible and could not be seen or felt during the COVID-19 crisis was the growing burden of mental health in the Americas. In order to tackle the challenges and develop different approaches that are appropriate and focused on mental health to guide the countries in the region, the Pan American Health Organization has created a strategic group of leads of humanitarian, social, and political organizations who are experts representing different organizations and entities, and people with experiences in mental health throughout the Americas in order to be part of the high-level committee on mental health and COVID-19 in the region. It has been my pleasure, and I was honored to be the chair of this committee with Ambassador Nestor Mendez Assistant Secretary General of the OAS, in order to guide these different working groups with different goals. The first is to provide advice to PAHO as to the appropriate institutional responses to tackle mental health throughout the region in order to respond to the challenges and impacts of the COVID-19 pandemic on mental health and provide guidance to prioritize mental health during and after the pandemic. The second goal was to formulate recommendations to support member states to strengthen their approaches and policies and to build a better mental health systems in the post-pandemic period. The third goal was to generate a report with key recommendations to improve mental health in the Americas from a holistic perspective to guarantee well-being to all of us who live in this region. Today, these three fundamental areas to improve mental health for our people and in our committee have become our priority. Firstly, because it is necessary to ensure promotion of mental health in all policies. This means understand that mental health is fundamental for enjoyment of rights. It is necessary to position the commitment of states to achieve health coverage that is both universal and addresses the human rights of all people, including mental health in all policies. Two, we believe, and PAHO also considered, that it is necessary to promote key actions to forge strategic partnerships for mental health. We need to connect the mental health agenda with different ministries, with the private sector, in order to ensure not only an interagency vision, but also intersectoral. We are committed to ensure that addressing mental health becomes an essential component of the health commitment and services offered by governments and states to their citizens. And third, we believe it is very important, and this can be seen as one of the goals of the committee, to have key actions to increase the budget for health in general, but for mental health in particular. This is a fundamental target in order to ensure there is coverage and access, but also treatment with modern approaches, telemedicine, and all these different forms that truly make it possible to reach out to all individuals who have been affected and whose mental health has suffered because of COVID-19. We need to be united. We understand that governments and public institutions, private organizations, health professionals, social organizations, communities, men, women, youth, children, adolescents, we all need to work together so that in the Americas, we can take strides to become a region with emotional well-being and mental health. We do understand that there are groups of people who have been particularly afflicted due to COVID-19, and in particular, their mental health. We're talking here about women, about Afro-descendants and indigenous peoples. We're talking about those who, given their inequalities prior to the pandemic, today face worse conditions to achieve full mental health. I'm deeply grateful for the invitation to address this conference. I do believe it's an extraordinary opportunity to contribute to the process to deliver a strong recommendation with key components that will allow us to move forward in achieving mental health for all the people living in this hemisphere. Thank you very much.
Thank you so much, Vice President. And we've been very honored to have her lead PAHO's first Commission of Mental Health, guided by a vision of equity. And also wish to acknowledge Ambassador Nesta Mendez here on my left, who is the co-chair. So this concludes our first panel, and our second panel will address mental health and the COVID-19 pandemic and beyond, applying lessons learned from COVID-19 for transformative change. And I would now like to ask Dr. Renato Oliveira, Chief of the Mental Health and Substance Use Unit, to open this panel with a regional overview. Over to you.
Thank you very much, Dr. Hennis. Good afternoon. I'm Renato Oliveira, Chief of Mental Health and Substance Use Unit at the Pan American Health Organization. Next one, please. Mental, neurological, and substance use conditions, as well as suicide, account for more than a third of years lived with disability in our region. Suicide claims the lives of nearly 100,000 people annually, and the regional suicide rate increased by 17% in the last 20 years. However, the large majority of people in need do not receive treatment. Furthermore, mental health services in many countries in our region continue to be concentrated in long-stay institutions where services and treatments tend to be not in line with international standards. Next one, please. The COVID-19 pandemic has exacerbated an already critical mental health situation in our region, with countries reporting highly elevated rates of mental health symptoms. Furthermore, COVID-19 has led to major disruptions in already weak mental health services. Next. It's crucial that while we address increased mental health needs during COVID-19, we simultaneously prepare for anticipated future threats to mental health by building back better mental health systems and services. In its World Mental Health Report, launched earlier this year, the World Health Organization named 4 key threats to global mental health that we must address: economic and social inequalities, public health emergencies, humanitarian emergencies, and the climate crisis. All of them deteriorate populations' mental health. Next one, please. What have we learned from COVID-19? Some of the key lessons learned include that emergencies are critical opportunities for mental health reform as they increase visibility for mental health. That mental health must be a cross-cutting issue in emergency preparedness and response. This means that national disaster and emergency plans must include mental health among other efforts. That a whole of society approach is essential. Mental health is influenced by a variety of social economic factors, which call for the participation of diverse actors across ministries and agencies, NGOs, academia, civil society, and people with lived experience of mental health conditions. And that political buy-in at the highest level can help to catalyze change. We must go beyond the health sector and work with high-level decision makers to achieve significant change. Next one, please. And what is the way forward? To build back better mental health, we must urgently work towards universal mental health with resilient and agile systems. We must invest finance and human resources in mental health policies and programs and in capacity building needed to strengthen mental health services and leave no one behind. We must also increase political will and engagement and build multi-sectoral partnerships and enclose those with lived experiences at the table. And last but not least, it's key to strengthen mental health preparedness and response for emergencies and crises, including the impacts of climate change. Next one, please. The new proposed PAHO regional mental health policy builds upon those lessons learned and provide a vision for a better future.
Our panelists will continue to share with you some examples of how to advance mental health in our region. Thank you very much for joining us today.
Thank you so much, Dr. Oliveira. I'll now give the floor to the Honorable Minister of Health and Wellness of Barbados, Mr. Ian Gooding-Edgell. Thank you, Honorable Minister.
Thank you very much, Mr. Chairman. Good afternoon, Dr. Tedros Ghebreyesus, other distinguished members of the panel, colleague ministers of health, distinguished delegates. Thank you for giving me this opportunity to share a small island perspective on climate change and mental health. I believe we have a golden opportunity to address a public health matter that is critical to our lives and livelihood. Our brothers and sisters in Dominica, Antigua and Barbuda, and the Bahamas can attest to the devastating consequences of the extreme weather on health of the population. Much of the health infrastructure was devastated, with hospital and primary care facilities being greatly impacted. Many people with hypertension and diabetes were without medication and support for the healthcare team for weeks and even months. There were several reports of psychological harm with increased incidence of mental illness. There's no doubt that global warming is one of the most important issues that we have to address as a country, as a region, and as a planet. In September of 2019, Prime Minister, the Honorable Mia Moore-Motley of Barbados, challenged the United Nations on the topic of climate change. She made it clear that beyond the science and evidence, the impacts on everyday existence in terms of loss of life and livelihood are real. Threats to health from a warmer world means more disease, famine, internal and external displacement of people, early death from natural disasters such as fire and heat waves, and more major mental health problems. If we do not act swiftly and appropriately, everyone will be affected. What is heart-wrenching is that the most vulnerable, children, the elderly, the ill, the poor, will be most severely affected. We live in very uncertain time, but we are aware climate change is real, not only affecting our fragile argo-based and tourism-based economies of the region, but affecting individuals, their families, and communities on a very personal level. Every hurricane season for the last 10 years was an active or more active than the previous year. Heat waves are becoming more common, and flooding, flash floods, and droughts are very commonplace. People across the region are becoming increasingly worried about climate change, with anxiety, depression, post-traumatic stress disorders, and climate change trauma becoming increasingly more prevalent. There's also documented evidence of increased substance and alcohol abuse. I'm also aware that certain population groups may be more vulnerable, and these include migrants, refugees, the very young, and the very old and chronically ill. After a natural disaster, there may be displacement of people and livelihood, limited employment opportunities, worsening of control of NCDs, and increased risks of disabilities and ill health. All these add to the mental health and psychological stresses at the individual level. I'm proposing that in each member state, a dialogue and safe space to be provided for communities and individuals to talk and to share about how climate change and health affect their lives. This will provide an opportunity for communities to take action through small steps by engaging public health and environmental leadership. This can also be initially achieved by personal efforts to reduce. Hold on 1 second. Sorry, my screen. Carbon footprint and advocating governments to achieve more evidence-based results. An example of such is the beach cleanup activity sponsored by many like-minded non-governmental health organizations, which have the benefits of increased physical activity and exercise while contributing to a cleaner, greener, and safer environment. The Ministry of Health and Wellness is in the process of establishing a national climate change and health focal point unit. One of the unit's first tasks will be to develop and implement a framework for comprehensive vulnerability assessment. Barbados was fortunate to benefit from several trainer of trainers workshops hosted by the Pan American Health Organization, which address mental health in the immediate and long term after a natural disaster. These workshops gave insight and training on psychological emergencies post-disaster. I believe this workshop can be extended to all first responders in the post-disaster period, as early recognition of those most at risk can go a long way to reducing psychological and mental harm in the future. I encourage PAHO to continue to extend this training and awareness to our defense force, police force, and public health service providers. As Barbados develops a national mental health policy and action plan, I will strongly support the broader use of mental health and psychological training in climate change and disaster management. There's also a need for collaboration with PAHO and other agencies, such as the Caribbean Community Climate Change Center and the University of the West Indies on a research agenda. The more we understand about the current and expected impacts and the measures that we can take, the better position we will be able to make more informed decisions. In closing, let me thank the conveners for hosting this side event, and I do hope my intervention stimulates much discussion. I thank you.
Yeah, thank you so much, Minister Gooding-Edgell. And as we can see, climate change is one of the silently growing threats to mental health in the Americas. And therefore, we have a responsibility to act, to develop policies for emergency preparedness and response, and to build resilient mental health systems and services. It is my pleasure to present Senor Jose Martin Yaqui, Director of the Asociación IDEI in Guatemala.
Has the floor. Good afternoon. Warm greetings from my country, Guatemala. It's a pleasure to see our authorities here. It's a pleasure to be here in Washington, D.C., where many of our fellow citizens hope to come, but unfortunately, many of them are here illegally because of a lack of opportunities allowing us to continue to build together. I am the director of Asociación IDEI. We have been working 28 years with the indigenous populations of Guatemala. We work on the highland in the country, and we are in 16 different indigenous communities of the Maya people. I wanted to begin with the next slide. I'll provide you with some context on my country. In Guatemala, we have 25 different cultures. The Maya people has 22 linguistic communities with 22 ways of viewing the world, understanding health and understanding development. We also have the Guarifana, Xinca, and Mestizo population, which makes us a multicultural and multi-ethnic culture. We have the Ministry of Health, and the ministry has been working with us to develop intercultural models that are relevant to make health truly a right. This map that you have here on the screen shows you the distribution of our indigenous peoples. In red, we have the indigenous population, the Maya people, and you can see that they cover more than 80% of the area in the country. In white, we have the Xinca Mestizo population, and in one corner, the Garifuna population, and then in another color, we see the Maya biosphere, that in green. Now, we are a culture that has been around for thousands of years. We have a health system and a way of understanding development and life based on the cosmos, the land, and also the netherworld. In addition to acknowledging the work that we are doing jointly with organizations that are part of the country, Guatemala, I wanted to recognize the work we have done with PAHO. In 2021, during the time of COVID, we worked on this model. It is an intercultural model to work with indigenous populations. We did this in 2 territories, in the Maya and Xil, as well as in the Mam population in San Marcos, in a specific area of Guatemala. Our intervention was aiming at supporting the dialogue that was occurring on mental health and the importance thereof amongst healthcare providers, the ancestral community, the Mayas, and also the healthcare workers from the Ministry of Health. We had to design a holistic intercultural methodology, and that led us to recognize an intercultural methodology. And for us as an institution, we learned that to be able to intervene in indigenous territories, first of all, you have to define a methodology that respects the peoples. The state of Guatemala has ratified the ILO Agreement 167 that recognizes indigenous rights and everything having to do with human beings and the indigenous population. But also we had to define our scientific intervention. And there we focused on the psychosocial part of the behavioral sciences, looking at clinical and psychosocial sciences. But we had to see that the ancestral knowledge of the Maya people had a relationship that would place us in the Western approach to the life of peoples. And we decided to use the ancestral knowledge called Kawawil. The Kawawil was part of the Maya cosmovision, like the dual spirit that we people have to understand and to deal with the world. Kawawil is an epistemological term that helps us have a definition that is based on a territory or a unit. Now, Popol Vuh says that we are the results of consensus. We are the product of a consensus between the creators and the formers. So we have the 4 cardinal points. That is where the sun rises, the sun sets. Also, we have a relationship with the land and air, and he is giving the indigenous terms, and also the heart, the water. This has given us location within Kawawil, where we are part of the double vision. In other words, we can look at the present and at the future. So we have 2 faces. And when we would engage in this exercise with the indigenous communities, we would raise the importance of mental health. In the indigenous communities, we have our feelings that have been hurt. That is what our Western psychology tells us because of the many years of armed conflict. And also some places there is a lot of a shortage in terms of primary health care coverage. So these are gaps that later turn into problems related to health. We have high pregnancy rates for young people. Also, we have sexually transmitted diseases. We have suicide in the communities, HIV, AIDS, in the Maya, Mam, and Chiquirichapa. Some 10 years ago, 30 girls committed suicide in a 6-month period. And a study was done to understand the cause. Why did they commit suicide? And the factors. Well, first of all, they said that they were committing suicide because of a lack of love, because they were children of migrants. Their fathers had migrated to the United States, so they felt a lack of love in their homes.
Also, they had a lack of information in terms of their future. Their own sexuality was also an important factor. And also, they talked about problems associated with the maras, with the criminal gangs in their communities. So that led us to this exercise that here you can see how ancestral knowledge helped us approach this dialogue, talking about the SMAP, different approaches to mental health, and the technique that is being developed by PAHO with us, which is the MHPOP, that helps us create community opportunities to work with these communities. We reached a point of convergence as part of this project that we were implementing jointly with PAHO, and we saw how changes of thought patterns, the behavioral components, our interpretation of context, all of this within the approach related to mental health, we found that cultural connection. Now, how did we include the Maya knowledge? We would include a reading of the Nahuales. Now, on the Maya calendar, we have the Hefker from Nahual, and that is one of the power Nahuals. And those born under those Nahuales will be the future authorities. That's what the Maya people think because of their ancestral knowledge. So in this time, the ancestors, the powerful people are being born. So in that way, people can use the energy that comes from their Nahual, and that allows us to help them change the objective of their life. And all of this done by using their culture and the power of words. When you go to a healthcare service unit, it is hard for a doctor or a person to treat the person in his or her own language. But if you can do that, if the physician can be addressed in his own language, we have a saying, how is your heart? How is your face? So this helps open up an interaction with people, and we can see that the mentality, the way of thinking of these people changes. And this has been very helpful with this methodology so that we can get the populations to find their destination, their future in Nahual. We call it your star or your future. And we say, you are valuable. You can be the future president of the country. So we can see that despite the effects of COVID, and COVID did cause an impact on these people, so there they feel that their heart has been hurt because of past conflicts, or now the food they eat, climate change. Often there is a lack of opportunities to go to school or to find a job or to exercise their sexuality. That is the relevant data that we have. Finding this light at the end of the tunnel, using the Nahuales, all of that, along with cognitive and behavioral sciences, we are helping change the health of these communities. So that was a very valuable exercise that we carried out with PAHO. So it is important to point out that to have a mental health approach, we have to have a territorial approach. And there with the Maya people, we have to do an individual interpretation, but also we have to intervene at the family and community levels too, because we have seen that if a person is okay, it's because his family and his community is okay. And it's because the area where he or she lives is okay. So it is important, and that is something that COVID-19 showed us. If the community, if the area where the person lives, if the family is, if all of them are okay,
that means that the person feels that things are better than if he or she feels that he has been abandoned or he's alone. So the SMAPS program that we developed with PAHO allowed us to use this territorial approach. And in the territories, we set up permanent operators. They are available 24 hours a day, and they are from Chiles and Maya communities. We taught them first aid so that they can be those healthcare operators using ancestral health techniques, so they can provide support to these desperate communities. They cannot find an answer. They don't know how to grapple with COVID or the post-COVID circumstances. Also, mortality rates were very high in Guatemala. We have the returnees, the people that were intercepted in Mexico, or people that are returned to the country. We're getting more than 100 people back twice a week. We're getting unaccompanied children. So those are the effects that we have to deal with. So all of this has been a palliative, and we can say, your Nawal says that you could be the next mayor. Why do you want to leave? You have to stay here and help build a sense of community. So there we have combined the effect of the Nahuales with the effects of healthcare for mental health. So all of this has allowed us to build agreements. All of us are called upon to deal with health, as we already said in this meeting, because health is the convergence of community action, territorial action. And for us, that is the relevance of the approach. And the important thing is not only using Western models, but also finding amongst these communities ancestral knowledge based on quantitative, qualitative measurements. But what we leave subjectively in the communities is the most valuable thing for a project or an intervention. We can think not only of interventions, we have to think of lives. In the Maya people, we talk about a three-dimensional structure. If your heart is okay, your mind is okay, and your soul is okay. And that is what we call good living. And good living is complemented with nature, with air, with water, with the cosmos, because we are holistically a complementary product of these community dynamics. That is why it's so important to understand ancestral knowledge. And also, this has to do, for example, with the grandmothers that are midwives. They never went to school, but they do know how to deliver a baby. They know how to support a life. More than 40%, to the data we have in Guatemala during COVID, those deliveries were supported by midwifery. So in Guatemala, when people come to a healthcare service, we ask them to draw what they did before they came to the healthcare unit. And they always say they went to the midwife, they went to the Maya leader. Sometimes they go to talk to a priest or to a religious leader, and they put Western health last. So we don't have complete trust yet. So that's a challenge. And the challenge is to have a territorial approach and work based on goodwill, making certain that our healthcare system be the summation of all of our efforts. Now, definitely we need to extend coverage of mental health. We want to reach all levels where institutions are needed. That is why we have suggested that academia, that the ministry engage in scientific action, supported by curricular programs to train health professionals. We're working with indigenous communities and also with PAHO Guatemala to create guidelines for healthcare workers to discuss what pluriculturality is, how we can have multidisciplinary, multicultural efforts. The idea is to continue to contribute to the healthcare system
so as to have an intervention that is intercultural in the country by creating opportunities that favor our people and to heal their hearts. We know that we can heal through the cosmovision, through the use of fire, by respecting the Nahuales. And I conclude by saying creation continues. Popol Vuh says that the first creators thought of humanity to build a good life. And that is something that we are all part of. Thank you.
So, Senor Yak, thank you so much for that very novel perspective on mental health in indigenous communities in Guatemala. So now I'm going to me gustaría ahora pasar la palabra.
I now give the floor to Jimena Aguilera Sanhuesa, Minister of Health of Chile. Thank you very much. Thank you for this invitation. I'm glad to be here to share with you our experience and the challenges that we face because of COVID-19. And also, I wanted to say how much I enjoyed the presentation we just heard from Mr. Yak. He was reminding us of our need to deal with mental health. Now, I wanted to say something about the tremendous healthcare burden that exists and how the situation was made worse by the pandemic for the general population and for populations that are already in a special position because they have some sort of mental pathology. Our president, Gabriel Boric, is really a champion of mental health. He has said that mental health cannot wait and that it will be a priority of our government. He has laid out specific objectives for government plans during his term of office, saying that never again will these people be alone in dealing with their mental health needs. The state will take its responsibility by implementing policies that can support people collectively when required. I was asked during my presentation to focus on two priority aspects, one having to do with strengthening the human rights approach to mental health, seeing mental health as part of human rights, and also to talk about technological solutions to increase access to mental health care. Now, here we can move on to the next slide. The next one, please. I'm sorry, the presentation. I'm sorry that I have so many slides, but I'm sorry for having to say next. But in Chile, in 2021, a law was passed to recognize and to protect the fundamental rights of persons as part of their mental health. And because of the pandemic, it has been hard to fully implement this law. And we still have a very broad-based mental health law that allows us to move ahead on all of these rights. But this year, we have given priority to this issue, in part because of the decided backing of the president. And also we expanded these guarantees to other areas that pertain to rights, especially mental health. Now, this is part of President Boric's platform, and it targets developing a comprehensive law on mental health. In June of 2022, a special mental health strategy was established, and that was an initiative to collaborate in the short term and to move ahead in terms of protection of rights. Here you can see the overall objective of this special strategy, which is to guarantee the protection of fundamental rights of persons in the exercise of sectoral actions in mental health, with special emphasis on psychiatric hospitalization. That is something that was mentioned by other panelists, incorporating into this process experts with experience and users, civil society, healthcare workers, academia, scientific societies. That is something that was mentioned by Canada and Argentina. They talked about participatory approaches Now, this strategy has a technical work group with the participation of different national and international organizations, including the Office of the High Commissioner for Human Rights from the UN, and also representatives from PAHO, the ministry, and other agencies of the state, so as to have a cross-cutting approach involving different sectors. So this is not only under the health sector. There are 3 different subcommissions to move ahead with deinstitutionalization and also the protection of boys, girls, and adolescents in terms of care provided by the state, with participation of stakeholders represented in the working group. There are commitments of that working group that are short-term to establish regulations for psychiatric hospitalization, also to develop technical standards for electroconvulsive therapy, to have a protocol in terms of violation of rights in the context of mental health care, to establish the psychiatric hospitalization regulations, and also we have a regional commission to protect the rights of people with mental health. Correpaprem. So the idea is to update what we're doing while protecting the rights of people in the connection of mental health. Also, there are a national plan for disinstitutionalization of persons with psychosocial disabilities, and there is a comprehensive law on mental health. So here we are dealing with the gaps that we have observed for years. We need to protect vulnerable populations. For example, the rights of children that are under the care of the state. And we have to respond to each of these challenges as quickly and in as comprehensive a way as possible.
With regards to technological solutions to provide access to mental health, during the COVID pandemic in Chile, as elsewhere, there were consequences and impacts on social services and health services. These were interrupted and affected, and there's also been a change of people who were already under control. In order to tackle this gap, and starting in February 2020, a mental health line was established with psychologists in the digital hospital of the health ministry, and they started working remotely. Soon there was a model for the population, universal access 24/7, including hotlines and specific means provided to health workers who were also carrying a very major burden. And we're still experiencing this. There's a lot of absenteeism due to the mental health burden imposed on the workers by the pandemic. During the pandemic, the model included sessions with trained psychologists in order to provide an approach based on needs and to be able to refer them to the appropriate territorial health center or to channel them through the strategy of providing support via telemedicine. In other words, there was a strengthening of remote care using telemedicine. And I believe this has really been promoted by the pandemic. It ought to be deepened after the emergency because the strategy of access to digital hospitals and telemedicine allows us to cover areas where before we encountered problems in order to provide universal health care. The model of care during the pandemic showed a requirement of care remotely. The users were selected, then they receive first assistance, then they are referred. In the post-pandemic, we hope to continue with clinical remote care, focusing in particular on the healthcare workers' mental health and to provide free service to all healthcare workers and be able to at least cover the first level of care, followed by psychological support in order to ensure recovery from the emergency. There is also the proposal of remote care for suicide, especially among children and adolescents who are under state care. This is a priority area. There's been an increase in suicide among young people in recent years. These children and adolescents who receive state care are a priority and are the focus of government actions right now. The resources are already committed in order to ensure coverage and guarantee a timely response as well as integrity of response to these particularly vulnerable groups. Lastly, and with regard to the projections and challenges for public health in Chile, I had mentioned that there are explicit priorities for the government. They're on this slide: to increase the budget, to promote the law, improve the quality and coverage throughout the network, create 50 centers minimum in each of the regions of the country, continue with mobile equipment and community level care also, propose support for the independent life of people with psychosocial disability. This includes people living with dementia and having a gender-focused care, train community agents, develop education and awareness campaigns to reduce stigma, and strengthen the Chile Grows With You network that takes care of people from the pregnancy to early childhood and has been expanding in order to incorporate health aspects in all public policy, especially in the first years. For this, it's necessary to have a mental health training program for health workers in order to ensure mental health is provided at all levels. Chile has a broad network with good coverage of primary healthcare units. They are already working for and have been for several years working on mental health, but those resources will be further boosted and will receive training. There's also particular concern to strengthen mental health care for LGBTIQ plus people, recognizing the special needs of this group being a priority group for public policy. The presentation, as we heard from the director of IDEI in Guatemala, we also have another challenge, which is to approach the intercultural aspect, which is also important in my country. So I share that comment that we heard from Guatemala. Thank you very much.
Thank you so much, Dr. Jimena Aguilera Sanhuesa. Very much appreciated. We're down to the last few minutes, and Dr. Tedros has kindly agreed to share a few ideas with us before we hand over to His Excellency Ambassador Nestor Mendez to close the session for us. So, Dr. Tedros.
Thank you. Apologies, I couldn't even sit in this chair because the AC above me is so difficult. And my hair is so it's so irritating, and I had to sit back, and once I had to leave the room actually. So I don't know, maybe the hotel should help you but because other colleagues here were also complaining, starting from Minister Carla. One, thank you so much for organizing this side event. Mental health should be at the top of our agenda. As you know, before even the pandemic, mental health challenges were serious. The magnitude of the problem was very serious. But our attention was really low. Now, with COVID and its impact, if there was one area that was seriously impacted is mental health, because millions have lost their jobs, have been isolated for a long time, lost their loved ones. And not only that, the other news have not been good either. Conflict, climate change impact actually becoming very palpable now. And because of all these challenges, I think the magnitude of mental health problem is now even more than it used to be. So thank you for organizing this side event. But what I understand and what we understand as WHO is the fight, I think, has to be maintained. I mean, we need to make sure that it's a constant agenda and that we constantly invest in it, and it's always taken really seriously. With all the stigma and, anyway, you have said it well. Thank you, by the way, for the excellent interventions. It will be very difficult still to push it forward. It will not be easy. But I think as WHO, we have to keep it visible and we have to talk about it daily. And we have to also invest and we have to mobilize our political leaders to lead on this. So with that, thank you so much again. I'm glad I joined you, except the irritation from here. So after saying this, I need to go back and sit behind because thank you. Thank you very much.
So Dr. Tedros, thanks so much for highlighting the importance and the need to have high visibility and action for mental health. So I really wish to thank all of our esteemed speakers and panelists today. And to conclude this session, I present Ambassador Nestor Mendez, the Assistant Secretary General of the Organization of American States and the co-chair of the Pan American Health Organization High-Level Commission on Mental Health and COVID-19 to deliver the closing remarks. Over to you, Your Excellency.
Thank you very much. Good afternoon, everyone. Dr. Tedros Adhanom, Director General of the World Health Organization, Dr. Carissa Etienne, Director of the Pan American Health Organization, Honorable Ministers and Secretaries of Health, Her Excellency Epsi Campbell, former Vice President of Costa Rica, distinguished ambassadors, delegates, colleagues, and esteemed guests. It's truly a pleasure to be here this afternoon and to see so many familiar faces and dear friends. I am honored to close this session and to thank you for your participation in this side event, leveraging lessons learned from the COVID-19 pandemic to address the region's mental health challenges for the future. I would like to extend a very special thank you to our distinguished speakers and panelists who have all shared outstanding insights and best practices and lessons learned from the pandemic as we strive to recover from this difficult period and build back better mental health. The COVID-19 pandemic continues to test us as a region with its catastrophic impacts on the health of populations, as well as on the social and economic well-being of our countries. The collective experience of the pandemic, the trauma it left, has exacerbated ongoing mental health challenges faced by our region, characterized already by a chronic mental health treatment gap, where only a small fraction of those requiring care actually receive it. While we long for a return to normalcy coming out of the COVID-19 pandemic, we must not accept a business as usual approach about mental health. A dismissive attitude will fail to guarantee each individual his or her fundamental right to mental health and deprive them of the opportunity to achieve their full potential. Furthermore, our communities will be left vulnerable to ongoing threats to mental health, such as future pandemics, socioeconomic upheaval, and most notably, climate change. It must therefore be our collective priority to ensure a future with optimal mental health in our region. This will require, among other things, expanding access to mental health for all as an integral part of universal access and universal health coverage, eliminating inequities in mental health so that no one is left behind, ending stigma and discrimination associated with mental health conditions, which prevents so many from seeking and receiving support. These goals will require significant political will as well as commitment from all sectors of government and all partners in society, including the private sector. Scaled up financial investments, multi-sectoral engagement, and supportive partnerships, and a vision to transform mental health in the region. Everyone has a role to play in this pressing undertaking. The responsibility is therefore in our hands as regional leaders. Achieving what we envisage will require that mental health is integrated into all policies and is elevated and expanded beyond the health sector. I wish to once again underscore the quote from Dr. Brock Chisholm mentioned earlier by the distinguished ministers of health of Canada and Argentina, that without mental health, there can be no health. As co-chair of the PAHO High-Level Commission on Mental Health and COVID-19, I echo Dr. Carissa Etienne's call to action and to use the opportunity to rebuild from the COVID-19 pandemic to strengthen and improve mental health. I also take this opportunity to reaffirm our commitment at the Organization of American States to support the work of the Commission and of PAHO to bring mental health to the forefront of our regional agenda. Our people deserve no less. Thank you.
Thank you so much for everyone for attending. We really appreciate your presence. And again, thanks to all the presenters and panelists. And again, to Dr. Tedros for gracing us with your presence. Thank you.
Muy buenas tardes, muy boa tarde a todos. Very good afternoon. Can I kindly ask your help, contribution here to take your seat so we can check the quorum and the conference can reconvene. If you could please take your seat. Thank you. Can I kindly ask you to take your seats so we can check the quorum to restart? Se les puedo pedir su ayuda para que por favor tomen asiento. Estamos esperando o quórum para empezar. Me hacen extrañar el virtual.
You're making me miss virtual meetings.
Éramos mucho más puntuales.
We were
con el virtual.
a lot more punctual.
Okay. Seventeen and counting. 17, 18. Necesitamos 22.
We need 22 and we're at 17 or 18.
19.
Okay, I see 19.
Casi. Chamem sus colegas,
We're
por
getting
favor.
close. Please call in your colleagues.
Muy bien. 20. Ok. A ver. Você já tinha Brasil? 21 com Brasil sentado.
21 with Brazil taking his seat. And 22, I think. Nicaragua. Thank you. I'm sorry. I can't see the people coming in. Thank you. We do have a quorum. We can begin.
Well, thank you very much and good afternoon to everyone. We'll resume with the topic policy for improving mental health, document CSP 30/9. When we took a break, we have the next speaker, Chile. So I'll yield the floor to the distinguished delegate from Chile to make intervention.
Muchas gracias.
Thank you very much, Mr. President. Chile shares the diagnosis of the current situation of mental health in the region, the world, recognizing the impact caused by the COVID-19 pandemic in the general population, and especially affecting populations with other mental health problems, and also affecting healthcare workers. In that connection, the country supports this call to action at the national level in healthcare services and for intersectoral collaboration, but also regional and international collaboration to work towards the recovery by improving the services rendered by mental health services. Chile celebrates the policy for improving mental health as proposed, and we look forward to this being a joint effort. President Bodic's administration has defined mental health as a working priority and has entered into specific commitments. This is something that had never been done in the last 50 years. That is a priority for the Ministry of Health to consistently and implement this system with determination. In that way, we can make progress. We can increase the budgeting going to mental health and closing the current financing gaps. Also promoting a integrated health law, implementing new teams, new programs, both in terms of outpatient service as well as primary health care to provide better care to the needs of those having mental health problems and establishing interministerial commitments on all policies to improve the living conditions for the people living in the country. Chile has established as priority lines of action immediate progress in protecting the rights of persons with mental health problems or with psychosocial vulnerabilities, especially those that use residential services in monovalent or psychiatric hospitals, and children or adolescents who live in hospitals that are under the care of the state. It is a priority to prevent suicide and improve the integrated response of the network for persons with Alzheimer's or other cases of dementia. Also, as specific actions, we have recovering from the consequences of the pandemic on mental health and the purpose of rebuilding our systems and services, giving them greater resilience. We hope to be able to share our results and our experiences with the region. Chile expresses its appreciation for the support received from WHO and PAHO and other member states. And also, Chile is willing to collaborate in terms of developments that could be well received. So Chile supports this resolution and agrees with it in its entirety. Thank you very much.
Distinguished delegate from Chile. The next three speakers will be Paraguay, St. Lucia, and Barbados. I now yield the floor to the distinguished delegate from Paraguay.
Thank you very much, Mr. President. Paraguay appreciates the efforts that have been made to prepare this document. The document will become a tool and it will reinforce the national legal framework. My country is mindful of the major challenge represented by reforming the mental health services framework. So we have implemented initiatives so as to transform this care in a model that is community-based with the aim of giving better access to quality services in this area. So here, we welcome the fact that this document includes strengthening leadership, governance, and multi-sectoral partnerships. And the document calls for integrating mental health and making it part of all national policies, incorporating the human rights approach, as well as multiculturality, and also including the use of psychoactive substances. This policy will facilitate the technical administrative work of the mental health services as the entities responsible for mental health in Paraguay. And it can be implemented by taking action that focuses on integrated action that's focused on the person, including providing affordable medication, amongst other initiatives. So my delegation supports this proposed resolution that is contained in document CSP 30/9. Thank you very much, Mr. President.
I thank the distinguished delegate from Paraguay for his intervention. The next three speakers will be St. Lucia, Barbados, Bahamas. I now yield the floor to the distinguished delegate from St. Lucia.
Thank you, Chair. St. Lucia has reviewed the information and supports the strategy provided in the policy document, Policy for Improving Mental Health. Mental health conditions were further exacerbated by the COVID-19 pandemic, as we all know, as the various measures used to reduce the spread of the disease affected the normal socialization within communities. The economic losses also contributed to mental health issues, we are yet to quantify the impact on children and adolescents. The mental health conditions of healthcare and frontline workers were also noted during the COVID-19 pandemic. St. Lucia, like the rest of the region, notes the shortage of human resources in relation to mental health. We also note the urgency and importance of addressing this critical public health issue, as it is linked to premature mortality from chronic non-communicable diseases, such as diabetes, cardiovascular diseases, and cancer. We support the strategic lines of action that include building leadership and multi-sectoral partnerships, improving the availability, accessibility, and quality of community-based services for mental health, advancing promotion and prevention strategies, and strengthening data, evidence, and research. I would like to acknowledge and thank PAHO for the support provided to St. Lucia in strengthening the mental health through the MHGAP training and community toolkits. This program has facilitated training of the community healthcare workers, managers, and community leaders in St. Lucia, giving them the capacity to expand their skills and abilities, to identify the needs of the local population, and train community service providers in community mental health interventions to respond to these needs. This aims to reduce the existing gap between the needs of the population and the existing resources. We support the strategies outlined in the document, and with the technical support from PAHO, we'll continue to work to improve the services provided to mental health patients. Thank you, Chair.
Thank you, the distinguished delegate from St. Lucia. The next three speakers will be Barbados, Bahamas, and the United States of America. I yield the floor to the distinguished delegate from Barbados.
Thank you, Mr. Chairman. Colleague ministers, excellencies, delegates, distinguished ladies and gentlemen. Let me begin by thanking the Director General for sharing the policy for improving mental health. Barbados supports the call to promote community-based mental health care to address the heightened demand for mental health and substance use services brought on by the COVID-19 pandemic, and to build stronger and more resilient mental health systems for the post-pandemic period. The Ministry of Health and Wellness will strengthen its partnerships with governmental and non-governmental organizations that provide education and training in substance abuse, as well as those that provide outpatient and residential substance use treatment services. The Ministry of Health and Wellness undertakes discussions and partners with civil society on mental health matters through the Mental Health Commission. Barbados has an already active community-based mental health system, which we will enhance by the increased training of primary care physicians in recognizing and treating non-complicated mental health cases. There will also be a drive to promote the use of these services by developing further strategies to decrease fear and stigma, which exists in some parts of the community regarding mental health conditions and their treatment. While the suicide rate in Barbados is low compared to the global rate stated in the PAHO report, we believe that this may be due to underreporting. A proposal has been written as regards the setting up of a suicide telephone hotline for Barbados. And we believe that any case of suicide is a distressing and traumatic event for the family and friends of the victim and the society at large. Suicide reduction strategies are considered important. Given the high and increasing burden of mental illness, it is essential that member states and PAHO continue to work towards advancing mental health in the region. We are grateful for PAHO's support in the development of the new Barbados Mental Health Policy and Plan, which were last published in 2004 and 2005, respectively. Mr. Chairman, I thank you.
Thank you, distinguished delegate from Barbados. The next three speakers will be Bahamas, United States of America, and Honduras. I yield the floor to the distinguished delegate from the Bahamas.
Thank you, Mr. President. Mr. President, as has occurred globally, mental health concerns and awareness has taken center stage in the Bahamas' health agenda during the past 5 years. As such, we are pleased with the efforts that have been undertaken to assist member states in advancing this policy. What is most appreciated is the approach taken by PAHO in not advancing another plan of action during this time. Rather, it acknowledged that there remains ongoing unfinished works and progress being made by member states that may be disparate and difficult to characterize in a one-size-fits-all approach. This policy for improving mental health seeks to encourage and support member states where they are along the continuum. And we commend PAHO for taking this particular approach, as it does not require member states to pivot from the progress that they have made in their particular countries in any one area towards safeguarding the mental health of its residents. Mr. President, in the Bahamas, there are several activities that we are seeking to pursue over the next several years. A mental health bill 2022 is expected to be debated this month. This new bill will replace a mental health act that is more than 50 years old and is aligned with the Convention on the Rights of Persons with Disabilities. The Bahamas has also completed standards and guidelines for substance use facilities and are in the final stages in implementing same in the existing treatment centers. Mr. President, the Bahamas has partially implemented the Mental Health Gap Action Plan, noting undeniable success in increasing access to mental services and expertise in our most rural populations. We are presently seeking then to expand the service in our urban settings to meet the need uncovered by Hurricane Dorian and the COVID-19 pandemic. Mr. President, we welcome the continued support of PAHO and encourage the use of this innovative way to ensure that our regional goals are met. We thank you.
Thank you, distinguished delegate from the Bahamas. The next three speakers will be United States of America, Honduras, and Canada. I now yield the floor to the distinguished delegate from the United States of America.
Thank you so much, Mr. Chairman. The United States thanks the Secretariat for developing the draft policy for improving mental health. This policy comes at a critical time, and it is important that member states continue to prioritize mental health and psychosocial support throughout pandemic response and recovery. The COVID-19 pandemic continues to have a profound effect on the availability of mental health and psychosocial support services, especially for LGBTQI+ persons, children and adolescents, older adults, people with disabilities, racial and ethnic minorities, rural and medically underserved areas, and other marginalized populations. Also, we recognize the global impact on health worker burnout and well-being, and the need for increased provision and access of mental health services amongst care providers who are essential to pandemic response and recovery efforts. We must do more to address barriers impacting the availability of mental health and psychosocial support services to reduce mental health disparities and promote equity. And this includes addressing stigma and discrimination. Greater focus is also needed for expanding access to mental health and psychosocial support services delivered via telehealth platforms, telephone, and similar mechanisms. As with physical health, true access requires community-based care as part of a stepped care framework of services. To be cost-effective, this requires delivery of primary mental health services by trained and supported non-mental health professionals with consultation and referral to professional health services as needed. We appreciate the draft policy's emphasis on strengthening data, evidence, and research to inform policy and service delivery. It is crucial to emphasize continued information gathering on the pandemic's effect on mental health and psychosocial support infrastructure, continuity of care, and the support of primary and community mental health and psychosocial support services based on scientific evidence. Lastly, we encourage PAHO and member states to reinforce the integration of mental health and psychosocial support in development contexts. Mental health and psychosocial support are vital to facilitating access to development programming and resources for those with mental health disorders. In closing, Chair, let me just note the pandemic has made clear the need to invest in additional financial and human resources in promoting mental health and to address the deep disparities in mental health outcomes due to inequitable access to behavioral health information, services, treatment, and care. I thank you.
Thank you, distinguished delegate from the United States of America. Next three speakers will be Honduras, Canada, and Guyana. I call upon the distinguished delegate from Guyana to make his intervention. You have the floor.
Honduras. Gracias. Honduras está de acuerdo.
Honduras agrees with the proposed policy for improving mental health. This policy makes it possible to provide support to PAHO member countries in activities of TC so as to improve mental health as a priority to improve social, economic, and health development in the region. Within the context of the COVID-19 pandemic and the period following that pandemic. So this policy also includes a strategy. It lays out strategic lines presented, and we agree with the proposed approach, which is community-based. And also, there is the idea of promoting strategies and activities for both promotion and prevention during the life course. We emphasize the importance of putting special attention into mental health of children and adolescents, because during the pandemic, these age groups were very compromised. It would be very important to promote more research and also to develop action strategies for these specific populations. However, in many of our countries, we still have a medicalized approach or even an institutional approach. So therefore, I would like to ask PAHO to provide us more guidance and more technical cooperation so that we can work on this transition so as to provide this care at the first level of care in community-based services and to make certain that these services can be easier to access, especially because of the mental health burden left by the pandemic. We acknowledge, Madam Director, that the funds provided for mental health are very limited. Also, we have funds from our own budgets, but a strategy to mobilize resources would be important to provide support in this area. Now, regarding the proposed resolution, we have no comments at this point. Thank you.
Thank you, distinguished delegate from Honduras. The next three speakers will be Canada, Guyana, Antigua, and Barbuda. I now yield the floor to the distinguished delegate from Canada.
Thank you, Mr. President. Canada commends PAHO on the important work taking place to improve mental health and well-being of all populations and communities in the Americas. This not only includes development of this critical policy, but also through efforts of the High-Level Commission on Mental Health and COVID-19 and the organization's continued collaboration and coordination with member states in this area. Every public health emergency we have witnessed domestically, regionally, and globally have made clear that addressing mental health and mental illness must go hand in hand with our emergency response efforts. It has also made clear that we will not make meaningful progress without recognizing that poor mental health and illness disproportionately affect populations living in the most vulnerable situations and those facing systemic and structural inequities. That is why, during the 170th Executive Committee, Canada proposed several amendments to the policy document. This included language that further highlights the importance of taking an equity-based approach and highlighting social, environmental, and economic determinants of health, while also encouraging additional global funding in integrated mental health programming and services, and incorporating mental health in universal health coverage, as well as identifying impacts of climate change on the mental health of populations in the region. We thank PAHO for carefully considering these amendments and are pleased to see them reflected in the updated policy. We also thank PAHO for having organized a side event focused on mental health and lessons learned from the pandemic at this year's conference, for which Canada's Minister of Mental Health and Addictions and Chief Public Health Officer were proud to be a part of. Canada remains committed and steadfast in our efforts to support the mental health and well-being of Canadians by treating this issue as a full and equal part of our universal healthcare system. We also remain committed to working with PAHO, member states, and other partners in improving mental health across the region, taking careful consideration of our population's mental, emotional, and spiritual well-being in all public health actions. Thank you.
Thank you, distinguished delegate from Canada. The next three speakers will be Guyana, Antigua, and Barbuda, Colombia. Guyana, now is your real chance.
Yeah, thank you very much, Mr. President. Guyana supports the resolution proposed by PAHO on mental health. We now have a better understanding of mental health disorders and its impact on persons, or social well-being, and of course, the economics of our country. And hence, the urgent need for us to develop programs that can protect our population. Guyana would like to commend everyone who has participated and worked on this resolution and look forward to its implementation. Mr. President, the Guyana National Mental Health Plan 2015-2020 estimates that approximately 10 to 15% of the Guyanese population is affected by a mental health disorder. That would mean close to 78,000 to 114,000 persons would have a mental health illness. And 3 to 5% suffer from a chronic mental health illness. That's approximately 20,000 persons. And in addition to this, in 2019, it was estimated that 32 deaths per 100,000 was caused by suicide. And as if this was not enough, we are now confronted with the challenges posed by COVID-19, which has increased mental health conditions, especially those of depression and anxiety. And of course, we know there's a subset of patients that would have neurological disorders and psychiatric symptoms, which is currently being researched because we don't know all the signs and symptoms of long COVID. So we really welcome this resolution. We think it's timely. And in Guyana, as one way of preparing and fighting against these disorders, or trying to prevent these disorders, we have looked at our legislation. We have updated a 1934 legislation, modernized it, and we now have new modern legislation that focus more on patient rights, deinstitutionalizing our hospital, having more community care. We have also recently worked on a new legislation dealing with suicide prevention with the help of PAHO. We have been able to lay that now in our parliament. We're currently working on a new policy for mental health in Guyana. And that new strategy would also focus on developing more community programs. And then, of course, we want to make sure that we can have better access to service. So we've been training more people in the area of mental health, including psychiatrists, primary healthcare doctors that we've been training so that they can better detect depression in primary healthcare. So there are a number of strategies that we have started, and we are also interested in making sure that we have research evidence. And so we have been working with a number of academic institutions, and we have right now 3 NIH grants that we are using to study various types of mental health illnesses in Guyana. Those research programs are being headed by Columbia University and a WHO collaborating center. As you know, they are a WHO collaborating center. So we've been working closely with them. And we believe by using this evidence, we can change the outcome of mental health illnesses in Guyana. So we really welcome this move by PAHO for highlighting this. Thank you very much.
And thank you, distinguished delegate from Guyana. The next 2 speakers will be Antigua Barbuda, Colombia, and Uruguay. I yield the floor to the distinguished delegate from Antigua Barbuda.
Thank you, Mr. President, and good afternoon to all. Antigua and Barbuda thank the Secretariat for the document CSP 30/9 on mental health and its accompanying resolution. Mental health has been a priority for Antigua and Barbuda for many years. Indeed, our Twill Island state has had a psychiatric hospital since the mid-1900s, and it has provided in-house psychiatric service not only for our citizens and residents, but also for patients from neighboring islands. Over the years, we have sought to improve our mental health services by ensuring easy access to up-to-date and effective medicines, having adequately trained staff, and decentralizing mental health services with a focus on community mental health. For the latter, we have trained many primary care physicians with PAHO's assistance through the MHGAP platform. We have also improved the infrastructure of our psychiatric hospital and worked with civil society organizations to improve services. Despite these improvements, there are still some gaps and challenges. The current mental health legislation is outdated, and although PAHO has provided assistance in its update, progress in this area has been slow. There's also a deficit in trained personnel due in part to the migration of healthcare workers, and the majority of funds for mental health services are allocated to inpatient care. The issue of stigma and discrimination associated with psychiatric disorders also remain a problem. These can cause persons to not seek treatment in a timely manner. And additionally, patients may not receive the much needed necessary support from family members due to stigma. These are areas that need to be addressed fully. The COVID-19 pandemic has highlighted the importance of mental health services, not only from the disruption of services, but also from its impact on healthcare personnel who directly dealt with and witnessed the morbidity and mortality associated with COVID-19. Increasing substance abuse among our youth, alcohol abuse, and an aging population would put further strain on mental health services in the upcoming years in our country. Antigua and Barbuda therefore welcomes and approves the resolution on the policy for improving mental health with its 5 strategic lines of action contained in Annex A of document CSP 30/9. We believe it will assist us in fulfilling the identified gaps and improving mental health services in Antigua and Barbuda. Thank you, Mr. President.
Well, thank you, distinguished delegate from Antigua and Barbuda. The next 3 speakers will be Colombia, Uruguay, and Ecuador. I now yield the floor to the distinguished delegate from Colombia.
Thank you very much, Mr. President. Let me begin by pointing out that the policy to improve mental health is satisfactorily aligned with national policies on the topic without wanting to technically or operationally contradict others. Quite on the contrary, the regional policy presented reinforces the purposes established by the national policies in recent years. In Colombia, our national mental health policies and prevention, as well as the use of drugs, have prioritized persons and may place them at the center of the discussion with their needs, understanding that public action have to focus on them and design actions recognizing their particularities given the particularities of life, gender, ethnic group, and context of their daily life. Thus, what is contained in the proposed regional policy document are fully in keeping with the purpose set forth in Colombia in our policies, as well as the territorial support of a technical nature. Colombia shares the invitation to promote the analysis of mental health data and generating evidence in context with support from PAHO as a key aspect for public policy decision-making. The document also talks to the importance of actions to tackle mental health and consumption of psychoactive substances should be encouraged to guarantee human rights. We welcome this vision and we underscore the need for health systems to undertake actions to provide integral care to all people. It is fundamental to accept that mental health is determined by interaction of a whole slew of action: biological, psychological, social, cultural, economic, political, and environmental throughout the life course. So the promotion and prevention are necessary at all stages of life. This is one of the aspects reminded and ratified by the pandemic. There are still many challenges ahead to implement actions and processes to guarantee the transformation of these factors and thus have an impact on the life of people. Despite advances, there are still many challenges to incorporate mental health in other sector policies, from understanding how each can contribute or impact it. We need to tackle the mental health associated determinants nationally and subnationally to design actions and processes geared at changing the conditions of life of people, strengthen mental health services, and overcome gaps for the population to access them, especially in an emergency context. And it is in overcoming these challenges that the PAHO policy will play a key role, providing technical assistance to the country, providing opportunities and meeting points with other governmental actions, as well as civil society and community, to share common positions, to better implement actions aiming to strengthen and maintain mental health. We trust that we will receive this kind of support from the organization. Thank you very much.
Delegate from Colombia. The next three speakers will be Uruguay, Ecuador, and Panama. I now yield the floor to the distinguished delegate from Uruguay.
Muchas gracias.
Thank you very much, Mr. President. Uruguay is grateful for and supports the contents of this document and its proposed resolution. Mental health is currently a priority and needs an overall look of a multidisciplinary nature. In order to improve mental health and timely care, it is important to work jointly with support from different actors, whether institutional or social, so as to have a deep look within the territory. Although human resources are scant, especially when we talk about psychiatrists and psychologists, it's nonetheless important to have different tools such as telemedicine to care for people, as well as a tool to train the primary care professionals. Although this doesn't replace the role of the specialist, it is nonetheless support to detect risk situations for mental health disorders and to have a first level of timely care. Uruguay also believes it's necessary to work in education, both formal and informal, to provide tools to understand the topic, be able to have dialogues, share difficult situations, reduce stigmatization of people, and especially contribute to the full respect of human rights. This aspect is one of the most important cultural changes required, an awareness carried out by society, removing prejudice. And that is why we believe it's important to work with associations, organizations, and social groups to address this topic appropriately. Uruguay is developing mental health plans throughout the country in order to improve accessibility to health cares, prevent suicide behavior and self-aggression, the problematic use of substances, and providing more follow-up of self-elimination processes, improving data collection, monitoring, and assessment of figures in real time for decision-making, emphasizing the psychosocial well-being and integral care for our entire population. Thank you very much.
Thank you, distinguished delegate from Uruguay. The next three speakers will be Ecuador, Panama, and Mexico. I now yield the floor to the distinguished delegate from Ecuador.
Thank you very much, Mr. President. Ecuador is grateful for presentation of the policy document and expresses support to the proposal to improve mental health and is in accordance with the 5 lines of action mentioned. The country is promoted to the national plan and the 10-year plan for mental health. First, reduction of suicide rates. Second, reduction of use of psychoactive substances and tobacco. We should mention that the National Assembly of Ecuador at present is looking into a bill on mental health that was built with participation with civil society, academia, Ministry of Public Health, and other actors, strengthening governance for mental health. And for this, we received PAHO cooperation and shared experiences with other countries in the region. Ecuador furthermore defined a new structure within the Ministry of Public Health, giving priority attention to management of the policy, regulation, and national strategies for mental health, focusing on the socioeconomic impact of drugs, while working on strengthening the mental health service network, focusing on improving outpatient care and primary level, providing medium-term and long-term care for the most complex mental health problems, such as the use of drugs, severe mental disorders, and suicidal risks. Moreover, it's important to talk about the work carried out in Ecuador to provide mental health care services and support to persons in emergency situation through hotlines and crisis services available 24/7, and strengthening the capacities of officials in the emergency system by ongoing education to care for emergency situations in mental health. The state is committed to care, prioritization, and non-discrimination of mental patients, and to train the health workforce to guarantee the human rights and informed consent. Lastly, Mr. President, Ecuador ratifies its support to the proposed resolution to approve the policy for improving mental health, and calls upon the Secretary to promote it with strength in member states and continuously support the capacities that will contribute to enforcement of this policy and attainment of its strategic lines of action. Thank you.
Delegate from Ecuador. The next three speakers will be Panama, Mexico, and Haiti. I now yield the floor to the distinguished delegate from Panama.
Thank you, Mr. President. We will refer to the document resolution CSP 30/9 to establish a policy for improving mental health, showing important elements of a global and regional and sub-regional level, and we should be thinking about mental health as an important aspect of general health. This past year, we have all acknowledged the importance of mental health in our lives. We have tested our collective and individual capacity to think. We have understood how positive it is to interact with others, to gain our living, and to enjoy moments of life. The pandemic has emphasized the importance of mental health programs, not only for the general population, but also our health workforce. The burnout of healthcare workers with long days and ethic issues have had an impact on their mental health. So let me focus on this to talk about how important it is to offer mental health services in our countries in order to improve the quality of life of people, families, and communities. Teleconsultation and tele-advisory services are some of the critical elements we can include to increase access to mental health care. Panama urges state to recognize mental health as a public health priority and to assign an earmark sufficient budget and raise awareness in order to work more on preventive care and not merely on illness or disease. The pro tempore chairmanship of the Ministers of Health in the Americas held in Panama. We received cooperation from PAHO's office in the Forum of Mental Health. This resulted in a decision by country that was perfectly aligned with the proposed resolution before us today, showing how the region has given priority to develop mental health strategies. The policy we are discussing today should help all countries in the region to work with the organization's support in accordance with the PAHO Strategic Plan 2020-2025. Human minds can recover, but we need to have models and plans to achieve this goal, recording strategic public-private partnerships. Panama welcomes the policy for improving mental health in member states and underscores multi-sectoral alliances and partnerships and make available high-quality community services for mental health, as well as the consumption of drugs and promotion throughout the life cycle. Thank you very much.
Delegate from Panama. The next three speakers will be Mexico, Haiti, and France. I yield the floor to the distinguished delegate from Mexico.
Muchas gracias.
Thank you very much, Vice President. Thank you very much also to the doctor who presented this policy. Mexico believes that the policy before us today is vitally important. Presently, there is greater participation and consideration of the different social and political actors for health decision-making. So we need mental health policies that strike a balance between academic knowledge, contemporary needs for care, and government and social capacity available to have an impact on the inequities for detection, attention, and treatment of mental health and disorders and other issues that have aggravated or were generated by the COVID-19 pandemic. There is no doubt that we need to provide mental health care. This needs to be part of the context of the community, with programs to bring an end to the cycle of poverty, hunger, unemployment, exposure to violence, stress, and discrimination, among other factors impacting people, together with better attitudes and public policies for those people who have a psychiatric disorder in order to provide high-quality services for the best treatment for each case. In Mexico, we promoted legal changes to move mental health care to the community with timely detection and to right through the integral treatment of the individual and their family, as well as the availability, quality, and health of the services, promoting human rights and promoting dignity. The Mexican delegation concurs with the proposed policy and gives priority to establish and execute multidisciplinary programs for mental health and suicide prevention to strengthen health, socio-economic well-being of the population. Thank you very much.
Thank you, distinguished delegate from Mexico. The next three speakers are Haiti, France, and the Dominican Republic. I now yield the floor to the distinguished delegate from Haiti.
Thank you, Mr. President. The COVID-19 pandemic that afflicted the region in a terrible way has increased the burden of mental health. The World Health Organization defined mental health as a state of well-being where a person can achieve his or her goals given the usual stress of life to have a productive work and contribute to the life of their community. We are faced with a dilemma because a new mental health is a cause and consequence of poverty, of deficient education, of gender inequality, poor health, and other global challenges. So we see how poverty, deficient education, bad health, stress, inequalities can result in mental health problems. We ought to find how to guarantee pay, resilience, equity for each family, each community, each country in the region in order to confront mental health problems and be able to achieve the SDGs. When Dr. Florence Duviol, Minister of Health, implemented the mental health unit within the Ministry of Public Health and Population, recognizing the contributions made by the mental health unit in attacking COVID-19, thanks to the psychosocial support given to the population. Haiti thanks PAHO for the support provided and supports the proposed resolution contained in the document, on the policy document presented for our consideration today. Thank you.
Thank you to the distinguished delegate from Haiti. We have two more interventions, France and Venezuela. We now yield the floor to the distinguished delegate from France.
Merci, Monsieur le Vice-président.
Thank you, Mr. Vice President. France is very attached to mental health. In 2018, we sent a sentimental psychiatric roadmap with a structural reform that is systemic focus on these domains. A ministerial delegate to mental health and psychiatry was appointed in 2019, but most importantly, France in October 2021 organized the Global Summit on mental health. In London in 2018 and Amsterdam 2018, it was the third summit and an effort to mobilize towards the rights in mental health and the healthcare provided respectful dignity. Several ministers of health and international organizations and civil society organizations, professionals, experts, and academia participated at the event. Strengthening the Mental Health Program 2013-2030, creation of the Coalition for Mental Health, amongst other efforts, recall that mental health is a public health priority, and France wants to work in this collective effort. That is why France stands next to PAHO member states to develop this policy for improving mental health and share the views if they are contained in this document.
Thank you, distinguished delegate from France. We now have our final intervention for member states, and I now yield the floor to the distinguished delegate from Venezuela.
Gracias, señor.
Thank you, Mr. Vice President. The delegation of the Bolivarian Republic of Venezuela thanks the Secretariat for presenting the document Policy for Improving Mental Health and its proposed resolution. Venezuela works in the framework of international agreements, the health agenda for the Americas, and the plan for mental health towards 2030, developing different strategies and actions to reduce the gap in mental health. We have been working on a multi-sectoral group with different actors involved, representing government, academia, and unions to develop a bill for mental health in order to establish a legal framework in accordance with the current situation for the promotion and prevention of mental health, neurological diseases, guaranteeing the human rights of people suffering one of the pathologies associated with mental health, as well as their families. We are strengthening the care system for mental health, and right now working on mechanisms to implement the global program to reduce the health gap in cooperation with PAHO. We're also supporting implementation of the GAP tool, opening in general hospitals a mental care unit. And a postgraduate course is also being offered to train psychiatric professionals through the Hugo Chavez Frias University and to have more professionals to care for our population. In our network outpatient care, which is the second level, so that 95% of people having mental health are guaranteed with comprehensive care close to their residence, and treatment should go from the individual, the family, and community environments. Also, a plan for reorganization of psychiatric hospitals is underway, and we want to have a social universal care. This is a principle for our national public health system established in the Constitution of the Bolivarian Republic of Venezuela. It's one of the challenges to overcome, and that is access to pharmacological treatment that due to unilateral sanctions imposed on Venezuela by the United States of America, is highly limited and practically impossible to administer traditionally. It is through the cooperation of international organizations or bilateral agreements with governments such as Russia, China, Cuba, Turkey, India, and Iran. It has been possible to provide for the people who come to our program. Thank you very much, Mr. Vice President.
Thank you, distinguished delegate from Venezuela. Just a reminder that we have the interpreters and we'd want to urge you to pace your presentation so that they could make the appropriate interpretation of the presentation. We have heard from all our member states, and now we'll entertain two presentations from non-state actors, Organismo Andino de Salud and the International Council of Nurses, ICN. I now yield the floor to Organismo.
Muchas gracias. Thank you very much for providing us the possibility of addressing you in this very important event from the Andean Health Organization. First of all, we'd like to congratulate your member countries, Bolivia, Colombia, Chile, Ecuador, Peru, and Venezuela. The chair's microphone is open. For the efforts deployed on mental health during the pandemic, we follow the mental health Andean policy and with an Andean plan for mental health, having approved at the ministerial meeting, Ministers of Health of the Andean region in June 2021 to increase the budgets for mental health, because we know very well that without a budget, there are no rights. Since our organization is a space for integration on health, we will continue to work in articulation and hand in hand with PAHO at a regional level, with Renato Oliveira Sousa, and with the different countries by exchanging experiences on mental health, community mental health that have been carried out in Chile and Colombia as a top priority. Regarding the proposed resolution, we have a few comments to share with you. We should not forget that the most vulnerable group is girls, boys, and adolescents. There's plenty of research work that attests to the fact that the pandemic has acted on the mental health of them. And a special group is that of orphans. Peru and Bolivia are the countries where we have the largest number of orphans because of COVID. So we need an intervention in order to provide support to the orphans and the new families where they will be adopted. On the other hand, it is important to recall that mental health is something that is witnessed in all spaces, that is to say, at home, in a household, in the community, in school, at the university, and we ought to continue insisting on the importance that there is no health without mental health. Last but not least, I would like to thank you for the proposal, and I see that all countries are accepting and to continue insisting on the need for a better knowledge of long COVID and its impact on mental health. We need to establish teams that will provide a comprehensive care to the disabilities brought about by the long COVID. We're talking about 10 to 20%. Thank you very much.
Thank you, distinguished delegate from the Organismo Andina Salud. We now yield the floor to the distinguished delegate from the International Council of Nurses.
Hello, my name is Dr. Giladinsky, and I'm speaking on behalf of the International Council of Nurses. As I mentioned earlier today, we are a federation of more than 130 national nurses associations, and we represent the voice of the 2 million nurses worldwide. The International Council of Nurses supports the need to focus on mental health, especially in the aftermath of the COVID-19 pandemic. ICN wants to highlight the mental health impact of the pandemic on specifically nurses. As a key population of frontline healthcare workers with their mental health significantly impacted by the pandemic. There has been a mass traumatization of the nursing workforce following the COVID-19 pandemic. Nurses are at the front lines of addressing mental health in their practice, not just nurse mental health specialists, but all nurses who provide holistic healthcare. Nurses are the backbone of healthcare systems, but without their own mental health needs met, they are unable to provide high quality care to the populations they serve. This policy for improving mental health highlighted that many groups such as Indigenous communities, migrants, older adults, and queer persons are at risk for poor mental health. This policy also highlighted that since the pandemic, women, young people, people with pre-existing mental health conditions, racial and ethnic minorities, and people living with vulnerability to COVID-19 were more likely to have worsening mental health outcomes. Since the pandemic, nurses, as key frontline healthcare workers, had been hit hard with poor mental health outcomes themselves. And these mental health outcomes are even worse in those nurses with intersectional identities, such as female nurses, nurse migrants, Indigenous community nurses, older adult nurses, young nurses, queer nurses, and nurses with pre-existing mental health conditions, nurses of racial and ethnic minorities, and nurses living with vulnerability to COVID-19. Due to nurses' role in addressing both physical and mental health, the mental health of the nursing and healthcare workforces cannot be ignored. ICN calls for nurses and health workforce mental health to be specifically addressed throughout all mental health interventions, because mentally healthy health workforces are needed to address population health of all kinds. Thank you.
I thank the distinguished representative of the International Council of Nurses. And there being no further intervention, I now yield the floor to Dr. Hennis for his comments on the discussions he has shared so far.
Thank you so much, Mr. Vice President. And thanks to all the member states who have contributed. Over 25 member states have contributed, as well as 2 non-state actors. And they really have reiterated the points that were made in the policy. The challenge of the mental health burden that existed before the pandemic, that really was not very visible, but really the chronic situation of underfunding in terms of finances as well as human resources. Then the fact that when the pandemic struck, there was tremendous disruption, anxiety, depression, and stress, isolation, all the other issues that were mentioned, and of course, compounded by the disruption of services when they were most needed. And of course, it also points out the whole issue of the most vulnerable groups who were most affected. So I think we are all ad idem with the challenges of the pre-existing situation and the exacerbation and the challenges that took place during the pandemic. We recognize also that the mental health systems were fragile. There's also inadequate preparation for the emergency and the preparedness and the response, and the other challenges that also existed in terms of the lack of progress of deinstitutionalization. And I will point out that back in 1990, in the Declaration of Caracas, there was a clear strategy developed in this region towards focusing on community-based care based on a human rights approach for people with mental health conditions. There had been progress, but it actually had stalled. And I think we really have to recover and recoup that space. Issues such as rights-based approaches, health in all policies, tackling stigma and discrimination, trying to address the treatment gaps. I think all the countries, all the member states, all the non-state actors are fully aligned. The need for multi-sectoral approaches, whole of society, whole of government approaches, health in all policies, and of course, the key importance of political will and political leadership. And we've seen some outstanding examples in our region of leaders of countries and heads of government taking a particular position on positioning mental health in response to the pandemic and the dividends that has yielded. So we recognize the need for investments, policies, systems and services and so forth to be part of the transformation and the way forward. So I think we all recognize that. I thank the member states for their support of the policy. And the other points that were raised, the fact that we should have probably emphasized a little bit more the need for health workers who also under vulnerable groups. This will all be taken into account during the phase of implementation. So I thank the member states and all for their support of this policy, and we look forward very much to their support as we implement as we go forward. Thank you. Thank you, Mr. President.
Thank you, Dr. Hennis, for your response. And Dr. Espinal, do you have any comments?
Just briefly, Mr. President, thank you. 26 member states just gave us comments about this. And people are talking about COVID and monkeypox. But your comments make us wonder if we are in the face of the next global pandemic. Mental health. They said mental well-being is a blind spot compared to physical well-being. We keep hearing everything about sports, physical activities, but mental health. To me, this is the new great pandemic and we need to face it. I think there is not much to say, but to advise member states that we hope this policy put in place today can help you to shape forward the battle against mental health for the well-being of our people, and the organization and the Secretariat will be ready to accompany our member states on that long road. Thank you.
Thank you, Dr. Espinal, for your profound observation. I now ask the rapporteur to present the proposed resolution.
Sí, señor presidente. Proyecto de resolución. Política para mejorar la salud mental.
Proposed resolution, policy for improving mental health, the 30th Pan American Sanitary Conference, PP1. Having reviewed the policy for improving mental health, document CSP 30/9, PP2, recognizing the significant adverse impacts that the COVID-19 pandemic has had and continues to have on the mental health and well-being of populations in the region, as well as on the operation and delivery of services for mental, neurological, and substance use conditions. PP3. Recalling the principles enshrined in the Caracas Declaration 1990, the United Nations Convention on the Rights of Persons with Disabilities 2006, and the Political Declaration of the High-Level Meeting on Universal Health Coverage 2019. PP4. recognizing the urgent need to improve mental health in order to recover from the COVID-19 pandemic and to build back a better mental health systems and services for the future, which are necessary for advancing the health, social, and economic development of member states and the region of the Americas as a whole. Resolves OP1 to approve the policy for improving mental health. Document CSP 30/9. OP2 urge all member states considering their conflicts, their needs, vulnerabilities, and priorities to little a, promote increased investment, both financial and human, in community-based mental health care in order to address the heightened demand for mental health and substance use services brought on by the COVID-19 pandemic, and to build stronger, more resilient mental health systems for the post-pandemic period. Little b, adopt a whole of the government and whole of society approach to improving mental health that promotes strategic collaborations and partnerships with diverse actors across all relevant sectors, non-governmental, civil society, academic, and persons who lived experience amongst others, and that includes high-level political engagement. Little c, improve and scale up equitable and comprehensive community-based mental health care for the entire population, and further integrate mental health and substance use into all levels of care to ensure progress toward universal health coverage. Little d, support mental health promotion and prevention and the establishment and implementation of multidisciplinary mental health and suicide prevention programs from early childhood extending throughout the life course. OP3, to request the director to little a provide support to member states to strengthen capacities that contribute to the implementation of the policy and the achievement of its strategic lines of action. Little b, continue prioritizing and facilitating the integration of mental health and substance use services into all COVID-19 emergency response efforts by the Pan American Health Organization, as well as other health initiatives across the organization. Little c, report periodically to the governing bodies on the progress and challenges encountered in the implementation of this policy. That is all regarding the proposed resolution, Mr. Chairman. Thank you.
Thank you very much. I now yield the floor to the plenary to discuss any matter relating to the resolution. There being no objections, I declare the resolution adopted. I'd like to bring document CSP 30/10 to the attention of the conference and invite Dr. James Fitzgerald, Director of the Department of Health Systems and Services of the Pan American Sanitary Bureau, to come to the head table. I yield the floor to the representative of the Executive Committee to report on the item.
Thank you, Mr. President. Item 4.5, Policy on Integrated Care for Improved Health Outcomes. The Executive Committee welcomed the proposed policy on integrated care for improved health outcomes and voiced support for the 4 strategic lines of action, which were considered timely and necessary to advance towards universal health coverage and the achievement of the health-related SDGs. Delegates agreed that the COVID-19 pandemic had exposed and amplified existing weaknesses in the health services and systems, clearly revealed the inefficiencies of fragmented systems, exacerbated health inequities, and highlighted the need to build integrated systems in order to improve quality of care and achieve better health outcomes. It was pointed out that had the pandemic has not only revealed gaps and weaknesses in the health system, it has also put health on the political agenda. The post-pandemic recovery period therefore offers a critical opportunity to strengthen health systems and improve the integration and coordination of care. It was considered essential to investing in primary health care in order to construct integrated health systems that are equitable, accountable, affordable, accessible, and people-centered. The importance of ensuring an intercultural approach and culturally responsive care was also underscored. The Executive Committee adopted Resolution CE 170.R3, recommending the Pan-American Sanitary Conference approve the policy on integrated care for improved health outcomes. Thank you, Mr. President. This concludes my report on this item.
And thank you very much. I now yield the floor to Dr. Fitzgerald to present the item.
Thank you very much, Mr. President. Honorable delegates to the 30th Pan American Sanitary Conference, Acting Director, Dr. Espinal. Fragmentation in health service delivery in all its forms is a pervasive problem in health systems, and it affects the organization, the management, and the provision of care in almost all member states of the Pan American Health Organization. Fragmentation impedes equity in access to health, greatly affects health outcomes, as well as people's experience of care and their satisfaction with health systems in general. As a consequence, it really limits the capacity of health services to respond to people's needs. The COVID-19 pandemic has exposed the lack of capacity of health systems throughout the region to integrate all levels of care and services in response to the pandemic, while ensuring continuity of care for people who need other essential services, particularly people with chronic conditions. Given this, integrated care is a broad strategy to address fragmentation in healthcare and service delivery. It combines clinical, social, organizational, and policy changes aimed to improve healthcare delivery, ensuring effective outcomes, and in particular, improving user experience and satisfaction throughout the continuum of care. It constitutes a strategy for improving care through better coordination of priority programs, providers, and services across the continuum of services, organized around the principle of person-centered care and taking account of the specific and differentiated needs of people. The policy document therefore presented today, Policy on Integrated Care for Improved Health Outcomes, provides a general strategic framework and policy options to assist member states in the implementation and delivery of integrated care. It aims to strengthen the capacity of national health authorities to lead and manage system-wide transformations for integrated care and the integration of health services at the national and local levels based on the strong foundation of primary health care. It further aims to transform the organization and management of health services to improve people's experience, population health, and the quality, equity, efficiency, and effectiveness of healthcare delivery, including the integration of providers in care and priority health programs. It further aims to move from theory to practical implementation, ensuring the practical application of evidence-based policies, emphasizing health promotion and digital health strategies to integrate information between levels of management, for decision-making. And finally, it proposes to empower and engage people and communities to improve their health and enhance organizational learning, embracing interventions with gender, intercultural, and life course approaches with formal mechanisms for community participation and decision-making. It should be noted that this policy builds on multiple other important frameworks that have already been adopted by member states to move towards the achievement of universal access to health and universal health coverage, and to build resiliency within health systems, promoting a greater degree of integration within the organization of health service delivery. Thank you very much, Mr. President.
Thank you, Dr. Fitzgerald. I now yield the floor to the plenary to begin discussions. I now yield the floor to the distinguished delegate from Honduras.
Muchas gracias.
Thank you very much. Honduras agrees with the proposal on policies on integrated care for improved health outcomes, since we ought to continue strengthening people-centered care and based on primary health care. We believe that it is necessary to continue promoting policies and to establish firmer regulations to promote the transformation towards a people-centered health system that will provide equitable services, accessible, affordable, appropriate, with a multicultural and linguistic approach, providing quality care that will be efficient, effective, and provided with warmth and in an integrated fashion. Access to universal access to health are essential objectives in order to have a comprehensive and integrated approach through intersectoral coordination with education, social protection, environment, public security, strategic planning, as well as others. The strengthening of the governing role and the governance of the National Health Authority in order to head the health sector is essential. The proposal on investments in the technology proposed in the document is necessary in order to transform the first level of care, including interventions in the availability, regulation, and the rational use of medicines, as well as other health technologies. Besides, it is essential to invest in digital transformation of the provision of health care services. These strategies to provide integrated care is an essential step towards the resilience of the health system and the attainment of universal health care. We will also see that contributing to the attainment of the SDGs, in particular SDG 3, which is to ensure health and well-being for all, and SDG 10, to reduce inequalities. In connection with the proposed resolution, Honduras does not have any comments to make, sir. Thank you.
Thank you, distinguished delegate from Honduras. The next three speakers will be Jamaica, Bolivia, United States of America. I now yield the floor to the distinguished delegate from Jamaica.
Thank you, Mr. President, distinguished colleagues. Jamaica wishes to commend the Pan American Health Organization Secretariat for providing such a comprehensive guidance document, providing member states with a rationale, guiding principles, and strategic lines of action, objectives, and indicators to ensure alignment across the region of the Americas. For Jamaica, the primary healthcare system is the backbone of our health sector's response and will serve as the gateway for integration. There have been efforts to expand and strengthen our health systems, thus building resilience within the framework of the strategy for universal access to health and universal health coverage. We have developed health strategies, plans, policies, and our roadmaps to advance towards integrated health approach and have started our primary healthcare renewal reform prior to COVID-19. However, segmentation and fragmentation of health system continues to exacerbate inequities and barriers to access as out-of-pocket expenditures in health remain high, in particular for medicines and health technologies. Coverage of health services remains low, in particular in rural settings, and the health workforce continues to concentrate in urban centers and specialized health service delivery settings. Against this background, Jamaica endorses strongly the proposed resolution and commits to promote universal health access in all policies and greater intersectoral action to improve equity and integration, promote health throughout the life course to include policies and programs on women's, men's, maternal, newborn, child, and adolescent health, sexual and reproductive health, workers' health, and older persons, and develop strategies and best practices to mitigate the loss of human resources to larger work markets. Thank you, Mr. Chair.
Thank you, distinguished delegate from Jamaica. The next two speakers will be Bolivia, United States, and Suriname. I yield the floor to the distinguished delegate from Bolivia.
Buenas tardes, presidente. Agradecemos.
Good afternoon, Mr. President. We're very grateful for the presentation made, and we understand the importance of this issue. Regarding strategic line 2 of the policy on integrated care for improved health outcomes, we would briefly like to talk about the practical importance of the same and the path covered by the plurinational state of Bolivia. As of the approval of the political constitution of the state in February 2009, which has established the right to health as the basis for construction and consolidation of a health system, a single, universal, free, equitable health care system, intra and intercultural, with the social participation and articulated to the age-old ancestral medicine in Bolivia. This health system in Bolivia attempts to modify the health system inherited from the neoliberal Republican times, which conditioned a fragmentation, segmentation, and the progressive definancing of the same, thus leading to a weakening of the public sector through the reforms of the sector during the 90s. They attempted to impose a competition and a new market in the health sector, as well as in the rest of the economy. The defunding and lack of physical and human resources for the public subsector led to the conditions in providing healthcare services to the population to be increasingly affected and non-equitable when compared to the other subsectors of the national health system, such as the short-term social spheres and the private sector. The contribution of this Bolivian health system on the basis of a social participation of the mobilized systems of the population allowed us to enact the relevant law in its implementation as of March 1st, 2019. The change in economic model implemented starting in 2006 in Bolivia enabled us to enforce social measures that had an impact on the social determinants of health, such as access to drinking water, basic sanitation, and food in the sectors of the population that used to live in impoverished rural areas. Access to education and reducing dropout levels with the implementation of programs for the redistribution of the wealth created by the strategic enterprises in the state, the Juancito Pinto, the Suru de Padilla bond, and one is most important, universal subsidy for mothers devoted to reducing poverty. In a nutshell, the new economic model allowed the health sector to receive more economic resources, essentially the public subsector, which is clearly reflected on the economic indicators such as the total expenditure in health vis-a-vis the GDP, which reflects the clear effort of the state of Bolivia in stepping up funding for that sector. It is within that context that the health system not only entails a dramatic inflow of financial resources to the health system, but structural changes regarding funding and management of the system, and obviously this whole set of actions and decisions which enabled us to expand the coverage the health integrated coverage of the population that did not have access to Social Security and to no other system or subsystem in health. After the 3 years of implementation of this single health system, 17 million care services have been provided to the population benefited from it, which is a dramatic drop in out-of-pocket expenses from families, so that in 2019, it reached 27% of this reduction. One of the objectives of the health system is to attain a percentage of out-of-pocket expenses vis-a-vis total expenditure in health below 15%. Last but not least, Mr. Chairman, we are grateful and we welcome the inclusion of the Bolivian proposal that appears in little f of this proposed resolution regarding the policy on integrated healthcare to improve results in health. Thank you, sir.
Thank you, distinguished delegate from Bolivia. We are proposing that we take a 20-minute break, but before we do so, we'll have 2 more interventions, United States and Suriname. Upon returning from this 20-minute break, we'll first hear from reports from the committee on credentials and from the working parts that studied the working party that studied the application of Article 6B of the PAHO Constitution before coming back to this policy item 4.5. My colleague, the Minister of Health of Chile, in her position as Vice Chair of the conference, will preside the next portion of the meeting for today. So we'll now receive the presentation from the distinguished delegate from the United States.
Thank you, Mr. President. The United States appreciates the draft policy on integrated care for improved health outcomes, and we're supportive of strategic lines of actions proposed in the policy. The pandemic has certainly shown us the detriments caused by fragmentation of care and the need for health systems that are integrated, accessible, and responsive to people's needs. As the policy notes, primary health care is foundational to strong health systems. Investing in primary health systems is key to strengthening integrated care and building high-performing healthcare that is equitable, accountable, affordable, accessible, and safe and reliable. Maintaining and supporting an educated and highly skilled health and care workforce across all levels of care is also central to the strengthening integrated care. The cornerstone of health system resiliency is keeping health workers and patients safe through a series of measures which includes infection prevention and control best practice. We appreciate the policy's emphasis on the need to develop training programs that are inclusive and responsive to intercultural, gender, and life course approaches. It is important that health and care workers are well equipped with the capacities and competencies to provide comprehensive, integrated, and quality care. Developing integrated health systems that promote, protect, and help maintain health for all people is fundamental to building resilient health systems. Advancing toward universal health coverage and achieving the Sustainable Development Goals for health. It calls for a whole of society collaborative effort, including across public, private, and faith-based healthcare systems, and recognition of the power that communities hold to influence the quality of their health systems. Thank you.
Thank you, distinguished delegate from the United States. We'll now have our last intervention before coffee break. I yield the floor to the distinguished delegate from Suriname.
Thank you, Mr. President. Suriname would like to thank the Secretariat for the joint efforts for this policy. The objective of this policy is to provide a general strategic framework and wide-ranging policy options to assist member states in the implementation of integrated care. The health system in Suriname is somewhat fragmented. COVID-19 has exposed some of the vulnerabilities in the system, highlighting how fragmentation can impede the equitable access to health across the country. Transformation of the system is therefore critical to support the move toward universal access and universal health coverage. The Ministry of Health developed a health policy plan 21-25 with several policy areas and key actions to guarantee access to quality health care for all and advance the achievement of universal access to health in Suriname. Suriname is also implementing the HEARTS initiative to provide integrated care for hypertension and diabetes in the first phase. Suriname is currently undergoing a reform process of the health sector and should assist in strengthening the primary health care approach and address central issues of fragmentation, segmentation, inequities, and barriers to access, as well as health system responsiveness and adaptiveness. There is, however, need for further advancements along the 4 strategic lines of actions outlined in this policy on integrated care, along with the necessary allocation of resources to support the implementation of planned activities in the country. Mr. President, Suriname supports the approval of this proposed policy. Thank you, Mr. President.
And thank you, distinguished delegate from Suriname. We'll now take a coffee break, and when we return, we'll continue with the business of the conference. Thank you for your participation.
It helps to close gaps and reduce inequalities. Investing in resilient healthcare systems is vital for their recovery and preparation for the future. However, no single nation or organization can tackle the health challenges facing the Americas alone. We are the partner of choice to promote public health and the best resource to improve the quality of life in our communities. We provide coverage in all countries, management and supervision of projects at the regional and national level, knowledge and networks in all areas of healthcare, capacity to convene people, mechanisms of transparency, and experience with responding to emergencies. Building partnerships has been essential to improving healthcare in the region. Life expectancy has increased by 36 years. The mortality rate for children under 5 has been reduced by 67%. Hundreds of millions of people have been able to get vaccinated and obtain access to medicines. Smallpox, polio, rubeola, and measles have been eradicated. Each of these achievements demonstrates what can be attained through collaboration. And yet, we still have much work to do. Many people's lives depend on us. Let us continue working together to bring health and hope to every corner of the Americas. The Pan American Health Organization.
Desde que iniciou o surto de sarampo no estado do Amapá, essa vacinação vem sendo realizada com muito empenho, com várias frentes de vacinação, principalmente na capital e nos municípios onde nós tivemos casos. Então, nós organizamos na forma de varredura, de vacinação casa a casa, estratégias em escolas, em creches.
Teve o caso de sarampo de uma criança da creche, a gente veio oportunizar também, a gente veio verificar as cadernetas das crianças, encontramos muitas cadernetas desatualizadas, Então, o foco também foi esse, a gente fazer essas vacinas de rotina, atualizar e também priorizar a vacinação da tríplice viral, sarampo, né?
A varredura vacinal é uma ação que a equipe de saúde vai até a população, batendo na casa e perguntando quem mora, qual a faixa etária e revisando o cartão de vacinação. A partir da revisão do cartão de vacinação é ofertada a vacina que esteja faltando para completar o esquema de vacinação daquela pessoa e atualizando toda a caderneta, não só de uma pessoa, mas de todos os residentes daquela casa.
Para a gente foi muito importante essas ações de varredura, principalmente com relação ao sarampo. Imagina, de 2019 para esse ano de 2022, a gente tinha 200 casos de sarampo. Então, a gente conseguiu controlar o surto de sarampo com essas ações, de modo que hoje a gente tem entre 10 e 12 casos.
Você acha que é importante você tomar vacina? Por quê?
Porque é ótima para nossa vida e nos livrar de todos os vermes e proteger a nossa família.
Las Américas, una región dinámica y diversa, pero también la más desigual del mundo. 201 millones de personas todavía viven en la pobreza. Enfermedades como la obesidad, la diabetes, la hipertensión y el colesterol alto son más prevalentes entre los pobres y los más vulnerables. La mortalidad de niños menores de 5 años es el doble cuando las madres tienen menor educación. Cada año nacen 2 millones de niños de madres entre 15 y 19 años. Tenemos el deber de proteger a quienes más lo precisan. Haremos lo que sea necesario para que nadie quede atrás. Lo hemos hecho por más de un siglo y no vamos a parar, porque nuestra determinación no para. Nuestra dedicación no para. Nuestro compromiso con las comunidades no para. Porque la vida no para. La salud es el recurso más valioso y un motor del desarrollo sostenible. Ayuda a cerrar brechas y a eliminar inequidades. Invertir en sistemas de salud resilientes es vital para la recuperación y la preparación para el futuro. Pero ninguna organización o nación puede abordar los desafíos de salud en las Américas por sí sola. Somos el socio de elección para promover la salud pública y el mejor instrumento para mejorar la calidad de vida de nuestras poblaciones. Tenemos cobertura en todos los países, capacidad de gestión y monitoreo de proyectos a nivel regional y nacional, conocimiento y redes en todas las áreas de salud, capacidad para convocar, mecanismos de transparencia y experiencia en dar respuestas a emergencias. Las alianzas han sido esenciales para mejorar la salud en la región. La esperanza de vida aumentó 36 años. Las muertes de niños menores de 5 años se redujeron un 67%. Miles de millones de personas se han podido vacunar y acceder a medicamentos. Se eliminó la viruela, la poliomielitis, la rubéola y el sarampión. Cada éxito demuestra lo que la colaboración puede lograr. Pero todavía queda mucho por hacer. Las vidas de muchas personas dependen de nosotros. Llevemos juntos salud y esperanza a cada rincón de las Américas. Organización Panamericana de la Salud.
La diabetes, las enfermedades cardiovasculares, las enfermedades respiratorias crónicas y el cáncer son las principales enfermedades no transmisibles. En los últimos años, estas han aumentado impulsadas por el envejecimiento, la urbanización, la globalización y cambios en nuestros estilos de vida, hasta convertirse hoy día en la gran epidemia de nuestro tiempo. El impacto de las enfermedades no transmisibles puede reducirse con estilos de vida saludables, pero para adoptarlos, la voluntad individual no es suficiente. Por ejemplo, cuando comprar alimentos saludables es más costoso y difícil de encontrar que la comida chatarra. Cuando realizar ejercicio físico es todo un desafío porque no contamos con áreas verdes acondicionadas, cercanas y seguras. Cuando dejar de fumar o de beber resulta complicado porque la publicidad de estos productos nos invade en todas partes. Se requieren leyes y normas que hagan de la opción saludable la más fácil de tomar, pues de no hacerlo, cada vez más personas se enfermarán y necesitarán medicamentos y tratamientos costosos de por vida, los cuales podrían llevarlos a la ruina. Pero estamos a tiempo de poner un freno a esta epidemia, y algunos países en las Américas ya han tomado acciones, como por ejemplo, reformulando los productos procesados para hacerlos más saludables, informando a los consumidores acerca de su contenido y promoviendo un mayor acceso a alimentos frescos, regulando la venta de alimentos en las escuelas, así como proporcionando agua potable sin costo, aplicando impuestos al tabaco, alcohol y bebidas azucaradas para reducir su consumo, a la vez que facilitando el acceso a programas para dejar de fumar, prohibiendo el consumo de tabaco en espacios públicos cerrados y limitando la publicidad en cigarros, alcohol y comida chatarra, creando espacios para la realización de actividades físicas, así como promocionando las ciclovías recreativas y el uso del transporte público. Los gobiernos deben asegurar los servicios de salud para la población, el acceso a la detección oportuna, el diagnóstico, cuidados de salud y medicamentos, sin discriminación y sin que ello implique caer en dificultades económicas. Las personas deben tener apoyo y acceso a la información para empoderarlas en el manejo de su propia salud, con el fin de mejorar el control de sus enfermedades y contribuir a un desarrollo sano de ellos y sus familias. De esta forma, las personas como tú, yo y todos pondremos un alto a esta terrible epidemia y podremos disfrutar de una vida más larga y beneficiosa. Políticas públicas y hábitos saludables constituyen la receta para un mejor estilo de vida. Comparte esta información y si deseas saber más, visita nuestra página.
La región se enfrenta a una inminente crisis por la importante disminución del número de niños que reciben todas las vacunas. En el 2021, en las Américas, 2.7 millones de niños menores de 1 año no recibieron o completaron sus esquemas de vacunas básicas a raíz de las interrupciones en los servicios de salud ocasionadas por la pandemia de la COVID-19. La pandemia también afectó la vigilancia de estas enfermedades y los sistemas de laboratorio. La región podría no ser capaz de detectar el próximo brote de una enfermedad prevenible por vacunación antes de que se convierta en una epidemia multinacional. Por la íntima relación entre epidemias y la vida en sociedad, estamos no solo ante un riesgo sanitario, sino también ante un riesgo económico, educacional y social. Necesitamos disminuir el riesgo de importación y de brotes de enfermedades que fueron eliminadas de las Américas, como la polio, la rubiola o el tétanos neonatal. Para lograrlo, los Estados miembros, los socios y la Organización Panamericana de la Salud debemos trabajar en conjunto para fortalecer todos los aspectos de los programas de inmunización, invirtiendo recursos financieros y aumentando la cantidad del personal capacitado que pueda garantizar servicios de inmunización y su integración al sistema de atención primaria de la salud. Esto solo ocurrirá si los gobiernos y los socios se comprometen política y económicamente a cerrar las brechas en inmunización. Como principal colaborador de la región en todos los asuntos de salud pública, la OPS está perfectamente posicionada para ayudar a los Estados miembros a priorizar sus necesidades más urgentes e implementar acciones en favor de la vacunación. Continuemos con nuestra exitosa colaboración para fortalecer los programas nacionales de inmunización en toda la región. Es posible superar esta crisis. Juntos. Hemos triunfado en el pasado y lo volveremos a hacer. Organización Panamericana de la Salud, 120 años. Somos la Organización Panamericana de la Salud, celebrando 120 años de solidaridad en la promoción de la salud y el bienestar de las personas, sin dejar a nadie atrás.
We live in a world that is evolving faster than ever, and in which life expectancy has increased by 20 years in half a century. For the first time, society and technology have advanced quicker than the life of a single person or a generation. Never before have 6 generations shared the planet. Generations who were born before the existence of antibiotics today coexist with younger generations that are being born into a biotechnology revolution at a time of high social connectivity. The aspiration is that this gift of 20 years in life expectancy is translated into a benefit and not a burden. The fact that people live longer, are sick for longer, and are therefore linked to health services for longer are reasons that demand the need for novel approaches. The gift of 20 more years in life expectancy requires that the physical and mental capacities of the population be fully developed and last longer. That allows us to not only to survive, but to thrive and actively contribute to this fast and demanding transformation. This is why health cannot remain only a concept or an abstract aspiration, but must be understood and measured as a resource and a tangible capacity. Understanding that health does not occur by itself and must be built throughout the lifespan and determined by special social conditions is essential. Building health throughout the life course seeks to motivate academia and health structures to look at health through this innovative lens. But beyond that, it intends to stimulate the application of the life course approach into public health practice and influence and determine the health trajectories of individuals and populations, and consequently, their capacity for human development.
Las contribuciones determinadas a nivel nacional, NDC, reúnen los compromisos asumidos por los países para enfrentar el cambio climático. Incluyen acciones de adaptación al cambio de clima y de mitigación, la reducción de las emisiones de gases de efecto invernadero y otros contaminantes atmosféricos. Su implementación trae beneficios: reducción del número de muertes, estadías en el hospital, licencias laborales y casos de enfermedades respiratorias y cardiovasculares relacionadas con la calidad del aire, entre otras consecuencias para el sistema público de salud, las empresas y el Estado. Para cuantificar los beneficios de las NDC, la Organización Mundial de la Salud desarrolló una herramienta de cálculo llamada Carbón H. Carbón H le permite a legisladores, votantes, tomadores de decisiones y empresarios contar con información sobre los efectos esperados sobre la salud de la mejoría en la calidad del aire. La NDC preparada por Colombia contiene 148 medidas para reducir el 51% de las emisiones de gases de efecto invernadero para el año 2030 en relación a 2014. Usando la herramienta Carbón H, Se estimaron que algunos de los co-beneficios a la salud de la implementación de las NDC son 25.600 muertes evitadas en el período 2021-2030 y 3.800 muertes evitadas al año a partir de 2030. 2.750 casos de hospitalización al año por causas respiratorias y cardiovasculares evitadas a partir de 2030. Reducción de 892.000 episodios de asma al año en población infantil a partir de 2030. Esto representa para la salud pública beneficios económicos de hasta 12.900 millones de dólares entre 2021-2030 y 1.800 millones de dólares al año, equivalente al 0.64% del PIB a partir de 2030. Carbón H es una herramienta gratuita al servicio de los países y la OPS está comprometida en
Buenas tardes, boa tarde. Very good afternoon. If I can kindly ask you to take your seat so we can reconvene, confirm quorum and reconvene. I would ask the shy advisors sitting on the second row to sit on the first row. Les puedo pedir a los asesores tímidamente sentados en la segunda fila.
Could I ask those modestly seated on row 1 or row 2 to move on to row 1 so that we can have a quorum and then begin the session, please. Those of you sitting on row 2, if you could kindly move up to row 1.
A ver, somos 18.
Are we 18?
18 y contando.
18 and counting?
20.
20.
20. Necesitamos dos más.
We need 2 more.
El café de la tarde estaba muy agradable.
The afternoon, the coffee break in the afternoon was delicious from what I can tell.
No. Les puedo pedir a los delegados que por
Could I ask delegates to please take their seats so that we can find a quorum? We're still doing 20, maybe Chile just sat down, 21. And here we have Dominican Republic and Honduras as well. Perfect. Thank you very much.
Señora Presidenta, podemos iniciar.
Madam Chairperson, you can start. Good afternoon. So we reconvene with a notification, the document on agenda item 4.8. Keep the region of the Americas polio-free is available on the webpage of governing bodies and on the app. So we continue with the session in agenda item 2.1, second report of the Credentials Committee. And for that, I give the floor to the delegate of Guatemala, the Credentials Committee, to introduce the second report of the Committee on Credentials. Second report of the Committee on Credentials. In accordance with the Rule 32 of the Rules of Procedure of the Pan American Sanitary Conference, the Committee on Credentials held its second session on 27 September 2022 at 12:30 p.m. The committee examined the credentials delivered to the Director of the Pan American Sanitary Bureau in accordance with Rule 5 of the Rules of Procedure of the Conference. The credentials of the delegates of the member states and participating states, associate members, and observer states listed below were found to be in good order, and the committee therefore proposes that the conference recognize their validity. Participating in member states, Antigua and Barbuda, Argentina, Bahamas, Barbados, Belize, Bolivia, plurinational state of Bolivia, Brazil, Canada, Chile, Colombia, Costa Rica, Cuba, Dominica, Dominican Republic, Ecuador, El Salvador, France, Grenada, Guatemala, Guyana, Haiti, Honduras, Jamaica, Mexico, Netherlands, Nicaragua, Panama, Paraguay, Peru, St. Kitts and Nevis, St. Lucia, St. Vincent and the Grenadines, Suriname, Trinidad and Tobago, the United Kingdom, United States of America, Uruguay, Bolivarian Republic of Venezuela, Curacao, Puerto Rico, St. Martin, and Spain.
Gracias.
Thank you.
Gracias, delegado.
Thank you, distinguished delegate of Guatemala. Any objections? So we approve this report. Thank you. We go on to 2.3, second report of the working group to study the application of Article 6.b of the Constitution of the Pan American Health Organization. And for that, I give the floor to the delegate from Costa Rica, the chairperson of the working party, to submit the second report.
Dada la ausencia del delegado de Costa Rica,
Since the delegate of Costa Rica is absent for the time being, let us move on to the next item on the agenda, which is to reconvene with our discussion on agenda item 4.5 rather, policy on integrated care for improved health outcomes. I give the floor to Colombia, followed by Chile and Canada.
Muchísimas gracias.
Thank you very much, Madam Chairperson. It is a great pleasure to announce that in Colombia, we're aligned with what is stipulated in the policy on integrated care for improved health outcomes. Our efforts and normative efforts and the changes in the system that we've had in recent years follow the same line of improving integrated care. However, we continue to see fragmentation in the care that has impacted the efficiency on the provision of health services. And even though the user satisfaction has had an improvement in the perception scales, we still encounter difficulties that have to be addressed. Madam Chairperson, the pandemic once again showed that hospital-based and hospital-centered systems lead us to increasing cost, unnecessary medicines and commitments and compromises of human condition. On the contrary, going back to primary healthcare services and the strengthening of this one within integrated healthcare services improves universal access to a people-centered care and allows us to have healthy communities, thus showing that it is possible to articulate things amongst stakeholders in order to come to results in health that create value. The 4 strategic lines of action proposed cover significant components that ought to be deepened in order to translate them into concrete actions that will provide the expected results. This is an opportunity that we have as member countries and as an organization in order to reaffirm our commitment to comprehensive care and to strengthen those required actions that will enable us to attain the expected results. Now, in connection with strategic line 1, it is essential to understand and delve into different mechanisms to have coordination and intersectoral coordination to improve managing social determinants of health, believing that these are not only found in the hands of the health sector and that it needs a participation of different stakeholders because health services cannot respond to all the needs of the population on their own. On its part, when faced with a strategic line 3, we believe that it is important to establish clear actions in order to strengthen the capacity to resolve in the low complexity services and the systematic biopsychosocial care. Besides moving forward in proposals that will incentivize quaternary promotion, providing quality services from the providers of services all the way down to those who receive them. Within the strategic line 4, we believe that it is also necessary to give incentives to community participation and civil society in order to strengthen citizen capacity to participate in the cycle of public health policies. All of the above by promoting health culture and self-care by changing the risk factors, encouraging those factors that protect health, and incentivizing the provisions in the health sector and the results expected in the provision of healthcare services. Thank you. Thank you, Colombia. Chile, please.
Muchas gracias, señora.
Thank you very much, Madam Chairperson. Chile is a country that has an integrated model for family and community healthcare that establishes as essential principles integrated healthcare, continuous and people-centered, by including as a cross-cutting element the objectives of the decade from 2021 to 2030. We've moved forward with the implementation of strategies in order to transform the organization and management of health services in order to improve their internal coordination and the different levels of care by strengthening institutional coordination to reduce segmentation, always pointing to having a better experience by people in the system. This policy on integrated healthcare is aligned with the model of integrated network of healthcare services that was used in recent years in the work done by the ministry, including the design and redesign of the network in order to strengthen articulation and to protect the need for investment in the national healthcare service system, grouping systems in micro-regional networks, particularly to deliver better access, and in particular in high complexity services, and have coordination tools such as integrated councils of the network. Chile, just like the other countries in the region, offers important population and epidemiological changes with high prevalence of chronic conditions and multimorbidity. Therefore, since 2019, the strategy of integrated care is people-centered for the promotion, prevention, and managing chronic conditions in the context of multimorbidity, which comes to supplement the model of integrated healthcare service, which considers, amongst other changes, to establish managing teams at all levels to stratify the population based on risk. Third, to schedule depending on risk, thus facilitating clinical care. For integrated people-centered care, considering self-management and integrated agreed-on plan, and fifth, continuity of care with professional care at different levels. We're moving forward on training of management and clinical staff and the design of prevention strategies, participation, and health promotion based on community assets. It is obvious, Madam Chairperson, however, that we face huge challenges ahead of us. And just to mention two, to strengthen the approach of a territorial guide, moving forward with a decentralization to improve strategies with their social, cultural, and epidemiological relevance. And second, to continue with moving forward with the inclusion of an integrated health care approach, particularly the network on healthcare services with a managerial team to facilitate the coordination and articulation of the different levels of care. Therefore, Madam Chairperson, Chile supports the resolution and agrees with what is stipulated therein. Thank you. Thank you to the delegate of Chile. Canada has the floor.
Thank you, Madam Vice President. Canada recognizes the importance of overcoming fragmentation within the health system in order to improve people's experiences of care. In our post-pandemic recovery efforts, we must strive to improve coordination and integration of care so that they are better positioned to respond to people's differentiated health needs. As such, we welcome PAHO's strategic guidance in these efforts and support the policy and resolution as presented. We recognize that culturally responsive and inclusive integrated care is particularly impactful in certain population groups, including those living with complex health needs, those currently or at risk of experiencing poor health outcomes based on socioeconomic factors, and or those identifying with underrepresented populations. We appreciate that this policy focuses on the principle of person-centered care and promotes the empowerment and engagement of people and communities to improve their health. As we continue this work, we would like to underscore the importance of applying an equity lens in the advancement of these efforts, with a recognition of diverse racial, cultural, and gender considerations, among others. Thank you.
Gracias a la delegada de Canadá. Thank you to the delegate of Canada. And let me announce the upcoming speakers so that you will be ready. Bahamas, followed by Argentina and Cuba. Bahamas, please.
Thank you, Madam Vice President. This policy by PAHO WHO has been presented at a time when we as member states are all closely examining our performance during the most devastating COVID-19 pandemic. In many instances, the level, quality of our response was hindered because of the limited or lack of established practices of collaboration and cooperation throughout the entire health system. Traditionally, our fragmented systems of primary care, hospital care, vertical programs, etc., tend to protect the use of resources in despair and are not people-centered to ensure that the client receives both the appropriate level of care and a positive experience across the spectrum of services. Madam Vice President, the Bahamas is an archipelagic country where resources must be provided on multiple islands despite population size, landmass, or distance from the capital. The quest for equity requires that policies and practices must be developed to ensure that the needs of all must be met. The 4 strategic lines of action proposed by PAHO are pertinent, and the expectations for action by countries are feasible. Fundamental to the discussion is the need for a competent national health authority to guide and steer the national process in a regulated environment. I note the importance of a legislative agenda that will transcend political changes. It is my personal view that we can only achieve health for all as a relay race where the goal of winning is set, and each administration must build on the accomplishments of the other. The race can only be won if the course is set in an integrated and not a fragmented manner. Hence, the guidelines provided by PAHO set the blueprint to build equity, maximize the resources, and realize a result where a people-centered integrated health system provides the appropriate interventions and experiences. In the Bahamas, we are actively engaged on the path to build an integrated health system, and the local PAHO WHO office is a leading partner, guiding us in the process. We support this proposed resolution, CPS 30/10. Thank you, Madam Vice President.
Gracias a la delegada. Thank you to the delegate from Bahamas. I now give the floor to the delegate of Argentina, followed by Cuba and by Barbados. Thank you, Madam Chairperson. Argentina takes note of the report and welcomes the development of this policy on integrated care. The COVID-19 pandemic brought to the fore the weaknesses in health systems that were deepened by fragmentation and segmentation, but at the same time, the pandemic enabled to position health and the key governing role played by ministries and national health agencies for planning and the procurement of basic inputs and supplies, as well as strengthening of national capabilities and the promotion of interventions in order to move forward and ensure equitable access, concentrating on rights and building resilient societies and systems of rights. The new health challenges, in addition to what is demanded by population aging, the inclusion of new technologies with prospects, equity and access, and ensuring a package that is minimum and uniform, called for an integrated approach in articulation and coordination between subsectors and provinces in the case of federal systems such as Argentina, as well as sustainable funding mechanisms, with the purpose of shortening the gaps in access, promoting integration and articulation between health coverage and the funding schemes in a federal system. The government of Argentina announced the design of a strategy that will move forward with the integration of the health system that will include promotion, prevention, care, rehabilitation, and palliative care. In this regard, Argentina supports the policy on integrated care for improved health outcomes and the 4 strategic lines with a view to contributing to the attainment of the SDGs, and in particular SDG 3 and SDG 10. Thank you. Thank you to the delegate of Argentina. I now give the floor to Cuba, followed by Barbados, Belize, and Brazil. Madam Chairperson, access and universal coverage imply that all people and communities have rights without discrimination to adequate and timely integrated services, to quality medicines, effective, efficient, and accessible, ensuring that the access to services will not expose users to financial difficulties, in particular vulnerable groups. Once again, we talk about the need for strengthening health systems, particular primary health care, as a strategy in order to attain better levels of care and the adequate means in order to promote their right. Cuba, since 1959, begun the implementation of health policies and public policies as a strategic basis for the development of the national health system, placing the individual at the very core under the principles of being free, accessible, regionalized, integrated, without discrimination, with community participation and intersectoral participation based on primary health care, with the physician and the family nurse as the main strength and an international cooperation. Health is a right of all people, reaffirmed in our Constitution. It is a responsibility of the state to ensure access, free services, and the quality of healthcare services, as well as the protection and recovery. In order to translate into practice, we have an integrated network of services that link the use of technological advances, medical thought, the development of research, teaching, and application of biotechnological novel products. We agree with the lines of action, the strategic lines of action that I proposed in the document, and therefore we make available to the organization and its member states the experiences of our country. Thank you very much. Thank you very much, distinguished delegate of Cuba. I now give the floor to Barbados.
Madam Chairman, distinguished delegates, Barbados has to address a myriad of ongoing and evolving health challenges. As a resource-restricted small island developing state, we need to do so in a manner which is strategic with a view to improving efficiency and effectiveness of our health system. We further acknowledge that there are long-standing deficits in our system and aspects which are fragmented, and these were exacerbated during the COVID-19 pandemic. Barbados is therefore in full support of this policy on integrated care for improved health outcomes. We note this policy's alignment with the Sustainable Health Agenda of the Americas 2018 to 2030 and the PAHO Strategic Plan 2020 to 2025, key regional health plans that Barbados has fully endorsed. The policy also is aligned with the Barbados Strategic Plan for Health 2022, Some of key selective objectives include enhancing the primary health care approach as a strategy for providing universal access to essential health services, modernizing legal and regulatory frameworks, improving the quality of service offered and instilling continuous quality improvement strategies, increasing the reliance on information technology across the health sector, and implementing policies to improve the overall performance of Barbados's health system, built on the 6 building blocks of health system strengthening. Finally, we also are doing this through engaging and mobilizing strategic partners. This speaks to the intersectoral approach required for successful implementation of integrated care with improved health outcomes. Another critical facet of our approach is health financing. This is so critical that the government has made a concerted effort to revamp healthcare financing through the establishment of the post of Health Financing Commissioner in the Office of the Prime Minister and commissioning a study by the Health Economics team at the University of the West Indies. Chairman, in closing, I again reiterate Barbados's support for this policy on integrated care, as its successful implementation will lead to more efficient and effective health systems, better health outcomes, and healthier communities across the Americas. I thank you.
Gracias, delegado de Barbados.
Thank you, distinguished delegate of Barbados. The delegate for Belize has the floor.
Thank you, Madam Vice President. The COVID-19 pandemic has challenged our capacity to integrate all levels of care and services in response to the pandemic, while ensuring continuity of care for people who need other essential services. The pandemic has also tested the resilience of health systems in dealing with chronic diseases and emergencies. Hence, over the past 2 years, countries with highly fragmented health services have not fared well, despite greater access to technology and higher levels of health investment than in the past. Provision of essential services, especially services for people with chronic conditions, as well as screening of health persons for cancers and other chronic diseases, has been significantly reduced and in many cases completely interrupted for many months, putting patients at greater risk. The Belize Health Sector Strategic Plan 2014-2024 recognized that the major strategy is to develop an integrated health services delivery network. It is also repeated in Strategic Objective 1, integrated health services based on primary health care for improved health outcomes. One of the methods for achieving Strategic Objective 1 was defined as the implementation of the integrated health service delivery network approach. Introduction of assessment tools for achieving integrated health services delivery was completed in November and December 2021, where health management teams participated in a virtual training sessions on the integrated health service delivery network, thus building capacity at the regional level, integrating mobile clinics to remote areas, promoting inclusive health management with HIV, TB, and mental health services at all facilities, and strengthening the community health platforms across the country are but only some of the activities completed towards integrated health. Belize is the 24th country in the region to join the HEARTS initiative and is working on implementing HEARTS in all 6 districts before the end of the year. Belize has also implemented PrEP and HIV self-testing at health facilities in all districts with collaborative efforts of the Global Fund. COVID-19 has taught us cross-training of healthcare workers proved successful and has truly assisted Belize in responding to the pandemic. In addition to building capacity, there was greater understanding of the holistic approach to healthcare needs of our people. This integration has proved a deeper understanding of integrated health and allowed staff to assess many aspects of health in one health visit. This practice will continue outside of the pandemic. The Health Sector Support Program believes a collaboration of the Pan American Health Organization with the European Union and Ministry of Health and Wellness has been making great strides with the implementation of the Belize's Health Sector Strategic Plan with focus on strengthening of integrated health service delivery. We support this resolution. Thank you, Madam Vice President.
I thank you, distinguished delegate for Belize. And I now am pleased to give the floor to the delegate for Brazil. Madam Chair, thanks very much to the Secretariat for the clear, concerted effort to describe this policy. It's with great satisfaction that the Ministry of Health of Brazil and the whole ministry contributed to the development of this text in order to focus on health services in our country, which of course is something that all of the countries of the region focus on, aiming to render more equitable access to health services. We know that greater equity has to come through a number of ways: incentives, prevention of disease, and an overwhelming attention on the primary care that has to be felt through all of the levels by promoting and producing health products. We feel that an investment in primary care is probably the absolute keystone for building integrated, equitable, and people-centered services to be accessible, for sure. And this is what, from 2019, Brazil was thinking when it established a new financing system for primary care. We based ourselves on a model of financing that aimed at ensuring that more people could profit from primary care through a mechanism that would put responsibility of those teams regarding the user aimed at better results obtained by those teams. Finally, Brazil very much supports the approval of this new policy because we believe it goes to establishing a general strategy that will assist the member states in the implementation and better offer of integrated health care for their populations. I thank you. Thank you, distinguished delegate for Brazil. Let us now give the floor to various organizations that have official relations with the Pan American Health Organization and indeed with the World Health Organization. And first, we give the floor to the World Health Federation.
Honorable Chair, distinguished guests, my name is Deanna Vaca-McGee, and I'm representing the American Heart Association. It is an honor to address you today. On behalf of the World Heart Federation, the American Heart Association, the Inter-American Society of Cardiology, the Coalition for America's Health, the NCD Alliance, and the Task Force on Women and NCDs, we applaud the Pan American Health Organization for their commitment to build a strategic framework that transforms health systems and their capacity to achieve the Sustainable Development Goals. As organizations committed to addressing the burden of NCDs, we know reducing premature deaths requires delivering more and better quality care that is reflected on a country's national health plans and their budgets. COVID-19 made clear that those with chronic conditions are significantly more susceptible to severe illness and death. We cannot afford to relive the loss of life many in this room have faced because our health systems were ill-equipped. Multimorbidity has become the norm rather than the exception. We commend the call for integration at all levels, supported by strong surveillance systems that avail real-time information to track and monitor emerging public health threats. The most vulnerable among us, the person with a pre-existing condition, the poor, the healthcare workforce, specifically the disproportionate number of women on the front lines, will be most impacted if we do not prepare today for the threat of tomorrow. We call that member states do the following: ensure access to medicine specifically for vulnerable populations by analyzing the roadblocks and addressing them, collaborating across key ministries, including finance and education and others, accelerate the adoption of evidence-based policies and programs such as the HEARTS initiatives and the PIN Plus strategy that seeks to address severe diseases such as sickle cell and rheumatic heart disease through an integrated outpatient model at first levels of care. systematically screen and treat pregnant women to better identify who may be at increased risk of type 2 diabetes and cardiovascular disease, support the expansion of healthcare teams so that pharmacists, nurses, and other allied health professions can provide the important patient care that we deserve. Universal health coverage will only be realized when a health system can detect and treat leading risk factors associated with non-communicable diseases, when it continues to provide important maternal and child health, and when country leadership adopts evidence-based public health measures that create healthier communities. Our time is now. Thank you.
Muchas gracias por su intervención.
I thank you for your statement. The Latin American Association for Responsible Self-Care has the floor. A good afternoon to you, Ms. Vice Chair. The Latin American Association for Self-Care is very pleased with this declaration put forward by the 30th Pan American Health Conference. We particularly call attention to 4.5 of our agenda, in which it is stated that an integrated focus on care is necessary to improve services in our region. And we welcome the emphasis placed on individuals and the implementation of concrete policies oriented towards self-care and active participation in responsible decisions regarding each person's own health. That, in connection with a long-term view, patient-centered, as a keystone of sustainable healthcare. The International Association for Self-Care, together with the World Health Organization, has been looking at this and has considered that the present cost of self-care in Latin America can aim to $7.2 million for the public health systems and $79 million for welfare of individuals. If the entire potential of self-care were liberated in this manner in the region, it could be 45% higher between now and 2030. Now, admittedly, in order to reach such levels, the index would need 4 key facilitators. First of all, self-care as a central policy of the region. Secondly, concrete policies in order to foster greater self-care and a multidisciplinary approach by medical providers. Third, an individual assumption of power through digital and other means. Fourthly, an enabling environment to allow systems that would be of low risk and regulatory sense that would allow individuals to further practice self-care and thereby lighten the financial load on national health systems. We agree with this point in the agenda, and we are at your service to provide more information as needed. Thank you very much. We now give the floor to the representative of the Latin American Association for Nephrology and Hypertension. A very good afternoon, and thank you, Madam Vice Chair. And esteemed directing table, ministers of health, on behalf of the Latin American Association for Nephrology and Hypertension, all our best to you. IFLAN is the coordinating center for nephrology and renal health in the region. Chronic kidney disease in the region is a chronic disease that very much hobbles Latin America, where the number of persons needing dialysis is greater every day. It goes from diabetes, the metabolic syndrome, and a number of other issues, but also the Mesoamerican set of diseases that afflict autochthonous peoples in this region. This, of course, is translated into our morbidity, the poor quality of life that many have, and the fact that this chronic disease has turned into a serious public health issue, which needs to be looked at from early detection, prevention, in early intervention, and especially appropriate treatment and follow-up. ASLAN is raising its voice in order to create a common front together with PAHO and the public to put these mechanisms at everyone's hand and to offer a strategy for integrated kidney health in every country. We have all kinds of experts in kidney, in public systems, that are willing to jump in and adapt to every possible context with the help of PAHO and the help of local nephrologists. This, we believe, would take us a very long way to timely detection and proper treatment, such as telemedicine, telenephrology, inspired in the Chilean program that Carlos Zúñiga, our esteemed colleague, knows is very effective. This also goes to registration and eventual transplants where needed. And this is the kind of registry for nephrology and including transplant in every country. And that's the sort of thing that we could simply repeat in a slightly different context, which is the broader sense of kidney health. The lack of kidney health is killing our young people. And the greatest adversary we have, you need to believe this, is chronic kidney disease. We need to put every effort and all the money we can into this effort. Let us go forward for kidney health. Thank you. Thank you very much. And thank you also for recognizing the Chilean experience in this regard. The World Federation of Anesthesiologists has the floor.
Distinct delegates, I'm talking on behalf of the World Federation of Society of Anesthesiologists, which represents over 300,000 anesthesiologists in 142 countries, with 24 national member societies in the PAHO region. Anesthesiologists perform multiple vital roles in the health systems. Their expertise in resuscitation, ventilation, perioperative and post-operative care, critical care, pain management, and much more means they have the potential to influence multiple steps in the patient pathway. As one of the few specialists working at multiple points throughout the patient journey, anesthesiologists are uniquely well positioned to provide leadership in developing equitable and integrated health systems. As was evidenced in multiple countries during the pandemic, a healthy and equipped anesthesia workforce was vital for the effective coordination and integration of stretched health service as they respond to the impact of COVID. Unfortunately, many countries with the Americans face a chronic lack of trained anesthesiologists. The WFSA's Global Anesthesia Workforce Survey found that 10 PAHO member states had a physician anesthesia provider density far below the recommended interim target of 5 per 100,000 population, as outlined in the WHO WFSA International Standards for a Safe Practice of Anesthesia. For PAHO member states to achieve a patient-focused continuity of care as outlined in the Sustainable Health Agenda for America's 2018-2030, there is an urgent need to develop, implement, and integrate a national policy and financial frameworks that will sustainable grow and support vital anesthesia service. The WFSA calls on PAHO region member states and key stakeholders to, first, engage with anesthesiologists in the development of integrated primary health care programs and initiatives. Second, address chronic workforce deficiencies through investment in anesthesia and critical care training and ongoing education. And third, embed national surgical, obstetric, and anesthesia plans into integrated national health plans and strategies. Thank you for your attention. Thank you, Madam Vice President.
Muchas gracias por su intervención.
Thank you very much for your statement, sir. And finally, the representative of the International Federation of Medical Students Association. You have the floor.
Good afternoon. My name is Kelvin Gutierrez, representing the International Federation of Medical Students Associations. Honorable Chairperson, distinguished delegates. The International Federation of Medical Students Associations strongly supports the approval of this policy and commends the Pan American Health Organization continuous efforts towards the implementation of integrated healthcare systems. An important step to overcome the challenges of its current fragmentation that affects the quality, equity, efficiency, and effectiveness of healthcare delivery, especially after the COVID-19 pandemic. We, the IFMSA, call on all member states to guarantee the multidisciplinary action sustained on primary healthcare, as it is the most inclusive, equitable, cost-effective, and efficient approach to enhancing people's physical and mental health. Furthermore, We stress the importance of improving innovation and including marginalized and vulnerable populations in community engagement, as well as medical students in policy and program designs, implementation, monitoring, and evaluation for primary health care. Thank you.
Muchas gracias por su intervención.
Thank you very much for your statement. I now give the floor to Dr. Fitzgerald for his answer to these various comments.
Thank you very much, Madam President. Thank you to all the member states and the organizations in official relations for your comments and support in this document. I think what we're hearing from member states is really comments in two broad major areas. First really relates to what we saw during the COVID-19 pandemic, the exacerbation of the impact of COVID-19 on essential health services. As of December last year, 53% of countries were still reporting severe disruptions across health services in the Americas. This as a result of the pulse surveys that we've been carrying out. We will in fact be carrying out a fourth pulse survey, and we really urge all member states to continue to support the implementation of these surveys, as they are really important for us in providing the necessary technical support and ensuring the continuity and the integration of services moving forward. The overall outcomes that we've seen during COVID-19 in terms of the impact on essential health services is a condition of the deficiencies of health systems prior to the pandemic. This has become extremely clear in the analysis that we have completed. And fragmentation, segmentation is core to that. Fragmentation in care in terms of the continuum of care, and fragmentation in terms of services across subsystems, providers, and the differentiated conditions of access that persist across that. That has been mentioned by a number of member states. And I think what we really heard from member states also, such as Honduras, Bolivia, and Colombia, is the need for substantive health systems transformation to address this degree of segmentation and fragmentation in health services. And this really speaks to the principle and core strategic area of work proposed by this policy to really support substantive health sector transformation that addresses at its core barriers to access, barriers to continuity care, and sustained fragmentation in terms of delivery of care. Central to this process is governance, leadership. We heard this from Bahamas and Barbados. And the principles of primary health care, as we heard from Jamaica, Cuba, and Brazil. And primary health care continues to be the central and core strategy that the organization is supporting countries, and countries are applying to respond to the needs of people, their families, and the communities where they live, particularly now as we see increased more excess mortality and morbidity and the continuing growth and burden of disease related to chronic conditions. All these factors really can improve access, equity, and overall health outcomes. And this is, as was mentioned by the United States and Canada, this is our principal overarching objective in terms of health sector transformation. Not transformation for the sake of transformation, but really having an overall lens of improving the health of the population, breaking down barriers, improving equity, and improving health outcomes. The second group of comments, I think, really spoke to the meso policy areas that countries are working in. First of these, and extremely important to really induce the necessary integration of the health system around health financing. We have seen important improvements in health financing, public health and financing, over the past 20 years. We have, through our national accounts, looked at this and seen that the public financing in health has increased from 2.8% to 3.9% over a period of 10 years. This is far from the 6% that member states adopted in 2014 when they adopted the resolution, but it does constitute an increase of overall of 40% from where we were some 15 years ago. Associated with this, as was mentioned by Jamaica, is the issue of out-of-pocket expenditures. We cannot eliminate barriers to access health. We cannot eliminate that degree of fragmentation in healthcare delivery unless we increase public financing and essentially substitute out-of-pocket expenditures, which are the most regressive form of financing within the health system. And this was clearly stated by Bolivia and Barbados and Jamaica. Health workers, yes, critical. I think we had an excellent side event yesterday, really went into detail on this. And through our initiatives and implementation of the strategy and plan of action for human resources for universal health, and now through the initiative of the American Health Corps, this will become a critical area of work to address those barriers and improve degrees of fragmentation within the health system. And finally, health services. This really is a central pillar of addressing fragmentation. A strong first level of care, but fully embedded in a highly organized, integrated healthcare network, including secondary and tertiary care with the necessary interprofessional teams, the necessary health technologies, the digital transformation required, and of course, the necessary financing that is required to support that. The countries, I think you as member states have made major advances in terms of health services organization and the organization of integrated health networks over the past 15 years, as we witness the UHC services index increasing quite substantially from 60 to 77, the goal for the SDGs being 80 over the past 10 years. It's really noteworthy that 22 of 35 countries reporting over the period of the last 10 years have increased the UHC index in the order of 20 points. Finally, the issue of governance, coming back to the governance, requires intersectoral and social participation. And I really want to thank Canada, Barbados, and Colombia for highlighting this. This is one of the strategic areas of work that we need to do more on. And as we really improve the integration of our services and our health systems as a whole, we really will need to drill down and develop strategies to improve the degree of social participation in these processes. Thank you very much, Madam President.
Muchas gracias, Dr. Fitzgerald.
Thank you very much, Dr. Fitzgerald. I wonder whether the director has any comments.
Senora Vice President.
Thank you very much, Madam Vice Chair.
All of the member states for their interventions on this agenda item. I recognize, and I know that you too recognize that you have embraced the policy and principles beyond underlying universal health and the need for the reforms to ensure that we get there. What is clear is that the COVID-19 pandemic exposed the fractures in our health systems. And we know that segmentation and fragmentation in all its forms is an important barrier to universal health where no one is left behind. I think now is an appropriate time that countries review the gap between policies that you have taken decisions on in this forum, and what your actual implementation at your country level is. And I think the health systems transformation must be all embracing. I know that we've presented it to you every year, every 2 years with a different aspect of health systems transformation. You have the responsibility now of pulling all of this together to ensure that you truly have transformation of your health system that embraces integrated care, comprehensive care, where it's not just curative, but it's also promotion, prevention, that you have some attention on quality of care, financing and the resourcing, including human resources, governance in health, integrated health services, network delivery, that the social determinants are included in that vista, and the whole question of multi-sectoriality and intersectorality. Of course, this is not an easy easy undertaking, but it will require some really very focused attention and on health systems in general, and what are all of those policies that we have and how to bring it to play on the transformation of your health system so you can better certainly deliver essential care for your people with equity, with quality, but at the same time that your health systems are strengthened for national development, strengthened for disease protection, strengthened for future pandemics. But it is this comprehensive approach that is going to help you. Because one time I hear you're talking, you want to deal with quality, the other one wants to deal with social determinants. It does not work like that. We have to pull all of those together and have a comprehensive look at your health system and how we move to transform it into a health system that is resilient and responsive. And if I were you, if I was a member state, I would task the Secretariat to pull together a blueprint that begins to put all of these things together, so it makes it easier for you with some sort of a toolkit to get you to where that needs to be. Thank you very much.
Thank you very much, Madam Director. Well, let me now turn to the rapporteur to turn to the proposed resolution. Yes, Madam Chair.
Proposed resolution policy on integrated care for improved health outcomes. The 30th Pan American Sanitary Conference, PP1. Having reviewed the policy on integrated care for improved health outcomes, document CSP 30/10. PP2, recognizing that inequities in health persist and have been exacerbated by the COVID-19 pandemic, and that reducing inequities has become increasingly challenging in light of a major demographic and epidemiological changes experienced in the region of the Americas, where non-communicable diseases, notably cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases, and mental health conditions now account for the greatest burden of disease. PP3. Considering that fragmentation in all its forms is a pervasive problem in health systems and affects the organization, management, and provision of care in almost all member states of the Pan American Health Organization, TAHO, and that fragmentation of care greatly affects equitable access, health outcomes, and people's experiences of care and satisfaction with health systems. PP4, affirming that in response to these challenges, the region urgently needs to radically change current approaches to the delivery of care by designing and implementing strategies for integrated care that are clearly linked to building resiliency in health systems and achieving universal health. Resolves. OP1, to approve the policy on integrated care for improved health outcomes. Document CSP 30/10. OP2, to urge all member states, considering their context, needs, vulnerabilities, and priorities, to A, promote implementation of the policy options set forth in the policy on integrated care for improved health outcomes. Little B, strengthen the capacity of national health authorities to lead and manage system-wide transformations for integrated care, with priority to intersectoral collaboration and partnerships to foster change, implementation of regulatory frameworks, and development of competencies for managing change and leadership, training new leaders, creating and guiding coalitions, building capacity to collaborate, providing support for change, and designing change management plans, among others. Little C, improve and strengthen the organization and management of service provision to advance toward integrated health services delivery networks, establishing the policies and legal frameworks designed for governance, network configurations, provider and care integration mechanisms and protocols, appropriate resource allocation and incentives, and research monitoring and evaluation. Little d, strengthen capacities at the first level of care to provide people-centered, inclusive, and responsive care across the life course, taking into consideration cultural and gender issues and improving the management of care for people with complex health needs. Little e, establish integrated care throughout the health services continuum through the implementation of policies aimed at empowering people for self-care and active participation in making decisions about their own health, with a due attention to gender and ethnic considerations, as well as policies to promote the clinical integration and multidisciplinary collaboration among healthcare providers, including the implementation of clinical guidelines that address the care of individuals with multiple chronic conditions. Little f, build capacities and enabling environments with an intercultural approach to empower and engage people and communities to improve their health through modalities such as health education programs, counseling to promote health-related behaviors, support for informed decision-making about care and treatment options, and promotion of self-management. Little g, implement the mechanisms for comprehensive monitoring, evaluation, and documentation of a policy implementation and foster constant analysis and evaluation of organizational actions and practices for continuous improvement and adoption of lessons learned. OP3, to request the director to little a, provide technical cooperation to member states to strengthen capacities that contribute to the implementation of the policy on integrated care or improved health outcomes and the achievement of its objectives within the framework of integrated health services, delivery networks, and the strategy for universal access to health and universal health coverage. Little b, report periodically to the governing bodies of PAHO on the progress made and challenges faced in the implementation of the policy through progress reports every 5 years. That is all in connection with this proposed resolution. Thank you very much, Madam Vice President. Thank you very much, Madam Rapporteur. Floor is open for comments in order to get the debate going.
Muy bien.
Very well. Having no request for the floor, this resolution is adopted.
Pasemos a considerar el siguiente.
Let us move on to the next item, 2.3. Second report of the working group of the Working Party to study the application of Article 6.b of the PAHO Constitution.
La Organización Panamericana de la Salud.
The Pan American Health Organization. I give the floor to the delegate from Costa Rica, chairperson of the Working Party, to submit the second report.
Gracias, señora vicepresidenta.
Thank you, Madam Vice President. Please allow me to be seated here. This is a report of the Working Party to study the application of Article 6b of the Constitution of the Pan American Health Organization. 1. The Working Party appointed to study the application of Article 6.b of the Constitution of the Pan American Health Organization, PAHO, met on 26 and 27 September 2022 to review the status of assessed contributions in light of the provisions of Article 6.b of the Constitution of PAHO concerning the suspension of voting privileges of any member in quotes, in arrears in an amount exceeding the sum of its annual payments of contributions for 2 full years, end of quote, by the date of the opening of the Pan American Sanitary Conference or a meeting of the Directing Council. 2, the Working Party has been entrusted with recommending whether or not to reinstate the voting privilege of such countries in accordance with the following terms of Article 6B. In quotes, if the conference or the Directing Council is satisfied that the failure of the government to pay is due to conditions beyond its control, it may permit the government to vote, end of quote. The members of the Working Party are the delegates of Costa Rica, Paraguay, and St. Martin. The chair of the Working Party is a delegate of Costa Rica. Analysis. As the opening of the 30th Pan American Sanitary Conference, one member state, the Bolivarian Republic of Venezuela, was in the situation foreseen in Article 6.b, with outstanding assessed contributions due for 2017, 2018, 2019, 2020, 2021, and 2022, amounting to a total arrearage of US dollars 12,124,147. The Pan American Sanitary Bureau, PASB, sent a formal communication to the government of Venezuela regarding its situation with respect to Article 6B in May 2022, as well as follow-up bi-monthly electronic communications during 2022 without receiving a response. In 2020, Venezuela had its voting rights suspended at the opening of the 58th Directing Council in accordance with Article 6B of the Constitution. At the beginning of that session, Venezuela had outstanding assessed contributions due for 2017, 2018, 2019, and 2020, amounting to a total of $7,854,219. Consequently, pursuant to application of the provisions of Article 6.b and Resolution CD 58.R8 2020 and CD 59.R7 2021, Venezuela's voting rights remain suspended as of the opening of the 30th Pan American Sanitary Conference. Venezuela has not made any payments towards its assessed contributions since May 2017, nor presented any correspondence in writing to the office, including a proposed deferred payment plan regarding payment of outstanding assessed contributions due since the 58th Directing Council in September 2020. The Working Party has reviewed the recommendations of the 170th session of the Executive Committee reflected in Resolution CE 170.R1, as well as the Statement of Assessed Contributions Due. The Working Party has analyzed and discussed the delay in the payments from Venezuela. It has emphasized the importance of timely receipt of the assessed contributions for fulfillment of the program budget approved by the member states, and has fully recognized that failure to receive the budgeted amounts at the time they are expected threatens the implementation of all planned activities and even the continuity of the organization, making it necessary to impose extraordinary measures for the management of financial resources. It has also affirmed that it is not advisable to make exceptions to the application of Article 6.b that may be cited by other member states when they fail to meet their financial commitments. Recommendation by the working group. The members expressed a regret, but in light of the lack of payment or communication with the Secretariat, the Working Party recommends that the conference not reinstate the voting privilege of Venezuela and that the situation be reviewed again by member states at future sessions of governing bodies. The Working Party congratulates those member states that have made the effort to meet their quota commitments to the organization during 2022 in the midst of challenges imposed by the COVID-19 pandemic and the resulting economic situation, and it urges those member states with pending contributions to meet their financial commitments without delay. That is all, Madam Vice President. Thank you. Thank you very much for this report, the chairperson of the Working Party. Any objection? I give the floor to Venezuela.
Buenas tardes, Vicepresidente.
Good afternoon, Madam Vice President. The delegation of the Bolivarian Republic of Venezuela that today attends this meeting brings it to this important forum that brings us together, that our republic historically has built a high level of international confidence in abiding by the responsibility that we've taken on as a country. We don't know of the moral solvency in being able to speak about this issue of payments that are due to the organization. In this regard, we must clearly state that if the Bolivarian Republic of Venezuela has not met its financial obligations before the organization, has only been motivated due to the impediment created by the genocide persecution against our homeland that has been undertaken by the U.S. capitalism. Coercive unilateral measures that have happened and that have been seen by the whole world. But we must say that they've taken place under the accomplice view of most of the countries in the world, including international organizations that essentially should safeguard the international law with a great sense of justice and egalitarian attitude. Silence is only broken to speak about the debts and the commitments that our country has not been able to honor. This claim by international organizations further strengthens the confessed and manifest of the political asphyxia that we've been subjected to. We would have to install international mechanisms that would review the reasons for these arrears and non-payments that we're accused of today. Maybe we would discover that these are caused by these attitudes of domination. Our country does not want to speak of a debt that today seems to be the main concern of this meeting, and that we are not considering that we've had over $150 billion in US dollars in losses of our GDP of a hybrid full and complete war. Over 31 tons of Venezuelan gold reserves deposited in the Bank of England remain sequestered without any consideration. But we must also denounce that the illegal blockade of over 10 million US dollars deposited in international banks, the theft and Venezuelan companies, as is the case of the Citgo Petroleum Corporation, plundering of these assets. It would take us months and months to break down all the sanctions and all the long list of international crimes of which our nation is today a victim, only because of the fact that we have an awareness of our people. All these atrocious events should lead to scandalous reaction by this assembly that have harmed the people, even the international law that today should be used as a guarantee for order on this planet. Our nation is aware of its debt and its commitment to settle the debt, but it demands before this honorable assembly to review all the contexts and circumstances that prevent us from paying that debt. Also, with a voice, we should call to the end of financial neo-colonizing manipulation. Our nation has an economic debt with this organization, and we're willing to honor that debt. What is obvious is that PAHO and WHO have been with us in the territory in these times of an economic war by enforcing health policies that do not interrupt the blockade, with humanism, honesty, humbleness, and honesty for the people of Venezuela and all those who go through it. Thank you very much, Madam Vice President. Thank you very much, Delegate of Venezuela. I now give the floor to the U.S. delegate.
Thank you, Madam Vice President. We regret that another member state has decided to use a multilateral forum to raise bilateral issues. The United States wishes to exercise its right of reply to reject Venezuela's statement here on this item and on the previous item, agenda item 4.4. We remain steadfast in our commitment to the Venezuelan people, which includes supporting their democratic aspirations and providing assistance to address Venezuela's humanitarian crisis. The U.S. Venezuela-related sanctions program includes broad exemptions and authorizations that allow for the provision of humanitarian assistance and the commercial sale and export of food, agricultural commodities, medicine, and medical devices to Venezuela. Our sanctions are generally designed to not be an obstacle to providing bona fide humanitarian aid to Venezuela. We have also made it clear to the Maduro regime that if there were specific instances where excessive compliance with U.S. sanctions prevented the provision of humanitarian aid to Venezuela, they should let us know so we can take steps to facilitate the aid to flow freely as appropriate. We have yet to receive a single referral. For our part, the United States, international partners, and the interim government in Venezuela are proactively responding to COVID-19 in Venezuela. Since FY 2017, the U.S. government has provided more than $2.3 billion in humanitarian, health, economic, and development assistance to help vulnerable Venezuelans inside Venezuela, those who fled, and the communities in 17 countries throughout the region that host Venezuelan migrants and refugees. We know that humanitarian assistance is necessary but not sufficient. It is only aimed at satisfying acute and immediate life-saving needs. Only the full restoration of democracy in Venezuela can help address the long-term needs of the Venezuelan people. Thank you, Madam Vice President.
Gracias.
Thank you. The UK has the floor.
Thank you very much, Vice President. I would just like to echo what the US just said on regrets that a multilateral forum has been used on a bilateral issue, and would want to reserve the right to reply further in the coming days, please. Thank you very much.
Muchas gracias al representante.
Thank you very much to the UK representative. Seeing no additional requests for the floor, the discussions and the arguments will be reflected in the final report. And seeing no, I'm sorry, Cuba has the floor.
Señora
Madam Vice President, distinguished delegates, Cuba wishes to state that the non-payment of Venezuela is due to conditions outside of the control of the government, and that in fact they respond to the unfair and unjust measures that have already been mentioned. We understand the very difficult and complex position faced by Venezuela in order to take on these payments. And we're also acquainted with a firm position of being able to settle these payments as soon as possible, provided that the situation changes. We wish to ratify our solidarity with the position of the legitimate Venezuelan government. Thank you.
Muchas gracias por su
Thank you very much for that statement, Delegate of Cuba. As I was saying previously, and I apologize that I have not seen you, the discussions will be reflected in the final report. There's been no objection to the report, and therefore it stands adopted and approved. Thank you.
Vamos al siguiente punto.
We move on to the next item on the agenda, the report on agenda item 5.1, report on the collection of assessed contributions. I bring to the attention of the conference a document CSP 30/13 at 1, and I invite Mr. Esteban Alzamora, Interim Director of Financial Resource Management of the Pan American Sanitary Bureau, to come up to the head table.
Le concedo la palabra a la representante.
Give the floor to the representative of the Executive Committee to report on this agenda item. The representative.
Thank you, Madam Vice President. Item 5.1, report on the collection of assessed contributions. The Executive Committee was informed that as of June of this year, one member state was in arrears to extend that it was subject to the provision of Article 6B of the PAHO Constitution. As of June 12 member states, participating states and associate members had paid their 2022 contributions in full. 8 had made partial payments and 22 had yet to make any payments at all of 2022. As of 20 June 2022, of $74.6 million of the $180.1 million due on January 1st, 2022 had been collected. In the executive committee's discussions, member states, participating states, and associate members were encouraged to make every effort to pay their full assessed contributions on a timely basis to ensure that the organization can deliver vital technical assistance and carry out its program of work. The executive committee adopted the resolution CE 170.R1, thanking those member states that had made payment in 2022 and urging other member states to pay their outstanding contribution as soon as possible. Thank you, Madam President. This concludes my report on this item.
Muchas gracias.
Thank you very much. I invite Mr. Alzamora to present an update on this report.
Madam Vice President, Madam Director, and distinguished delegates of the 30th Pan American Sanitary Conference. The assessments from the member states constitute a significant component of the resources supporting the organization's biennial program and budget. Prompt payment of both the accumulated arrears and the current 2022 assessments is imperative for the organization to effectively implement the full program of work. There we go. Oops, too many. Total assessed contributions due as of 31 December 2021 was $74.8 million, representing a slight improvement as compared with $84.6 million in 2020. However, in 2011, just 10 years ago, the outstanding balance of assessed contributions at year end was only $24 million, reflecting a serious deterioration in the rate of receipt of assessed contributions. Total assessed contributions due on 1 January 2022 was $180.1 million, of which $98 million was received as of today. The balance of assessed contributions due is $82 million. 16 member states have paid their assessed contributions in full. 7 member states have made partial payments. However, 19 member states have not made any payments towards their 2022 assessed contributions, and 15 member states have not made any payments for their assessed contributions thus far in 2022. The organization has only received 42% of the 2022 assessments. As of 31 August 2022, the organization utilized $21.5 million from the $50 million available cash balance of the working capital fund in order to meet the commitments of the assessed contribution budget. If the organization does not receive the balance of assessed contributions in a timely manner, the full implementation of our biennial program of work as approved by the member states could be in jeopardy. The assessed contributions budget represents important flexible funds that are critical to ensure continuity of the operations for the organization and responsiveness to the member states' priorities programs that rely on flexible funds. Thank you.
Muchas gracias.
Thank you very much. Thank you, Mr. Zamora, for this update. And I now open the floor to the plenary for discussion.
Le doy la palabra a la
I give the floor to Argentina. Thank you, Madam Vice President. Argentina has a strong commitment with PAHO, and therefore, in spite of the economic conditions, difficult economic conditions that we're going through in our countries, worsened by the pandemic, is deploying huge efforts in order to settle the outstanding arrears. We are aware that contributions missing has an impact on the work of the organization, and therefore, even in the context of an economic recovery and new health and economic emergencies in the country, we reaffirm our commitment with the organization, and we hope to continue complying with our payments to live up to our obligations. Thank you.
Muchas gracias.
Thank you very much, Delegate of Argentina.
Señora Zamora, ¿quiere?
Mr. Alzamora, do you have any comments?
El delegado de Honduras tiene la palabra.
Honduras is recognized. Thank you very much. Honduras agrees with the current report on the collection of assessed contributions because it clearly shows the status of the same and the importance to be attached to the fact that member states, participating states, and associate members settle their assessed contributions at the beginning of each year in order to ensure the financial stability of the organization. Emphasizing what is stipulated in the report, that the assessed contributions by members contribute to an essential part of the resources supporting the budget, the program budget of the Pan American Health Organization, 2022-2023. And the delay in the payment of outstanding accrued contributions from previous years, as well as the current assessed contributions for 2022, has had a profound impact on the ability of the organization to fully execute its approved work program. Because of all of the above, it is important to thank member states, participating states, and associate members since they have settled their payments in 2022, and to urge them to continue living up to their commitments in time and form. To ask the Bureau to continue following up on the status of the condition of assessed contribution, measuring the impact that this has when having a delay in the payment of these contributions on the financial health of the organization, and report to the Executive Committee on compliance by member states of their financial commitments towards the organization. To say that Honduras honored its commitment to pay its contributions on a timely basis. Therefore, we call on the distinguished Pan American Sanitary Conference to consider approving the corresponding resolution. Thank you, Madam Vice President.
Muchas gracias, señora delegada.
Thank you very much, distinguished delegate of Honduras. Madam Director, do you have any comment?
Thank you, Madam Vice President. Clearly, we are not in an enviable position where the member states of this organization recognize the value that this organization and the Secretariat is for their own national health development, where for many of those countries, assessed contributions pale in comparison to the country budgets and the technical cooperation that is given to each of your countries. May I say that cars don't run on water, neither on fumes. They require gas. Your assessed contributions are an important component of flexible funding. And flexible funding is essential for the organization to be able to deliver on the priorities that you've set for us, and particularly on some of the more essential programs for which we are unable to mobilize resources. Let me remind you that this is my 10th year, and for all of this period, we've never requested an increase in quota contributions for you. This might have been a bad decision because if you realize that costs increase over time. And so in real terms, your contribution to the organization has dropped significantly. And in addition, not meeting your what are your responsibilities will continue to affect this organization. So with those few words, I wish to appeal to you that as we go forward, that you make it a priority to support this organization through paying of your quota contributions. And we do recognize that the pandemic has caused significant economic hardships for many of our countries, but this is a situation that has gone on long before the pandemic. And I do believe that if you are resolute, if you truly believe that this organization must contribute to both national, regional, and global development, that will be a priority for you. So let me thank you in advance of your making of those payments for your assessed contributions. Thank you very much.
Muchas gracias, señora directora.
Thank you very much, Madam Director. I would like to invite the rapporteur to present the draft resolution. Resolution, collection of assessed contributions. The first preambular paragraph, having reviewed the contribution of assessed contributions, document CE 17013 and addendum 1, and the concern expressed by the Executive Committee at the 170th meeting with regard to the state of the report on the collection of assessed contributions. Paragraph 2, observing that the Bolivarian Republic of Venezuela is in arrears on their outstanding contributions with regard to 6.B of Constitutions of the Pan American Health Organization. 3, noting that as of the 20th of June, 2022, 22 member states have not made any payments toward their 2022 assessments, corresponding again to 2022. Fourth preambular paragraph, noting that by 26th of September 2022, only 42% of the contributions that have been earmarked for this year have been received, and $34.8 million have been of the working capital fund have been utilized, jeopardizing the full implementation of the biannual program of work for 22-23 to be as approved by the member states. Resolves. Operation paragraph 1, to take note of the report on the collection of assessed contributions, documents CSP 30/13 and addendum 1. Operational paragraph 2, to express appreciation to those member states, participating states, and associate members that have already made payments in 2022. Operational paragraph 3, to strongly urge all members with outstanding balances to meet their financial obligations to the organization in an expeditious manner in order to efficiently implement the program budget for 2022-2023. Operational paragraph 4, to request the president of the Pan American Sanitary Conference to notify the delegation of the Bolivarian Republic of Venezuela that its voting rights continue to be suspended as of this 30th Pan American Sanitary Conference. Operational paragraph 5, to request the director to A, continue to monitor the status of assessed contributions and the impact of delays on the financial health of the organization. Paragraph B, advise the executive committee of members' compliance with their financial commitments to the organization. C, report to the 60th Directing Council on the status of collection of assessed contributions for 2023 and prior years. That is the draft resolution we have for you at this time. Thank you very much, Madam Rapporteur. Let me offer the floor to the plenary for the debate on the matter at hand.
Dado que no se ha solicitado el uso de la palabra,
I see that no one is requesting the floor. The resolution is hereby considered adopted. Thank you.
le doy la palabra a la secretaria, señora secretaria.
Madam Secretary, you have the floor.
Thank you, Madam Vice President. Just one announcement, please. As today's session comes to a close, we would like to remind delegates that item 3.3 on the election of the new director of the Bureau will be brought to the conference early tomorrow, Wednesday, the 28th of September. We kindly ask that all member states please ensure your early arrival. The session tomorrow will begin promptly at 9 a.m. Thank you, Madam Vice President.
Many thanks, Madam Secretary. We beg you to be not only punctual, but to be here early in order to participate in this important election of the new director of PAHO. And we will begin with 6.1. We'll follow with 3.4, 3.3. Following that, there will be the coffee break. And after that, we shall pick up on such texts as we are able to tackle and end the meeting with 4.6 for the morning session. I thank the Secretary, the Rapporteur, and Madam Director, and everyone else. If you agree, this means that our meeting this afternoon stands adjourned. Thank you.